As the landscape of poisons, designer substances, and forensic challenges evolves rapidly, our responsibility as forensic clinicians and toxicology experts become more critical than ever. As a prelude to today's CME, we successfully conducted 2 days of e-poster scientific sessions featuring contributions from the faculties, senior residents, junior residents, and forensic science graduates as well, showcasing remarkable research, case-based learning, and innovative approaches that enrich the academic discourse. Today's platform continues that momentum, encouraging all of us to learn, collaborate, and transform ideas into real world outcomes that strengthen healthcare and justice delivery. It is my privilege to work in a very young, enthusiastic team with organizing chairman, Dr. Sindhil Kumaran, associate professor, in charge head of the department, organizing secretary, Dr. Gerard Pradeep Devnath, assistant professor, and treasurer, Dr. Aravindan, senior resident in the Department of Forensic Medicine and Toxicology. On behalf of the organizing committee, I, Dr. Mukesh, Joint Organizing Secretary, hereby welcome you all to a day filled with insightful discussions and impactful exchanges. I request Dr. Gerard Pradeep Devnath to take over from here for the meaningful session. Thank you. Okay, just take pause. Just a minute, sharing.
அது நீங்க கண்ட்ரோல் பண்ணலாம் சார், கேன்சல் பண்ணிட்டு போஸ்ட் வந்து கண்ட்ரோல் பண்ணலாம், ஷேரிங்கை கேன்சல் பண்ணிக்கலாம்.
Sir, can you cut your screen for just a minute, sir, for your screen, so that we will show your things there in the online.
True.
Sir, your screen is all visible, sir. Only your screen is visible. We want to show an introduction for you, sir. That's something if you could.
Stop, sir. Okay, fine. Do it. I'll do it. Yeah.
So, good morning to all of you. Today we'll start with the first session of the day. The title of the first session is Clinico-Forensic Toxicology, advancing today's practice towards global excellence. For this session, first I welcome our chairperson, Professor Dr. Srimant Kumar Das. Good morning, sir, and welcome you, sir. Professor Dr. Srimant Kumar Dasher is currently heading the Department of Forensic Medicine and Toxicology at AIIMS Madurai. Sir will be the chairperson for the first session. I would now like to welcome our chief guest for the first, chief speaker for the first session, Professor Dr. Krishna Chawali. Sir has a professional experience. Sir's profile has been displayed here. Sir has a professional experience. Sir has started his career in forensic medicine and toxicology from Government Medical College, Surat. Sir is currently serving as the professor and head of the Department of Forensic Medicine and Toxicology at AIIMS Raipur. Our speaker holds multiple administrative positions. Sir is also the member at holds many professional memberships. Sir has started the first DM course in medical and forensic toxicology at AIIMS Raipur, the first of a kind in India. Sir has received many awards to its credit, and notably Mr. Justice Jagdish Sharma Mishra Oration Award for 2024. Sir has multiple publications of national and international journals to his credit. Sir has jointly developed the checklist for medical legal autopsy with Dr. Swapnil Agarwal and Dr. Lavash Kumar. With this brief introduction, I request our guest speaker for today's session, Dr. Krishnajit H. Chawali, sir, to kindly share his PowerPoint.
Dr. Gerard, just give me a moment before I can just start. Yeah. I want to enter anything. Yeah. I hope I'm audible and my slide is visible. Can someone just tell me?
Yes, sir, you are audible.
Yeah. Thank you. Thank you so much, Dr. Gerard. And good morning, Dr. Shriman. Nice to see you.
Thank you, sir.
And it's an honor that Dr. Das, with whom I have been associated at AIMS Raipur, he's chairing this session. Thank you so much, sir.
Rather, it's my honor and privilege to be in the session when you are speaking and I am in the chair.
Thank you so much, sir. Thank you. I can sense that the beginning with such a great enthusiasm and energy that Dr. Das brings wherever he goes. That it's a good sign for the conference, and I must acknowledge the AIMS Madurai's efforts, especially Dr. Senthil, Dr. Devnath, Dr. Mukesh, again, Dr. Mukesh, with whom we have worked here together in AIMS Raipur. So their brief, their young department with a great vision for the future, their great vision for the national toxicology advancement is fabulous. I was asked by Dr. Mukesh to talk about, he said we are organizing a conference and we want you to give a talk. And I said yes. And that was just a reflex yes. Then the topic was sent to me, and then I was actually confused. I did not know what to talk on this topic. It was really very a challenge for me. To be very honest, I don't claim to be an expert in toxicology. I am still learning, and as per my learning, it was a little difficult for me. Somehow I could. It appears like I am giving an exam today. I'm the candidate, and the examiners are all sitting there right in front of me, assessing me. So, excuse me if there are any faults, and please bring them to my notice so I learn along with you all. I'll just go for a brief overview of the topic first. So, what is clinical toxicology? Clinical toxicology is the part of toxicology that deals with patients who are exposed to various poisons, you can say. And the key words here would be precision, it would be speed, it would be personalization.
Sir, respected sir.
Yeah.
Sir, your screen is not a slideshow, sir. Just
not changing?
sir, slideshow, sir, slideshow.
No, it's already on slideshow from my end.
No, sir, once again, you have to share the window, sir. You have to share the window.
Yeah, I've shared it. Just let me do it once again. I do one thing. I need to cancel this and I'll do it again.
Yes, sir. You have to share the window after opening
Okay,
the
sure.
slideshow, sir.
Sure, I'll do that.
Yes.
Okay, I think that's better. And there we go.
Sir, okay, sir. Fine, sir. Yes,
Fine,
sir. This is fine, sir. Fine, sir.
Now it changes?
Fine, sir.
Okay.
Okay.
So thank you. Thank you for bringing that to my attention. So we are talking about clinical toxicology, and the key words here would be precision, it would be speed, it would be personalization. And we now have a lot of point of care and rapid diagnostics where we have lots of advances in biosensors. We have portable analyzers. We can just carry them wherever you can go, and almost instant. That was the biggest lacuna with earlier systems that we had. The biggest lacuna was it used to take time, and now we have the wherewithal now to go for almost instant detection of toxins and drugs in the emergency settings. And we have also equipment like mass spectrometry and liquid chromatography, which are becoming more, smaller in size, more portable, and their efficacy and their accuracy is very high. And that improves your bedside toxicology. We have emerging subjects like pharmacogenomics and personalized assessments, where the person's genetic profiling, it helps predict his individual susceptibility to drug toxicity, and it guides us for safer prescribing practices. So that is also something that is included in clinical toxicology. And now, when everyone is joining the AI bandwagon, we can't stay back. AI-driven decision support helps us. We already have, AIMS Raipur is pioneering in AI-driven tri-age care, AI-driven, ECG assessments. So this also can be applied to toxicology, and machine learning models can help in predicting the overdose outcomes, drug interactions, optimal antidote uses, long so on so forth, long list of things. So these can be embedded. These decision systems can be embedded into the person's electronic health records, so that you can have real-time toxicology alerts as well. So that is what is clinical toxicology. If we talk about forensic toxicology, this is more about a legal perspective. Here, the scope and its keywords would be sensitivity, because legally you can't afford to have a vague report, or a report where your sensitivity is very low, your specificity is very low. So you need a high sensitivity, a scope, and legal relevance should be there. So here, the while in clinical toxicology, your requirement for precision was not very high. Here, the precision should be very high. Ultra trace detection and novel matrices are also coming in. Now we have techniques like HRMS, like that means high resolution mass spectrometry, and tandem mass spectrometry along with liquid chromatography. These can detect substances up to picogram levels. So that said, it's also important that the the results thrown in by these systems have to be interpreted with care. Otherwise, it could be a faulty detection. So that scope of the toxicology also is now wide. We have newer substances, designer drugs. The criminals are always a step ahead of the law enforcing agencies. So there are multiple emerging substances and designer drugs. You have, and then you have different what you call matrices. Now, lately, hairs, nails are being used for historical interpretation of historical detection of exposure to poisons. And so we have to always keep pace with the current trends. You also have this microbiome and postmortem toxicology. So microbiomes are studies on human microbiomes are on the rise, and they also help us with a lot of information. And postmortem toxicology. Sometimes, you can also use the DNA for detection of postmortem interval. Similarly, you can have postmortem for toxicology as well. You can use the microbiome. Forensic microbiology is now emerging as an important tool to detect biotoxins. So microbiology is not same that we knew of only the organisms, the bacteria. It has gone beyond viruses. So now microbiome examination is gaining importance, and microbial signatures, they also help us in suspicious deaths. So we are now integrating lots of other fields into the scope of toxicology, which was so far only limited to only chemical substances. And finally, without legal and ethical integration, forensic toxicology would have no meaning. So we can discuss those things as well. So historically, if I say in the ancient era, poisons were like hemlock, arsenic, opium, aconite. They were all documented in literature, in Greek, Roman, and Indian texts. And physicians often doubled up as for poison experts. So there was nothing like a toxicology expert. So it was a like we all already have in our current setup also. Physicians, we double up as poisoning experts. So clinico-forensic toxicology has now evolved from that rudimentary poison detection to antiquity to a, you can say, a sophisticated discipline, which is integrating multiple specialties, which include clinical medicine, it includes analytical toxicology, it includes legal investigation. So multiple integrations are already going on. In the Middle Ages, poison became a common tool in the political intrigue. It was now when people started understanding, like research into toxicology is, you can say, is as old as the man's quest for food. So it was a hit and trial initially, where people might have tried and tested various materials, whether they're edible or otherwise, and edible ones would be consumed, inedible ones would be discarded. But then Middle Ages, the thinking changed, and they thought that those things which are inedible but which could also cause some damage could be used as a weapon of offense. So it became a common tool of offense. And here detection was basically based on symptoms. And there was hardly any laboratory support, or even if it was something very, very rudimentary, very empirical. Then came the birth of forensic toxicology. Or we all know that Matthew Orfila, who is regarded as the father of forensic toxicology, systematized poison detection in biological samples, and he emphasized the medico-legal applications of toxicology. So in early forensic cases, courts started accepting toxicological evidence linking clinical symptoms along with chemical proof of poisoning. So that's where analytical toxicology came into being. Later on in the 20th century, there were more analytical advances. We can put them into three categories. One is the classical methods, where you have the color tests, where we have the precipitation reactions, and we have the spectrometry, improved sensitivity. These are all there. Some of them were plainly like color tests and precipitation reactions could be screening tests. They would only help you in screening certain substances. Maybe many times they had the more of a exclusionary value than an inclusive one. So while spectrophotometry, it improved some amount of sensitivity. Then came in chromatography and immunoassays, where starting with the TLC, our humble TLC, which still till date is being used in many centers. But then came up gas chromatography and high performance liquid chromatography, which allowed separations of complex mixtures. And then we had immunoassays, which like we already are using a lot of immunoassay cards kits. They enabled rapid screening. Again, this was only a screening test. Once separated by the chromatography, the separate substance could also require to be tested for a confirmatory test. That is where mass spectrometry came in. It revolutionized detection with high specificity, and it was crucial for drugs, alcohol, and poisons in both the clinical and the forensic contexts. So as far as the clinical forensic toxicology is concerned, we're talking about integration. So clinical forensic toxicology bridges that patient care and legal accountability. We already know very well that in India, the Medical Council of India, the erstwhile Medical Council of India, and now the NMC. If you look at the curriculum for MBBS, toxicology is given to forensic medicine subject, and it's not included either in medicine or emergency medicine or anywhere else, or even pharmacology. So it's a place where we are the bridge between legal applications of toxicology and patient care. That is the reason why we are the best persons suited to take over toxicology fully onto us and then start working on the subject. In the hospitals, toxicology subject guides antidote usage. It can also guide you about drug monitoring and management of overdoses. So it's not that toxicology should be restricted to only poisons. There could be a drug overdose. There could be adverse effects of poison of legitimate medicines. So it includes everything. The toxicology should also be integrated into hospital practice for drug monitoring and overdose management. And in the forensic supports, we all know that it supports postmortem analysis, workplace safety, and criminal investigations. So, what would be the contemporary challenges? We have novel psychoactive substances like synthetic cannabinoids, opioids, and designer drugs. The criminals, like I said already, they are a step ahead of us. And these newer substances, they complicate detection. Their interpretation is difficult, and we might need to, upgrade our systems to come up to that level to detect these substances. We also are looking for towards automation and high throughput screening, where the sample size increases, where your number of tests might increase, where then manual testing would become very difficult. It would be very difficult for a person to manually extract the poison from the matrix and to also test them individually. So an automation and high throughput screening would be desirable. That is where robotics and digital data systems would come in, and they can enhance your efficiency. But the problem again is about privacy, because the moment any data goes online, it can be hacked. And we have very recently we have had concerns about the hospital data of AIMS Delhi getting hacked, and it was down for quite few days before it was again restored. So these are some of the problems with automations. And naturally, there would be ethical dimensions of the whole thing, about consent, about confidentiality, and medical and legal priorities. They continue to remain the central issues. So we should never be forgetting about those things as well. So today, clinico-forensic toxicology is a multidisciplinary science. It combines pharmacology, it combines clinical medicine, it combines emergency medicine, it combines analytical chemistry and also law. So it's a vital role in emergency care, public health, workplace safety, and criminal justice. So both patient survival is not just about saving the patient, but also about protection of the society from the ill effects of the substances. So, interdisciplinary integration is the mantra for today, and we need to bridge between clinical and forensic toxicology to establish a synergy between these two subjects. We need to use it. It's something which bridges emergency medicine. It bridges pathology, analytical chemistry, and the law. So technological advancement that we have is, we have already talked about this. Analytically, we have the tandem mass spectrometry with liquid chromatography. We have the HRMS. We have biosensors, and we have multiple portable toxicology kits. So these help us in our daily work, make our life a lot easier. Digital toxicology is about you use artificial intelligence assisted triage. You can use toxicology databases where a substance that you might have found, which is toxic, you add to a database that could be accessed by a person sitting on the other side of the globe, and he would not have to. So now that excludes the requirement of standards, because that is one big headache. Those who have experience in analytical toxicology will agree with me that whenever we do a testing and you have to test against a standard, and that standard is difficult to get or it is very expensive, and that makes the task all the more difficult. So these toxicology databases would help in eliminating the requirement of standards, and also like AI would help in decision support systems. You can key in the findings into the computer, and you might get assistance from the artificial intelligence systems in your clinical decisions. In fact, some of the online available systems are already using decision support systems for their clinical decision making. Surveillance is yes, very important. Yeah. Toxicology, vigilance networks, and early warning systems for novel psychoactive substances is something that we need to establish. So these are the advancement that we need to do. And education and capacity building is very important, because not just work, but we need to build people. We need to create a workforce that works entirely in toxicology. So the first step would be curriculum innovations. You need to have training for existing people, and which includes clinicians and forensic experts and legal professionals. And you might have to start new courses like the course that we have started at AIMS Raipur, the DM course in toxicology, and we can also look for collaborations, global collaborations for fellowships, for exchange programs and joint research initiatives. So we learn from each other. We can have faculty exchange programs, and we can have this sort of, for example, this particular forensic convergence is a nice initiative by AIMS Madurai, where we can, people sitting from distant places can actually exchange ideas. And community education on toxic risks and antidote access should be created. So community is also well educated. A big concern in India would be, say, for example, snake bites. Snake bite is a big concern. And because of lack of education, I just give an example of this lack of education. People uh, go to faith healers before uh, they access legitimate healthcare. Another thing that we have seen in Chhattisgarh here is a person who suffers any sort of stroke, he or and becomes hemiplegic or paraplegic. they are administered kerosene, and it's just that they do not have that awareness. And this kerosene, instead of doing good, I don't know what good it does, but it definitely does harm. There is a high risk of aspiration in these patients, and if the person is not dying of the stroke itself, he would definitely die of aspiration pneumonia, the lipoid pneumonia. So community education should be strengthened. And in future, you might think of personalized toxicology, though it's only on paper as of now. And in India, we do not have this facility right yet. But genomic and metabolomic profiling of individuals will help in tailoring their requirements to personalize their interventions and their requirements. So that would be a great step forward, which would almost eliminate drug overdoses at all. So we can simply eliminate a lot of things, but this is a far way to go. And then, like we said, toxicology. When we started with toxicology, we thought it's a simple thing. Less knowledge is a dangerous thing. So we felt that toxicology is something that we can all easily handle. We already know everything, and we jumped in. And once we jumped in, we found that toxicology is an ocean, and we are not even a drop in that ocean. So it's no toxicology is not just affects humans; it's also affects animals and as a whole environment. So if you can integrate all these things, because ultimately one affects the other. So if these three things can be integrated together, that would make a wonderful initiative. So that's all that I wanted to talk to you about. Thank you so much. Over to you, to the organizers.
Thank you, sir, for
Thank
your
you.
enlightening talk. Now I request our chairperson, Srimant Kumar Dash sir, to kindly give his opinion. Sir Dash sir, you please unmute yourself, sir. Sir, kindly unmute yourself, sir. Srimant Kumar Dash sir.
Okay, okay. Am I audible now?
Now you're audible.
Yes.
Yeah.
Wonderful.
First of all, I'll congratulate the Department of Forensic Medicine and Toxicology, AIMS Madurai, in charge HOD, Dr. Senthil Kumaran, and his team for organizing such a wonderful CME, which has spanned over almost 3 days. In between, one day of gap was there, and the participation from the various parts of India was there. So many paper presentations, especially from postgraduates. It's really encouraging to see that the youngsters are coming up with their presentations, innovative ideas. And today's presentation, especially, nothing more to say about sir, because everybody knows the way he has developed his not only his career but the department, especially forensic medicine and toxicology, and he is having a distinct identification for the first department or first institute to start this DM in forensic and medical toxicology. And now he is a proud teacher. Already he has given, I think, not less than 5 or 6 students, DM students, to the society. Those will be working in various parts of the country, providing their services for the upliftment of the toxicology, especially. And today's presentation, sir, it was really a detailed and lucid presentation, which is really a difficult topic to talk on. But somehow, it's as usual, your presentation was really good, especially involving the point of care and especially the involvement of AI, which is like getting into all the aspect of our practice. Is not only clinical but also in forensic. So it's a wonderful presentation from your side. If any question is there, it can be asked.
Delegates are requested to post their questions in the chat box, sir. We will discuss all the questions in the panel discussion at the end of the session. Thank you, sir. We conclude the first topic for the today's CME. I would like to thank our esteemed speaker, Dr. Krishna Chavali, sir, for his wonderful talk, as well as our chairperson, Professor Dr. Srimant Kumar Das, sir. Thank you, sir.
Thank you so much.
Dear delegates, we move on to the next talk of today.
Thank you so much.
Thank you, sir. Yes. Now we move on to the second talk of today's schedule. The topic of the second lecture is current trends in acute poisoning management. For this talk, for this session, I would like to invite our chairperson, Professor Dr. Ambika Prasad Patra. Sir is currently heading the Department of Forensic Medicine and Toxicology, Jupmer, Puducherry. We welcome you, sir, and good morning to you, sir. And now, it's my pleasure to introduce the speaker for the topic, Dr. Narendra Nath Jana. Our speaker is currently the director and clinical head at the Institute of Emergency Medicine, Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. Sir has a vast professional experience, has mentored over 100 masters in emergency medicine residents across India and abroad, has developed and led multiple academic programs in emergency medicine and toxicology. And sir is also the founder of the Emergency Medicine Academy. Sir holds multiple academic positions at various organizations in India and international. Sir is the recipient of the Global Leadership Scholarship Award from the American College of Emergency Physicians, USA. This is such a prestigious award that has received, and we are honored to have such a recipient of this prestigious award to be the speaker of our session. Sir has also authored 170 publications in various nationals and international peer-reviewed journals. With this brief introduction of our speaker, now I request our speaker, Dr. Narendra Nath Jana, sir, to kindly share his PowerPoint and start his session. Good morning, sir. Welcome, sir.
Good morning.
Yes, you can share your presentation from your side, sir.
Okay. Hope it is visible.
No, sir, you have to share your window, sir, so that it will be more clear.
Okay. 1 second.
Morning, sir. Can you hear me? Dr. Senthil, can you find me?
Sir, you are audible, sir, but you are yet to share your screen, sir.
Yes.
So I request you to open your PowerPoint in a separate window and then share it, sir, rather than opening the file and sharing it.
No, there are. I am Dr. Ambika.
Yes, sir.
Yeah.
Sir, good morning, sir. Welcome, sir.
Good morning. Dr. Senthil,
Morning, sir.
hope it is visible now on the slide.
Yes, sir. The slides are visible, sir.
Fantastic. Can I start?
Yes, sir. Before that, I would like to again welcome our chairperson for today's session, Dr. Ambika Prasad Patra, sir, who's currently heading the Department of Forensic Medicine and Toxicology, Jipner, Puducherry. Good morning and welcome you, sir. Now, I request the speaker.
Thank you, Dr. Gerard, Dr. Senthil, and entire organizing team for having me in this gift. And good morning, sir. Let's start right now.
Yes, sir. Now, I request the speaker to kindly proceed forward. Thank you.
Take it on. Okay. Thank you, Dr. Senthil. Good morning to everyone. Thank you for your introduction. And of course, it is a great initiative by you and AIMS Madurai. Next slide. Not okay. I'm just sharing, just to wait
Yes,
a
sir.
few
Yes, sir.
minutes.
Yes.
There, AIMS. Says- You can now, probably you can see my slides. Dr. Senthil?
Yes, sir. Your slide is.
Okay. If by chance you are not audible to me or my slide is not moving, kindly let me know in between.
Yes, sir. Sure, sir. Sure, sir.
Fantastic. Thank you. What is happening? Okay. Okay. Oh, this is fine. Okay. So I'm from Madurai. Probably those who are in Temple City or in Tamil Nadu or in South India, probably they know why Madurai is very popular. Madurai is very popular because goddess Meenakshi is there. So it is more than 2000 years temple here. And I'm very privileged that, we can visit anytime there. But those who are not seen this temple, probably they must visit sometimes when they get chance. And of course, I am working in this two beautiful hospital, which is one of the largest hospital in South Tamil Nadu, particularly in the private sector. And we are now we inaugurated this new hospital, which is called Meenakshi Super Specialty Hospital in Madurai. And I am working as an emergency head of both two hospitals. So already we have thanks Dr. Senthil and for the wonderful initiative by him and All India Institute of Medical Science. The beauty of this conference is he collaborated with the two specialty, particularly one is forensic and another is clinical medicine. And at the previous speaker, he was talking about the breeze between forensic and clinical medicine, which is very important, particularly for the toxicology. Sir rightly said that it is the need of hour that two specialties should grow together to save, of course, many more lives, which is very, very important. And I should thanks to my chairperson, probably, we know each other since long time. Professor Ambika Prasad Patra sir, he's from my original state from Orissa. And of course, he's my neighbor. Now he's there in Jipmar.
Thank you,
So
sir.
basically, when we are talking about the clinical toxicology, the theme as such is very wonderful. The theme is forensic toxicology from theory to practice. Today, much about actually, a previous speaker has told the different types of toxicological science need of the hour, including artificial intelligence. But I will stick to the most important thing. What we supposed to do when a poisoning patient's brought to the clinical facilities, particularly to the hospital or clinics. There is no doubt that poisoning is a global problem. It is a public health concern. And most of the time, when patient brought to the hospital, it is an emergency as well, like stroke, like MI, or like road accident. Poisoning is also an emergency. And of course, it required timely intervention with standardized protocols. We know the spectrum of toxin is evolving, particularly advanced of agriculture agents, pharmaceuticals, recreational drugs, and household chemicals. But what are we supposed to do when the advancement of agents are there? Definitely we have to advance with therapy. So the modern management should be work with rapid diagnostic tools. Of course, previous speaker talked about artificial intelligence, which helps most of the time decision making, and of course, novel therapeutic approach. My presentation will be very simple because I was told that there were so many residents also joined, postgraduates also joined. So it will be helpful for everyone because it is not only the clinicians. I always believe that even there is a role for each and every specialty. When they will see any poisoning patient, they should not hesitate to treat or educate others. And that's why it is very important that it is a multidisciplinary coordination required, and it is multidisciplinary therapy and approach. Global burden, when we talk about poisoning, according to the WHO, there is a 0.3 million deaths annually. And of course, if you see the statistics, we will find the most of the time the low and middle income countries, mostly exposure to the toxic. And again, very important thing that up to around 30% patients, they are admitted in intensive care units. That's alarming actually, because 30% patients, they required intensive care. Mostly, if you see, the common agents are OPC, sedatives, alcohols, and of course, industrial chemicals. And we have seen in many hospitals, there is a difference between rural and urban areas when the patients takes these poisons. Of course, rural areas, OPC, aluminum phosphates, all these stuffs are there. But in urban areas, you will agree with me that most of the patients, they brought to emergency or ICU with some recreational or prescription drugs that maybe overdose are very commonly we used to find. When you talk about poisoning, most of the people, we don't know that poisoning is also a fourth leading cause of mortality in India. So it is a serious problem. Like heart attack or coronary artery disease or diabetic. This is also a problem in public health. So some study says that this may be more, but it is a 5 to 6 per 100,000 population annually. Now you can see, again, very important statistics. Young people, 4 decades of their life, they're consumed and sometimes they die. So this is again a huge problem. And commonly, as I said, it is the same again in India, rural or semi-urban agriculture-based families. And probably everyone we will be agree. We have research on diabetics. We have research in coronary artery disease. We have research in every field, but we have less research in toxicology. Because probably, I don't know, because probably the poor people are affected in this clinical toxicology, probably in poisoning. But we required more research on this, more awareness on this, more education on this. I should thank the previous speaker. He was also emphasized. And I should thank that he has started first time DM in toxicology, and probably it can help to do more research work, more clinical work, practice on clinical toxicology in our country. We know there are challenges, including the awareness side, general public side. There are challenges also in clinical sides, because there are so many agents, lack of standardized protocols. And of course, all antidotes, though we talk about, we prescribed, we practice, but availability is always challenging. Most of the time, even ASV is not available most of the time, but thanks to the government, so many states now, the ASV is available in the primary centers. That is called the awareness, of course, the demand, and of course, the clinical side, it has been improved. So I just wanted to share important slides here, because my thesis in CMC Vellore, it was poisoning. And when I was doing my training there, last 20 years, I have not seen that there is decrease of poisoning or suicide attempt. Rather than day by day, it is increasing. And you will not surprise, probably when you see in the newspaper, you will find somewhere this type of news you will get. So it is a serious problem in our country. Now you can find there are some cereals also made, curry and cyanide. So our approach has to be changed. As I said, that every doctors should learn and spread the awareness and education regarding how to manage acute poisoning. So this is very important, that patients, if not treated on time, patient may be, before reaching to the hospital, they may be die. Particularly if you see in snake bite statistics, documented snake bite, 50 to 60,000 people die in India. So this is a serious problem. Only snake bite. Again, apart from there are so many poisonings. So it requires a systematic and consistent approach of this poisoning care. First few hours, particularly first 4 to 6 hours, these patients required appropriate decontamination techniques, timely administration of antidote, and further supportive care can change the outcome of this poisoning care. So as I was told, the more participants are residents background. So I will try to make it very simple what to do in clinical toxicology side. Though I am not expert in forensic medicine, but I will make it very simple how to approach when a poisoning patient will encounter in our emergency department or OPD or clinical practice. So first, immediate assessment required. We should not think about what poison, but we have to think about the patient first. We have to stabilize the first. And let's think about decontamination. We will think about how to eliminate this toxin. Antidotes, if available, we should prescribe. And poisoning patient required very few lab tests. If it is available, of course we do. And nowadays, urine tox screening is available some departments, but I should suggest that it should be available most of the emergency department I have, and I am getting the diagnosis very early and quick. And of course, these patients require proper disposition, admission to observe, monitor, and if required, further treatment. So I can make it as A, B, C, D, E approach of poisoning patient. So what we supposed to do? A stand for airway, B stand for breathing, C stand for circulation, decontamination, and E stand for enhanced elimination is essential in toxicological emergencies. So most of the patients that die either neurotoxic due to snake bite or OPC poisoning or any other poisoning because the airway was not secured in the first position. Patient who had a breathing difficulties, patient had a pulmonary edema, patient had an, as I said, neurotoxic, was not addressed that first few hours. So securing airway, it should be the first priority, especially again, if the GCS is low, again, patient is comatose patients. After that, breathing, circulation must be stabilized with oxygenation, fluids, if required, inotropes. After airway, breathing, circulation, I will go details on this. Decontamination should be with activated charcoal or gastric lavage if required, because it is time dependent. Enhanced elimination through hemodialysis indicated for selected poisoning. So when we will address airway, it is very simple, but it is very dynamic. When patient you will encounter, if airway is compromised, patient is gasping, GCS is low, patient is comatose, if you think, address it. If airway is compromised, then definitely patient required airway protection, definite airway protection. That is, if available outside pre-hospital care, if trained people are there, visible we can intubate or we can use LMA. Somehow we have to address the airway. Of course, in the emergency department or ICU, we should not take chance. We should intubate the patients as early as possible, because some substances, the airway edema, airway can be so much edema, it can be difficult further intubation. So we have to address the airway with intubation. If airway is patent, that means if not compromised, airway is okay, the saturation is okay, but in this is the difference in clinical toxicology. That is what we have to address. Other clinical, when patient is other diagnosis, that is maybe it's different, but in clinical toxicology, if sensorium is altered, For example, patient has taken alprazolam tablet, more tablets, and his GCS is again low, but airway is okay. Airway is not compromised, but here sensorium is compromised. Then of course, if alter sensorium or compromised, then we have to intubate. If again after intubation, we have to proceed for the other clinical stuffs, resuscitation. After sensorium, if normal, airway is normal, sensorium is normal, then these groups of patients, we have to proceed with further resuscitation. There are a lot of studies has been there, including Indian authors, about the initial management poisoning patients. We have to how to address the airway. When there is, we have to check whether whether patient is able to protect their airway when their GCS is normal. Mostly, we have to see whether the patient can protect or ability to protect his aspiration, particularly when the OPC poisoning, and we have to address this. Now you can see why intubation is important. What are the types of poison that can face the problem? Means the clinician can have problem. Corrosive poisoning, paraquat poisoning, hair dye poisoning. Usually, this will not give more time. Obstructed airway or laryngeal edema can be profound within few minutes. I have seen many patients, particularly hair dye poisoning. Patient is GCS is fine, speaking to you, but within few minutes, his laryngeal edema so much that you can difficult to intubate. And we have learned lessons on our practice that we have, if we address the airway early, it will be give us more scope to treat further. Particularly again, organophosphorus, bronchoria is profound, so we have to intubate. And these drugs, benzodiazepines, alcohol intoxications, opiates, they depress the sensorium, and we should intubate particularly. Then we can proceed for the resuscitation further. So after airway, we should think about or check saturation. Always these critical patients require oxygenation and with non-rebreathing mask. We have to observe the breathing pattern and adequacy, because sometimes patient may be breathing, but we have to check how the pattern of the breathing and patient whether adequacy is there or not. If not, then we don't have to think anything, intubate and ventilate these patients. So sometimes these patients can come with hypotension, and these patients hypotension because of some drugs overdose. And it is very important that we should check the vitals properly, particularly heart rate, respiratory rate, blood pressure, and we should not hesitate to do early ECG. Certain chemicals, certain agents can cause myocardial depression, dysarrhythmia, conduction abnormalities. So we have to check their vitals at the time of patient. You see, that is which is very important. Some patient can present to us with hypotension, particularly when there is a calcium channel blocker overdose. Sometimes patient can brought to the emergency with overdose of this hypertensive medicine, antidepressants, sedatives, and opiates overdose. So these patients can have hypotension. Again, certain groups of patients, when they consume some type of these types of medications, they can come to the emergency with hypertension, particularly cocaine, hallucination drugs, anticholinergic drugs, recreational drugs, and monoamino oxidase inhibitors when patients are treated with depression or sometimes of Parkinson's diseases. These medications, when they are overdosed due to anxiety, depression, and these patients can come with hypertension. So these groups of patients, these groups of substances, when there is overdose, these patients can come with bradycardia, particularly when patient has taken beta blockers overdose, anticholinergic drugs, clonidine, alcohol, ethanol, and digoxin. These patients can come with bradycardia. So synonym I have written paste to memorize. So some people, those who interested, they can take a screenshot so that they can remember when patient encounter bradycardia patients in emergency and suspect that patient can have a tablet overdose of these patients. Certain patients again can have a tachycardia, cocaine, anticholinergic, sympathomimetics, theophylline overdose. These patients can have presentation tachycardia. So vital is very important. We are taught from our MBBS days that history. There is no substitute taking history. But here it is sometimes difficult, and sometimes it is also learning lesson for us. As per our poisoning patients are concerned, so most of the time there are so many papers you will find. Only 1/3 of patients, they will tell you the right things, right story behind, or right drugs they have taken. But more than 70% patients, they will not tell you exact what they have taken the medicine, before coming to the hospital. So that is why it is very important the clinical medicine is come to picture. That's what it is very important that we should think about this clinical medicine. We should not forget that what we have learned from our MBBS days. That is what I always say, 5T. First T is very important. Talk to the patient. That is communication. Communication between you and the patient. If GCS is low, patient comatose, or something like his anxiety, then of course there is time to talk to the relatives or those who brought the patient. You can get so many information from the relatives. Second T is touch the patient. Nowadays we are absolutely forgetting this clinical skill. Touching the patient means clinical examination. So first T, talk to the patient. That is communication between you and patient and relative. Second T is touch the patients. That is why the vital is very important. If you touch the patients, you can either smell, or this is how the vital measurement is very important. Third T is if patient is sick or GCS is low, then here we have to treat the patient. Treat. If GCS is okay, patient is talking to us, then probably we require some test here. So we can interchange. So third T is either test the patient or treat the patient. So after the fourth T, first T is talk to the patient, touch the patient, treat the patient, test the patient, and fifth T, transfer the patient to the right department and the right specialty. If required, ICU. If patient require dialysis, of course, early dialysis, certain patients can be life-saving. So early identification of poisoning, mostly achieved through the clinical evaluation. Very, very important, and which 5T is critical. And point of care testing. So most of the time, as I said, urine test can be done, tox screen urine. You can get what type of overdose patient might have taken. And of course, toxidrome recognition, like cholinergic, anticholinergic, opioid syndromes can guide us that what type of substance this patient might have taken. And it may be overlapped, but it will give us a clue what might have taken. If I can tell you that if you do the clinical examination properly, we can get mostly provisional diagnosis, and we can treat, and we can transfer to the right department. Biomarkers to be done early, particularly when you are suspecting certain group of patients, serum cholinesterase, lactate level, it can narrowing the diagnosis. We have seen in emergency it is not easy because so many differential diagnoses are there, and you have to suspect when there is particularly when there is a comatose patients, tox screen is very important. That's what when you see the reversible cause of cardiac arrest, 5H and 5T, when you are talking about 5T, 1T is toxin. And it can also, if there is a sudden cardiac arrest in the emergency department, brought the patients to the emergency department, and there is a cardiac arrest, don't hesitate to think that the patient can have a toxin. So that is why 1T among the 5T of reversible cause of cardiac arrest, it is toxin. Of course, nowadays, artificial intelligence, triage tools, digital diagnostic support can be utilized in the emergency or ICU to treat patient and early diagnosis, which is very important. So recent advances in antidotes, including the next generation lipid emulsion, artificial guided antidote protocols are very, very important. So after airway, breathing, circulation, now we'll talk about decontamination. What are the standard trends? What we supposed to do? Every patient not necessarily required gastric lavage. That is how the standard textbook is there. If you see all the developed countries or European textbook in poisoning care, you will hardly find that decontamination means gastric lavage is required. But we have seen in Indian scenario, most of the patients, they take sustained release medications, which is and multi-composition drugs. Now you can think about OHA, anti-hypertension medicine, certain antibiotics, which is 2 or 3 medication combined. One tablet can have instant effect, and same tablet can have a sustained release. It can affect for after 6 hours. For example, OHA, oral hypoglycemic agents. So certain medications can cause. So even this patient comes early to our department, these patients required gastric lavage. So we should know what time patient has taken these substances, how it has taken, and what is the condition of the patients. Of course, we know the universal antidote, which is called activated charcoal. It will, if it is effective within few hours after the ingestion of the toxin, that is which is very important. So multi-drugs activated charcoal having roles of treating particularly certain poison and particularly OPC poisoning, and there are so many articles are there. That if you are taking multi doses of activated charcoal, then the ICU stay has been reduced, particularly OPC poisoning and ventilation as well. So gastric lavage is reserved for life-threatening poisoning when performed early under airway protection. That means if patient is comatose or patient is GCS is low, we should not do gastric lavage instantly. We have to address the airway. Then after that, we should do the gastric lavage. There is scope of whole bowel irrigation used, particularly sustained release formulation or in body packing cases. Endoscopy may be indicated for the retained foreign drugs, drug masses. So in poisoning, we talk about that airway, breathing, circulation, decontamination, but the most important thing is supportive and critical care. So it is the spine. Every patient, not necessary that they required antidotes, but if supportive care is very good instantly, and most of the patients, it will be well settled or saved their life. So if patient is required ventilation, so probably these patients should be treated where mechanical ventilation is available, particularly ICUs. When their GCS is low or there is a respiratory compromise, these patients require mechanical ventilation. Sometimes, maybe if you require more time, then probably they can be treated with tracheostomy. We have seen so many patients, rather ventilating, when intubating, we can do the tracheostomy and patients will come out well. Of course, certain compounds, these patients having seizures, they require benzodiazepines. Certain patients having renal compromise, renal problems, these patients required hemodialysis early. And of course, certain patients required ECMO, and when there is a severe cardiotoxicity with refractory shock, particularly when there is aluminum phosphates, and these patients, if treated ECMO early, then definitely patients can be survived. So my thought is we should have these type of clinical modalities so that we can treat early or refer early those centers where these facilities are available, and so that we can save their lives. So we know, as I said, when to lavage and when to not. And of course, gastric lavage should be as early as possible we should give if it is appropriate. And they should be given gastric lavage. And most of the time, we should not, certain group of patients, we should not give gastric lavage, particularly when there is a corrosive hydrocarbon and a patient is comatose. We should not do the gastric lavage. Extracorporeal removal can be done and required, particularly poisoning patients, particularly when certain groups of patients required hemodialysis or charcoal hemoperfusion, peritoneal dialysis, and plasmapheresis. And there are extremely well documented, approved that these types of care, if done early, poisoning patients can be survived. For example, if hemodialysis, you can see in the right side these substances: isopropyl alcohol, salicylate, theophylline, methanol, lithium. These patients, these substances, these patients taken, definitely most of the time hemodialysis required, and if treated, can be saved life. Hemoperfusion is sorry. Hello. Yeah. So CRT required when particularly those patients hemodynamically unstable and are not candidate for conventional hemodialysis. may require CRT in certain groups of patients, which can be again life-saving. Antidotes, as I said, it is extremely useful, but it has to be procured, kept, and used appropriately. Particularly, you can see these types of drugs, starting from acetaminophen, particularly paracetamol, anticoagulant, benzodiazepines, beta blockers. If you treat with antidotes, certain groups of patients can be life-saving. GCS can be improved instantly, and patients not probably require that time intubations. But if not available, of course, we don't have to worry. We have to address again airway, breathing, circulation, decontamination, elimination, and particularly, the critical care, supportive care management. If not available antidotes, we don't have to worry about that. If it is available, nothing better than that. Particularly when we have seen many patients, those patients come with benzodiazepines. When you are giving flumazenine, instantly within few minutes, it happens. Sometimes patient conscious level improve. So that's the important things of antidotes. Emerging tools and trends, when you are talking about, we should practice, we should incorporate technological advancement in clinical practice, particularly in poisoning care. Mobile applications, e-poison centers, AI tools that can be helpful for us, more accurate diagnosis and triage. Portable diagnostic kits like rapid bedside confirmation of common toxins, genetic toxin, and nowadays, as I said, we are using urine tox screens available in the emergency department. Within few minutes to hour, we can establish a clinical diagnosis, and we can treat with this clinical evidence. Appropriate clinical treatment can be given, and probably it is a great help, and future is great. We can associate it with more technology, artificial intelligence to diagnose and triage and treat patients. Previous speaker also talked about public awareness, and he talked about education. He talked about capacity building. He talked about call for action. And I'm absolutely agree that this is most important for poisoning care appropriately. First important thing we should think about prevention strategy, particularly when there is we are dealing with more pediatrics poisoning care. Second important thing, we have to think about legislation should restrict access to the high risk toxins. There are certain toxins already. I'm thankful to Tamil Nadu government. They have banned few toxins, pesticides. That is very, very important. And it has to be, I think, practiced all over India. Few pesticides should be banned, and it should not be available to access. As I said again, child-resistant packaging and proper labeling should be there. Most of the medications, so that child accessing these medications or substances should not be there. Poisoning control centers, of course, few centers are working very wonderful, including in Chennai, CMC Vellore, AIMS, some centers, Amrita. So these centers, they have 24/7. Most of the big centers, they should have 24/7 poisoning control centers. It will really helpful for the real-time toxicological support to the public and clinicians. Public education, this is the key. this campaign through media. We should teach also school children's local outreach programs. So it enhance the awareness and discourage unsafe home remedies. Snake bite patients we have seen before the kidney failure or cellulitis or some other complications. Patient has been treated in the village with snake stones, with as sir told earlier, with some kerosines, other ways mechanism. So this has to be, this mass education should be there through the campaigns. And there are most again important that we healthcare professions should understand that poisoning, it is a public health concern. Many people can, it is possible, and there is antidotes available, and it has to be addressed early, and it has to be, these patients should be admitted to the hospital, because I have encountered many patients, they brought by our own healthcare professions, having, antidepressants or alprazolam tablet overdose. But the first few hours, there may not be any symptoms. But it can possible that after some time, the symptoms may come. So we have to aware about all these symptoms, signs and symptoms, and we should treat accordingly. So when we talk about the poisoning care, we should learn that A to Z of poisoning care. This is very important, very cryptic. So poisoning, when there is a airway problem or not problem, we should look for the obstruction or compromise. Breathing, look for respiratory depression. Circulation, think about if patient is hypo or hypertension. Disability or decontamination, think about hypoxemia, hypoglycemia, or any drugs. Electrolytes imbalance can be possible. Check sodium, potassium, calcium. Patient required Foley's catheter. Patient require gastric lavage, appropriate time and appropriate size, and appropriate compounds required gastric lavage. H for history, H for ions, acidosis or alkalosis. Certain medications can possible acidosis or alkalosis. Investigations, as I said, not necessary so many investigations. That's what I used to say, 5G, ABG, CBG, ECG, beta HCG, and USG, and appropriate urine test can, solve particularly in poisoning cases. J for juvenile age, mostly young people, they may have suicidal tendency. So we should not forget a psychiatric opinion before discharging them. K for kalemia, hyper and hyperkalemia. L for life-threatening conditions. That's what airway, breathing, circulation, disability is very important. And if you address these 5, A, B, C, D, E, more than 60% patients can be survived. M for monitoring. Vital monitoring is very, very important and crucial. We have to do it. NPO, N for NPO, nil per oral. And we have to, O for output. We have to check whether for pediatrics group, 1 ml per kg body weight per hour. For adult, we should 0.5 ml per kg per body weight per hour. P for P wave or PR interval in ECG to rule out any heart blocks. That's what it is very important to know that ECG, P wave, PR interval, QT interval to rule out any heart block or arrhythmia. R for reversal agent. For antidote particularly, we should know about certain antidotes, how to give, how to address it. Not necessarily we should remember. We can put a, you can check how to give antidotes and what is the use, what time we should give. And of course, S for sign and symptoms, particularly when there is a nicotinic symptoms. And T for toxidromes, cholinergic, anticholinergic, sympathomimetic, etc. It can be overlapping, but diagnosis can be done. U for unknown substances. most of the time, not necessary that we should know all about the substances. If there is unknown substances, look for the clinical sign and symptoms, call for the poisoning information center, or call to the senior people, those who are practiced or practicing clinical toxicology or forensic medicine, or anybody who dealing with the poisoning care. For volatile substances, particularly hydrocarbon, that particular time, we should know that stomach should not be given. Most of the pediatrics age group or patients, we have seen that patient with hydrocarbon poisoning, or when they are taken, these patients, they are referring to the hospital with NG tube or gastric lavage. Documented that most of the pediatrics age group patients, they die not due to poisoning, they die mostly in the ICU due to sepsis because of this window period, particularly iron poisoning, rat poisoning, bite and sting. So these patients, first few hours may be clinically normal, symptoms also may be, patient may be normal, but we know that after certain window period, these patients' enzymes will be high, patient may be deteriorated, and the patient may die. So we should prepare that certain groups of substances can cause a bigger problem after some hours or days. So we should know this window period. X factors, complication which will kill the child, we should know. That's what A, B, C, D is important. We should know why these patients has taken. Sometimes either accidental or suicidal tendency are there. Sometimes some patient may come with 1 or 2 tablets of alprazolam, and we have not addressed it and discharged from the emergency department. But next time, if you are not addressed that time, next time these patients might be brought to the emergency department with a broad dead. So we have seen certain number of patients could have been addressed early with a psychiatric opinion. Jed, for remaining, that's what we should talk about. Hospital information. Talk to this certain group of patient, to the toxicologist or clinician. Those people are doing, practice in clinical medicines. So this is a schematic view of how we should treat the patients, starting from initial assessment to the supportive care. So before I conclude, I will just tell about the fundamental principles of clinical toxicology patients in clinical poisoning, clinical toxicology patients, how to handle. So very simple, the dose makes the poison. Remember this. So it is not necessary that, the small dose or high dose, small snake or bigger snakes, it is the toxicity is always problem, and it is dose dependent. As I said, never trust the history, rely on clinical presentation. That's what 5T is very important. Clinical presentation. I said more than 70% you will not get the right history if the patient himself consumed poison or tablet. Documentation is very important. If not documented, you have not treated properly, and it is not evidence. If you documented, it is evidence. And poisoning, all cases are medical legal cases. We have to document, particularly clinicians, when we are treating, we should document the poisoning. If required, what are the substances and what are the history available, everything we should document. Identify the toxidrome early. Not only the vitals, we should check the people's secretions, CNS. These can give us clues to treat early. ABC first, toxin is second. What patient has taken, it is second. But airway, breathing, circulation, decontamination, elimination, it is first of five. So stabilize airway, 50% patients can be survived. Treat the patient, not the poison. So clinical status drives management. Time, we talk about time is brain, time is heart. We should also think about time is a toxin. Certain substances, if treated early, can be life-saving, particularly very simple if snake bite. If the poisonous snakes are bitten, if you ASB given early, patient might not require dialysis, patient might not require intubations. So we have to think early recognition and intervention are the key. Management priorities, it is not that the children having small dose, half tablets, or we should know the doses. Even small doses can be present with big toxicity. Elderly, again, we have to think about that patient.
Unable to hear.
Sir, your voice is dropping intermittently. So,
can you hear me now, sir?
No. Yes.
Yeah. I have not done anything from that side problem. So decontamination, dilution is the solution to pollution only in selected cases. As I said, no lavage in unprotected airway. Use appropriate rice tube. Activated charcoal, as I said, multi-doses of activated charcoal is useful, particularly OPC poisoning. Documented, most of the paper says it will be reduce the ICU stay and ventilation. Antidotes use, if available, use early, not available, supportive care. So that is very important. Monitoring, elimination, and key takeaways. Obtained baseline labs before intervention. Treat seizures aggressively and appropriately. Benzodiazepam is the first line of choice. Serial drug label is better always rather than single labels. Use clinical toxicology lab if available, particularly urine tox, it is available. I am using and I'm getting every week 4 to 5 diagnoses. Even they don't say we can get it. Helpful, it is guiding and not definite, of course. Beware of false positive or negative. Never delay treatment, awaiting results. So this is very, very important. And last, I will say that resuscitation and stabilization are the key. Treat first what kills faster. Airway kills faster in poisoning. So treat faster. Airway, breathing, circulation. Don't delay oxygenation for a diagnosis. Resuscitate where you investigate. Common things are common. If your center is semi-urban, then definitely most of the common poisoning you will get. Absence of evidence is not evidence of absence. Remember this is very important. Monitoring and intervention. Treat the patient, not the monitor. Never trust one set of vital. Critical patients required multiple monitorings. It is very important. That's why these patients should be admitted if further in ICUs. What gets measured gets managed. If you cannot measure, watch closely. So always in clinical toxicology, plan for the worst, but hope for the best. Call for help early if difficult. It's very important. No, don't hesitate to take opinion from the senior people because poison is different. Not necessarily everybody we should know about all the poison. So, but in poison, slow is smooth, smooth is fast. So we should remember these things. and treat appropriately. I should thanks actually the National Health Mission Tamil Nadu. They have came with handbook of poisoning management. It is I'm privileged that I'm invited one of the person who formulated this guidelines handbook, and it is released in Chennai by the National Health Mission Director, and it is freely available. And a lot of senior professors, most of the premier institutions, they have given their feedback, and they came out with this handbook of poisoning management, primary care to tertiary care. Fantastic. You can refer this book sometimes when get chance, and it's available. I should thanks to Tamil Nadu government for this, and I'm lucky that I was there, part of this. And we have written this clinical toxicology, a case-based approach book. Those patients brought to our emergency exactly same clinical evidence. Certain patients, some patients we lost, we have mentioned there as well, that we could not do much, but most of the 51 cases we have written exactly the presentation, what we found, and how we treated. So this is the book we have published. We are also running from the Indian College of Emergency Medicine one fellowship in clinical toxicology, 1 year online program. And the 12th program is hands-on training program with lots of senior professors in India and abroad. And we are just updating this clinical toxicology to the doctors in different specialty. And we are helping or supporting this awareness program on education, how to treat. Of course, there are so many centers are doing that, and we are also part of that. And I would like to invite, we are organizing on 4th to 7th December in Madurai, Resuscitation Congress, World Resuscitation Congress. We have invited many countries. Recently, American Heart Association has updated their resuscitation guidelines. And we are organizing this conference in Meenakshi Mission Hospital, the workshop 2 days and 2 days in Marriott. It is my privilege to invite you all for this conference. And with this, I would like to thank the organizer for the opportunity to speak on this online symposium. Thank you, Dr. Senthil, and for the opportunity. Thank you. So this is my team, including there are nurses and paramedics whom we have trained in clinical toxicology. They knows how to do gastric lavage, when to do, when not to do, what are the antidotes are available in my department. And we do regularly training program, workshop on clinical toxicology. And next on 5th, we are also organizing one clinical toxicology workshop in Madurai, part of this World Resuscitation Congress. We are trying our best to, awareness about the poisoning care, whatever the available resources we have. With this, I would like to thanks for the opportunity to me to talk in this Congress. Thank you so much, Dr. Senthil.
Thank you very much,
Thank you,
sir,
sir.
for enlightening talk.
Uh,
Now, over on to the chairperson for the session, Ambika Prasad Patra, sir.
Thank you, sir. It was really enlightening and enriching session. Especially most of our delegates are from the forensic, DM forensic toxicology. So they will definitely benefit from it. And thank you for highlighting so many issues on the antidote availability, primary care, and the emergency physician, and the coordination deficits also there. So all these issues, more or less within a restricted time frame, you have addressed. That is fantastic. So for the sake of audience and the pragmatic issues that we are facing, my one simple question will be: what are the most critical training gaps among the, so to say, frontline healthcare workers, particularly primary healthcare workers, in recognizing and managing poisoning cases, especially toxidrome, and moral and more important than that is the what are the critical medical legal issues the emergency physicians are facing. These two area can you highlight in a specific or the short brief answer that will be helpful for
Can I answer, sir?
please go on.
Yeah. So rightly you asked, actually, rightly you pointed out very significant and very appropriate questions. Primary, you might have seen, you are in a premier institution. You have seen so many patients actually referred to the emergency, your institution or my institution, or so many institution. The first aid treatment, that is why not addressed or not treated. See, basically, when there is a poison patients, as I said, airway, breathing, circulation, decontamination, elimination is required. So decontamination, elimination, it is in fourth and fifth. But if each and every doctors will learn about airway, breathing, circulation, treatment of any critical patients, then of course, what I feel, half of the patient can be saved. Neurotoxicity, ASB is available. There are so many centers, ASB is available, but the primary centers there, there are so many things actually. It is not that doctor is not available at that time, or ASB is not available all the time, or there are maybe so many things, issues. But if addressed, if there is a sign and symptoms are there, a snake bite, then why we are not giving ASB there, and we are sending a patients when it required 4 to 5 hours to travel to a center. So this referral should be reduced.
Correct. Sir. No. Actually, what exactly with respect to the sample preservation, collection, preservation, and transmission to the company police poisoning cases? What is the current trend or the practice among the emergency physicians, especially in our area?
Emergency medicine, particularly when there is a emergency physicians are there, I believe they are already trained in clinical toxicology. And sometimes these doctors, if there is not available, if emergency physicians are there or those doctors are treating poisoning, if it is they are available, definitely they will treat these patients. And if not available, then certain time these patients are referred to the different institution. Referral not a problem. Problem is right time in the golden hour that we are missing. I have seen so many patients. They have not treated at the right time at the right things. That is the problem. So we have to extend the support, or when these poisoning actually where it is not in the metro cities. We have to understand this poisoning in rural or semi-urban areas. And the rural and semi-urban areas, availability of standard of care still challenging in India. Probably in Tamil Nadu it is not there, but you go to so many states where the standard protocols or the treatment in the semi-urban or rural area getting a challenging always. There is a problem. And most important, again, awareness not only among the public, even the doctors, even the healthcare providers. It is very important. So, like we have learned about diabetics. We have learned about cardiology, coronary artery disease. We have learned about stroke. We are learning about trauma management. So same thing, we should talk about more about poisoning care. And it has to be expanded to the school, colleges, medical students. You see now how many medical students are dying, suicide. It is not only just poisoning or snake bite. It is also suicide, mental health. We should talk about mental health. So many doctors, even including All India Institute of Medical Science, every year you will find there is some getting All India Institute of Medical Science. It is so much challenging. Still people are dying. Our doctors are dying. You might have seen. I don't want to tell about.
Sir, that is very true. Absolutely true. We are running out of time. So let's wind up this session. And I'm actually thankful for your insight, especially giving some protocols and your A to Z tables, all that information, and inviting for the conference also. I'm thanking you, the organizers, for undertaking this convergence symposium, and thanking Dr. Senthil, Dr. Gerard, Dr. Mukesh, the entire organizing team for giving this opportunity. So let's close this session with the want of time for the next session. Thank you.
Thank you. Thank you, sir.
Thank you, respected speaker and the respected chairperson. Dear online delegates, now we'll proceed with the inauguration function. I request all of you to kindly attend the inauguration function, after which the third session will start. Thank you.
A very good morning to everyone. I am Dr. Aravindan, Senior Resident and Treasurer of the Organizing Committee of the event. On behalf of the Department of Forensic Medicine and Toxicology, AIIMS Madurai, we are deeply honored by the presence of our esteemed dignitaries, guests, faculties, resident doctors, speakers, and delegates of the event who have joined us online. To begin our program, I request everyone to please raise for the Tamil Thai Vazhtu, followed by Vande Mataram.
அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை நிரம்பியந்து செயல் மறந்து வாழ்த்துதுமே
वन्दे मातरम् सुजला सुफला मलयज शीतला सस्यश्यामला मातरम् वन्दे मातरम् शुभ्रज्योत्स्ना पुलकितयामिनी पुल्लकुसुमित द्रुमदलशोभिनी सुहासिनी सुमधुरभाषिणी सुखदां वरदां मातरं वन्दे मातरम् वन्दे मातरम्
Today, the Department of Forensic Medicine and Toxicology of AIIMS Madurai feels proud to organize the National Online CME on Forensic Toxicology from Theory to Practice. We have come together to exchange insights and enrich our knowledge in forensic toxicology, connecting theoretical concept with the real world practice. I am pleased to inform that we have received an overwhelming response of more than 300 participants from all over the country and more than 80 e-poster presentations for e-poster competition under various categories. The participants include distinguished people from different fields of science, like forensic medical experts, doctors from various fields of medicine, judicial officers, and forensic science experts. We are truly honored to have each one of you with us on this occasion. Now, I'd like to invite the organizing chairman of the CME, Dr. Senthil Kumaran sir, Associate Professor and Head in Charge, Department of Forensic Medicine, AIIMS Madurai, to deliver welcome address.
Very good morning to one and all present here, both physically and virtually. I am Dr. Senthil Kumaran, Organizing Chairman. On behalf of the Department of Forensic Medicine and Toxicology of AIIMS Madurai, I extend my heartfelt thanks to each and every one of you for joining us today. I warmly welcome you to all to the National CME, Forensic Toxicology from Theory to Practice. The theme, Forensic Convergence, the topic was selected. It's formed with the aim of bringing experts together for integrating knowledge and bridging the gap between the theory and practical application in forensic sciences to enhance learning, collaboration, and advancements. This year marks as Forensic Convergence 1.0, focusing on forensic toxicology. And each year we aim to feature a new theme. This year's theme, Forensic Toxicology from Theory to Practice, emphasizes applying core toxicological principles to real-world forensic investigation, strengthening practical skills, accuracy, and evidence-based analysis. As a part of the CME, we conducted an e-poster competition on 19th and 20th November for undergraduate students, postgraduates, senior residents, and faculty members, which nearly 80 e-poster being presented. We are delighted to share that we received more than 325 CME registration from across India. We take this opportunity to thank our President, Professor Dr. Prashant Lavania sir, and our esteemed Executive Director, Professor Dr. Hanumanta Rao sir, for constant support and encouragement in arranging for this conference, CME. I also take this opportunity to welcome our faculty in charge of research, Dr. Mangair Garsi Madam, for his constant support and encouragement in organizing this program from the beginning. Welcome you, ma'am. I also take this opportunity to welcome Dr. Ramesh sir, Academic Registrar of AIIMS Madurai, for his support in organizing this conference, CME. And hereby I also welcome Dr. Manigandan G, HOD of Forensic Medicine, JRMC Medical College, Ramanathapuram, for his constant support and his encouragement in conducting this CME. I extend my warm welcome to all speakers, chairperson, participants joining online, and to the faculty members, students, and staffs of AIIMS Madurai. We welcome you all. Thank you.
Thank you, sir. Now I request the respected dignitaries to join in lightening the Kutvilaki. request Dr. Senthil Kumaran sir to felicitate our faculty in charge research, Professor Dr. Mangayat Karasi ma'am. Now, I request Dr. Senthil Kumaran sir to felicitate Registrar Academics, Dr. Ramesh sir, Additional Professor and Head, Department of Pharmacology. Thank you, sir. Now, I request Professor Dr. Mangayat Karasi ma'am, in charge research, felicitate Chief Dr. Manikandan sir, Head in charge of Forensic Medicine and Toxicology, Government Ramanathapuram Medical College, Doctor. Thank you, ma'am. It is now my great honor to acknowledge and felicitate members of the event organizing committee. Firstly, I request Professor Dr. Mangayat Karasi ma'am to felicitate the organizing chairperson, Dr. Senthil Kumaran sir, Associate Professor and Head in charge, Department of Forensic Medicine and Toxicology, AIIMS Madurai. Next, I request Professor Dr. Mangayat Karasi ma'am felicitate the organizing secretary, Dr. Gerald Evnath, Assistant Professor, Department of Forensic Medicine and Toxicology, AIIMS Madurai. Next, I request Additional Professor Dr. Ramesh to felicitate the Joint Secretary of the Organizing Committee, Dr. Mukesh, Assistant Professor, Department of Forensic Medicine and Toxicology, AIIMS Madurai. Thank you, sir. I request Additional Professor Dr. Ramesh to felicitate the Treasurer of the event, Dr. Aravindan, Senior Resident, Department of Forensic Medicine, AIIMS. Thank you, sir. I request Additional Professor Dr. Ramesh to felicitate the DO of our department, Department of Forensic Medicine and Toxicology, AIIMS Madurai, Mrs. Tampa Ilakia. Now, I am glad to invite Professor Dr. Mangayat Karasi ma'am, Faculty in Charge Research of AIIMS Madurai, to deliver the inaugural address.
Respected President, Professor Prashant Lavania, respected Executive Director, Dr. Hanumant Rao sir, the organizing chairman of this event, a wonderful event, Forensic Convergence 1.0 from Forensic Department of Forensic and Toxicology, Dr. Senthil Kumaran, and the Secretary, Dr. Gerald Pradeep, and Joint Secretary Mukesh, and the Treasurer Aravindan, the team. And I welcome Professor Manikandan from GRMC, the Department of Forensic and Toxicology. On behalf of AIIMS Madurai, I welcome you. Respected Professor and Head, Department of Pharmacology, Dr. Ramesh is also a medical registrar, and the Administrative Registrar, Mr. Agilan, and other professors, Dr. Venkatesha, and other senior faculty members, assistant, associate, and additional professors, and junior and senior residents, and also the students. And I also welcome all the speakers, the wonderful speakers of this event, Professor Krishnadat and Narendranath and Dr. Senthil Kumaran. Again, he is a speaker today, and Professor Kusha Kumar Saha and Dr. Venkatesh and Dr. Manivasagam and Mr. Shanmugam. And they are also conduct the panel discussion with the eminent speakers. So it's a wonderful theme and wonderful program, CME. They included many eminent speakers from all over India, from AIMS, Raipur, from Jipmar and Meenakshi Mission from Madurai state government and also the national level. And from Emergency and Critical Care Manian Medical Center, and from Jipmar and AIMS Kalyani, and also the government Mohan Kumaramangalam Medical College and Viluppuram Government Medical College. So I welcome all these speakers, eminent speakers. The forensic and toxicology department is very, very important and is very crucial dealing legal procedures of a medical institution. So we cannot avoid we know the importance of the forensic and toxicology department in every crucial steps of dealing the medically relevant, identifying the victims and to tackle the legal procedures. We have to go to forensic and toxicology department. In this way, you all must know the importance of the forensic and toxicology. So everyone must have the knowledge of related to medical relevant knowledge about forensic and toxicology. In this way, the eminent and wonderful speakers are going to share their experiences in this meet. So here, more than 320 registration have done already all over India, the participants. So I appreciate all the delegates who are participating in this CME. So this is actually because of more than it's not easy to conduct this type of, though it is an online, it is not that much easy. He has done work for, this team done work for past 1 month and to do the online program and collected all the speakers, requested speakers to participate in this. So it is a very, very challenging and completed and successful program in a resource limited place where we are staying in government medical college. So in this way, give a big applause to the team under the head of Dr. Senthil Kumaran, Jarab Pradeep, Mukesh and Aravindan. So I also appreciate all the delegates who are joined with AIMS Madurai and participating in this CME. So thank you one and all. Thank you and welcome to AIMS Madurai. Thank you.
Thank you, ma'am. Next, I request Additional Professor Dr. Ramesh, Additional Professor Dr. Ramesh, Professor, Additional Professor and Head of the Pharmacology Department to deliver the Guest of Honor address.
Good morning, one and all. Good morning, one and all. At the outset, I congratulate the team of Forensic Medicine and Toxicology, AIMS Madurai, under the leadership of Dr. Senthil Kumaran, for organizing this national online CME, Forensic Convergence 1.0, with the theme Forensic Toxicology from Theory to Practice. For the last 3 days, it has been an academic feast with so many scientific presentations as e-posters on original research articles, reviews, case reports, and case series. And today, we are witnessing the eminent speakers enlightening us with their vast knowledge in diverse areas like clinical forensic toxicology, current trends in acute poisoning management, diagnostic imaging of toxicological importance, clinical relevance of toxicology in the CBME curriculum, postmortem diagnosis of unusual poisons, forensic reasoning in alleged poison poison deaths, and challenges in toxicological analysis of hospital samples. These topics reveal the scope and importance of forensic medicine beyond the conventional boundaries. I hope all the delegates from across the country are able to enjoy this scientific feast. Once again, I congratulate the Department of Forensic Medicine and Toxicology, and I thank them for having given me this opportunity. Thank you all.
Thank you very much, sir. It gives me a great pleasure to invite our chief guest, Dr. Manikandan sir, Associate Professor, Head in Charge, Department of Forensic Medicine and Toxicology, Government Ramanathapuram Medical College and Hospital, to deliver chief guest address.
Good morning to all the respected dignitaries, judges, esteemed colleagues, faculty members, resident doctors, and delegates. It's an honor here today for Forensic Convergence. The theme of forensic toxicology from theory to practice is both timely and vital. This is an era where patterns of substance use, poisoning, drug abuse, and chemical exposures are rapidly evolving. The bridge between academic knowledge and practical application has never been more important. The term forensic toxicology stands at a unique intersection of medicine, science, and law. Actually, what begins as a microscopic module contributes to macroscopic consequences in medical legal investigations. The transformation of theoretical principles, absorption, distribution, metabolism, elimination into actionable interpretations at the crime scene, autopsy table, and courtroom is what defines our discipline. Today, we celebrate not the science, but also the people behind it, mainly the forensic medical experts and the toxicological professionals. However, as we all know, the journey from theory to practice is neither automatic nor easy. Actually, it demands an continuous skill development, updated protocols, quality assurance, and also very important is the interdepartmental collaboration. As science advances, so must our approach also. Whether it is validating advanced chromatographic mass spectrometry techniques and other methods for improving the chain of custody documentation, strengthening the interpretation of various body fluids like vitreous, cerebrospinal fluids, and even tissue analysis also. All these things contribute to the larger goal, that is delivering justice to the people. I congratulate the organizers for bringing together such a meaningful convergence of knowledge and experience. May today's celebrations ignite new ideas, strengthen collaboration, and push boundaries of what forensic toxicology can achieve. Thank you, one and all, and wish the event a great success. Thank you.
Thank you very much, sir. Now, we arrive at the most awaited moment of our program, the prize distribution ceremony. Let's begin celebrating the extraordinary achievements of our students in e-poster competition. I request Dr. Manikandan sir to distribute the prize. The third prize is shared by Mr. Now we arrive at the most awaited moment of our program, the prize distribution ceremony. Let's begin celebrating the extraordinary achievements of our students in key poster competition. The third prize is shared by, I request Dr. Manigandan sir to distribute the prize. The third prize is shared by Mr. Aman Panchal and the team of Ms. Lakshmi ji and Mr. Jalal Dattarwal. Next, I request Dr. Ramesh sir to distribute the prize. The second prize is shared by Mr. Mohit Verma and the team of Mr. Kodali Sampath Ritvik and Mr. Merjan Azam. Next, I request Dr. Mangai Karasimam to distribute the prize. The first prize is shared by Mr. Darshan Thakre and the team of Mr. Devananda Nair and Mr. Priya Soni. Thank you, ma'am. Now, I invite Dr. Jalal sir, Assistant Professor, Department of Forensic Medicine and Toxicology, to deliver the vote of thanks.
Good morning to all of you. Good morning to all of you, respected dignitaries on the dais, beloved faculties, administrators, dear students, and the online delegates. We thank all of you for attending this CME. I would like to extend the message and wishes of our beloved Executive Director, sir, and our beloved President, sir. Even though they are not available here, they have shared their best wishes and messages and blessings for the grand success of this event. Thank you, sir. Now I'd like to thank the organizing team, especially our beloved HOD, sir, who has made this idea into reality within a short span of 1 month. Even though it was in one-day online CME, all of you are aware, it was a 3-day event. We are able to gather people from all over India for their presentations. And next, I would like to thank our Assistant Professor Dr. Mukesh, who was the backbone behind this entire Zoom network. Without this, the CME, online CME would have been possible, supported by Mr. Maniarsa and his team. Next, I would like to thank our treasurer, Dr. Arvindan. Even though he is a senior resident, his ability to manage all the events, the financial aspects is truly astonishing. I like to thank Dr. Arvind at this point of time. Supported by our excellent DEO, Miss Tamilakya ma'am. So whatever we tell her, she will execute it. No need to follow her anything behind. So we have such a capable DEO as a backbone of this event. And I like to thank all of you with a special word of mention about the chief guest. Dr. Manikandan was the first PG of JIPMA. So when I joined, sir was the completed his post-graduation, joined as the senior resident, as well as Sendil Kumaran sir was the first senior resident in JIPMA. So both of them are my seniors. And I became the senior resident. Dr. Mukesh joined as the junior resident. So we all know together, and as by God's grace and by thing, we are all again connected here in AIMS Madurai. And I'm very happy to have Manikandan sir. He has guided me in so many ways, and Sendil Kumaran sir, in academic as well as in many aspects. So it is indeed a very happy day for me to meet all of you. And thank you, one and all.
Thank you very much, sir. And now I request everyone to raise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you.
Thank you.
Thank you, ma'am.
In another 2 minutes, we'll resume. In another 2 minutes, we'll resume again. Just 2 minutes.
Respected delegates, we will resume the scientific sessions shortly. So we request you to kindly wait patiently for a few more minutes. Thank you.
Just ஒரு ஷேர் பண்றதுன்னா சொல்லு அவர் ஷேர் பண்ணுவாங்க.
ஓகே.
ஷேர் பர்சன் யாரு இருக்கு? தமிழ்
So dear delegates, we welcome you again for this scientific sessions. I thank all of you for attending this inauguration function. So the third topic for today's CME is titled Diagnostic Imaging of Toxicological Importance. First of all, I like to call upon the chairperson for the today's session, Professor Dr. Tamil Mani sir. Sir is currently heading the Department of Forensic Medicine at Tanjavur Medical College, Tanjavur, Tamil Nadu. So good morning, sir. We welcome you in spite of busy schedule to chair this session. Thank you, sir. It's a time and my pleasure and honor to invite the guest speaker for this topic, Dr. S. Sendil Kumaran. Sir is currently the senior consultant and head Emergency and Critical Care Center, Manian Medical Center, Erode, Tamil Nadu. Sir has a vast professional experience. Sir has completed his Masters in Emergency Medicine from Ramachandra Medical College and Research Institute, Chennai. Sir holds an extinguished gold medalist of his batch. Sir also has Diploma in Accident Emergency Medicine from Ramachandra University. Sir has also been a gold medalist in his batch. Also, Sir has acquired his fellowships in critical care from Australia, Singapore, and Vienna. Fellowships in neurointensive care from the Walton Center of Neurosciences, Liverpool, UK. As I previously said, Sir is currently the medical director of the Manian Medical Center, Erode. Sir is an extinguished member in various professional bodies and has accredited over 300 scientific publications in national and international levels. Sir has been conferred with the prestigious fellowships of the Royal College of Physicians of London and Edinburgh. With this brief introduction, now I request the guest speaker, Dr. S. Senthil Kumaran, sir, to start his address. Sir, you can start sharing your PowerPoint, sir.
Very good morning to one and all. At the outset, I thank the organizing team, Dr. Senthil Kumaran, and this energetic team for giving this wonderful opportunity. And my respectable wishes to my chairman, Tamil Mani sir. With this great introduction, and thanks for this, I'm going to share imaging in clinical toxicology. Is my slide visible, sir?
Yes, sir.
So in emergency, Dr. Narendra would have given a broad outlook what the general management of poison patient has to be done when the patient comes to the emergency. So the imaging is a routine part of and parcel of the practice of the emergency team. So any trauma patients or any blood pressure patients.
Your voice is not clear, sir. Just you have to increase your sound, sir.
Am I audible, sir, now?
Yes, sir. Now it's clear, sir.
1 minute, sir. So many times we used to take a lot of imaging, but coming to the clinical toxicology, very limited imaging used to be done. But for medical legal purposes, and we should know when to take and when it is critical. Okay, and the patient gives you a unreliable clinical history. Recently, we had a patient who had an altered mental status. They didn't give a proper history. The attendants and bystanders were telling he went to home sleeping in the night, wake up with the altered sensory. We couldn't able to find out what is this, but imaging gave a clue that it is due to some poisoning. So like that, when there is a suspected any internal injection of being given or altered mental status, then we can consider about using an imaging. And then we are also having some suspected complications. Not only the cause and the effect also we can be able to identify with this like aspiration pneumonia, any pulmonary edema, salicylate overdose, we used to see a lot of pulmonary edema, or gastrointestinal perforation, or any other toxic sequelae. And treatment guidelines, whether the right tube is in or whether the right tube is in the lung, there are a lot of other complications or subsequent follow-up of an antidote administration or any surgical intervention is needed. The decision can be made by doing this imaging. So imaging as such, we have been taught first is the basic imaging, chest X-ray. So chest X-ray, why we prefer chest X-ray? As we well know, it is readily available. It's very cost effective. Immediately we can take and we can see and no need any specialized training because our medical school we have been taught and trained to how to read X-ray. So it will be easy. And very important in the clinical toxicology, we can detect all the radio-opaque substances. So whenever there is, you suspect the radio-opaque substances, recently we had a patient who had broken glasses. Okay, and the patient has swallowed the glasses because of some psychological illness, and the patient was brought to us, and we took an X-ray. I will show the X-ray. Lot of glass particles are inside. So he underwent the surgical removal. So this will help you out. So advanced imaging like the CT and the MRI is very, very crucial, and it is very fast, and we need a technical thing, and the infrastructure has to be there. So whenever there is a complex toxicity or multi-organ involvement or neurotoxicity, or we are doing for any surgical interventions like perforation or esophageal, esophageal fistula removal like that, then we can think of this higher end. Otherwise, just a plain radiograph X-ray will give you a lot of clue. You'll see that. So for the best of practice, we can have this mnemonics, chips and chloride. This can be used as a mnemonics. It can be either one can be kept. Chips is nothing but chlorhydrate or chlorinated hydrocarbon. Heavy metals like lead, mercury, zinc, or any iron supplement or iodinated compound. Potassium salt or phenothiazine. Phenothiazines are very common. When I started making the practice 30 years back, we used to see a lot of phenothiazine overdose, and now it is reduced because of newer antipsychotic drugs. Entry-coated tablets are sedatives, especially when they are extended release or when they are in the special preparation. We used to see this in the mnemonics we can see. And easy things, we can also have another mnemonic which very commonly can be memorized for MCQs. Chlorhydrate, lithium, opioids like a body paper, radio opaque contrast dyes, iodinated compound, then metallic substances, and entry-coated preparations. So this will give you a clue, and we can able to find out. So with this, I'm going to share some cases which we encountered recently in our emergency room. Okay, this is a 2-year-old girl was suspected as a coin injection. Okay, and this was done in her grandmother's house. Usually, the toddlers, people that they are in the grandmother's house, they are more prone to explore lot because of over patterns from the grandparents. They will try to explore everything, and their grandmother witnessed that she has found something, and it was round. So they thought that it is suspected coin. Okay. So when we took a X-ray, and my resident told her, yes sir, coin has been there. Then I asked her to send the X-ray, and the X-ray you can see any thing you can think this coin, 5 rupee coin or 10 rupee coin or 20 rupee coin. Actually, it is not a coin. It is a disk battery. Okay, alkaline battery. Okay, how to differentiate between this coin or it is a disk battery? Why we are worried? As an emergency physician, my concern is more because if it is a battery disk injection, okay, this will produce a catastrophic event because of discharge of this alkaline causing perforation, esophageal perforation, forming esophageal fistula or media stenosis. Okay, just you can think this is called as a tip of edge. Okay, the coin will have a smooth edge. If you see, observe this is called a step up. Okay, step off edge. Whenever you see a step off edge, it is not a coin, it is a disk battery. Okay, this is called as a halo sign, double halo sign. Okay, you can see double halo sign. This ring one inside and another ring. So this will produce only in the disk battery. Okay, so this battery, three things has to be, three ends are the, remember, one is narrow end, negative pole, and the sign. Okay, so this will produce this. I'll just show you a small video of this baby. So if you leave it for a long time, what really happens is this will erode and try to cause a perforation. So it has to be removed as early as possible. So the simple dictum is, if the battery is seen in the esophagus, it has to be removed immediately. If it is in the stomach, we can wait and watch. Okay, this is a message from this case. So this is when I was posted in the airport. So a 35-year-old male was detained by the customs. So when we are in Ramchandra, we had a critical posting in railway station and airport. At the time they brought us. So their complaining was only severe abdominal pain, and they had some suspicious travel history. So we did a line X-ray there, and we saw this. This was considered to be one of the costliest X-ray in my life. Can you guess what is the work? It was in 2005. This X-ray cost was almost 85 lakhs. Okay, so it is nothing but a body tracker. So initially there was a confusion whether it is a body pack or something else. So it can be easily identified by a double condom sign. Okay, whenever you see this is called as a double condom sign. I will show you very another in X-ray. So this is called as a tic-tac sign. Okay, you can see this is a tic-tac sign. This sign should be there, and after giving enema and bowel evacuation, and we able to evacuate almost 54 intact signs of purest form of cocaine. Okay, so this is from another case. Okay, this is a female, that is a male. Two people in my career I have seen the body tracker. Okay, so the important thing of this body tracker is this imaging will save the smugglers before the top is spread. Okay, this should be removed. Okay, so the idea behind the smugglers carrying this is maximum 24 hours. Within 24 hours, we should be emptied and we should be removed. Otherwise, this condom can rupture and the cocaine can enter. That was in the Tamil movie, where the Surya's friend was able to explore the cocaine from this condom, and then he went for a cocaine toxicity, and then he will die. Okay, so that kind of things are being seen witnessed in a lot of literature as well as the travel medicine. Okay, so third one is this is recently happened after Kalakuchi incident. This was happened in our place. A bunch of comatose patients were brought to the emergency room with severe metabolic acidosis. And two of the people were telling that I am not able to sleep properly, and they are complaining of blurring of vision. Okay, so immediately we were suspecting comatose, metabolic acidosis. So we did a osmal gap was elevated, so this was fitting into a toxicology. So we did an MRI. MRI was characteristically consisting of methanol poisoning. I will show you this. This is called as putamen necrosis. Okay, this is in T2 imaging, and this is in the file. You can see a classical point of necrosis. This was in the first patient, and this was in the second patient. You can see the second patient as the time evolved. This was first patient was 12 hours. Second was presented to us after 15 hours of ingestion. So this is a classical case of putamen necrosis, and this is causes. And if you trace this, the optic nerve thickening will be there, and optic nerve changes can be witnessed whenever we see this kind of methanol poisoning. This is from Sipcot, Erode Periphery Sipcot. We received a 6-year-old child. Actually, the entire family is migratory workers. They came 7-8 years back, and the child born in the Erode, and then the child was playing there around the spot only. And the one important thing they came to us is to our pediatric department is growth retardation and complaining of pain in the wrist and knee joint. Okay, so when we took an X-ray, it can see the X-ray. This is called as a Harris line. This is a pure radio opaque line. This will tell you the growth arrest. Okay, and this is considered to be one of the pathognomonic for lead toxin. The other important thing is called as zebra stripe sign. You can see in the wrist of the metaphysis area, you can see both Harris line as well as the zebra stripe line. So once you see the zebra stripe line, you can examine the oral, you can see the lead line. So this will tell you that these patients are being exposed chronically to the lead poison. And before, and I'm telling you about 15 years back, all our pains were containing lead. Okay, so the child used to take like a Pica syndrome. They used to swallow and they come with an abdominal pain. When we take an X-ray, they show a typical various pieces will be settled in the radio picture. So that will tell you that the patient is being suffering from a lead toxicity, and then we have to start treatment. Otherwise, it will start a problem. So chelating agent has to be started at the early. So this is a positive job. This is very common in the 2000 before millennium. It was common in the 19th century. It is very common in the fire workers. But recently we are seeing, and my wife is an oral pathologist, and used to see a lot of patients with this kind of osteolytic lesions, especially these patients who are being treated and survived from the yellow phosphorus. So just remember, jaw removals, the liver has survived, but it gets being attacked. So this will tell you the delayed consequences of the acute toxic exposure. Okay, and this is very common in the pediatric emergency as well as in other emergency rooms. Child is playing, especially in the summer time. They used to store the kerosene in the food drink bottle. Just like that, kids will be busy and then they will come to the emergency room. It's very panic. So immediately if you take an X-ray, this will not help you out. So you should know the protocol when to take an X-ray and when to do a further imaging in the patients with the hydrocarbon poisoning, chemical storm. So whenever you take, you can see there is a bilateral patchy area opacity, very characteristic like a ground glass. Okay, so before getting any lab features, the X-ray will give you a clue. Okay, so this is an X-ray just 30 minutes before the injection. Okay, can you able to see any abnormality? No. It looks like a real normal, near normal X-ray. The same patient, after 6 hours, you can see there is an increased opacity in the perihilar region. So once there is increased opacity in the perihilar region, this patient is going for a lipoid pneumonia. So after 6 hours, you have to do a X-ray. This is a X-ray after 24 hours. You can see there is a change, and the CT classically show you the lipoid features of the lung. This is due to hydrocarbon. Even though the hydrocarbon patient has not vomited or not aspirated, microaspirations are very known complications of hydrocarbon toxicity. So don't send the patient without documentation. So the patient has to be observed in the emergency room minimum for 12 to 24 hours and do a X-ray after 6 hours and then 24 hours, and show that there is no progressive changes in the lung parenchyma, and then you can safely send the patient out. This is very common scenario happens in the emergency room. Drinking in the bathroom cleaners, any corrosive, it may be an acid, it may be an alkali. Most of the time in the bathroom users are alkali. And when the patient comes, entire oral cavity will be charred or swollen, the airway cut will be there. So when we take directly here, we should not take the patient for an X-ray unless there is suspect pneumomediastinum or any pneumothorax or any perforation. You can directly go for a CT to grade the injury. So esophageal walls, Nigeria has classically graded the corrosive injury to 4 classes. Based on that, the treatment and other modalities will be there. So with this CT scan, we can help to map the extent of injury can be mapped. If you want to do a upper smoking, it has to be done immediately, otherwise it has to be done after 22 hours. In between, you should not do because it will cause an hypergenic perforation. So CT should be done always before the stroke, and then you know the thickness and to know whether there is any other injury is there. So this is a patient. This is a female patient. What was in a gasping stage? We intubated this patient, okay, and then we put a central line. And then air entry was low, so this was done by a resident. So I called him and I told that, see, you put a central line, this patient has got a pneumothorax. But actually, the patient's old X-ray itself has some sign. This is called as a deep sulcus sign. It is a subtle sign saying you that this pneumothorax has been happened already. It is not due to hypergenic of putting a central line. This will medical legally save the doctor. So if you are able to document the deep sulcus sign, it will give a clue that the patient has been already having a pneumothorax. This is another patient who had a pneumomediastinum. You can see a surgical emphysema. So this surgical emphysema, the tracking of the air into all our subcutaneous tissues, this will dissect the subcutaneous plan and enter up to the face. You can even see a facial swelling. So this will give a clue that this patient is having a esophageal or pneumomediastinum, esophageal perforation or pneumomediastinum. You can see this is a subtle sign. So the early sign you can watch here, not extensively you need to see. Even a small sign if you see, you can able to see this. So this is the first patient. You can see lot of surgical emphysema of the pneumomediastinum is being noted here. So this CT will help you out to identify the grading of the injury. So this is a case where you can see a esophageal perforation. You can see and the air leak and the pneumomediastinum, and you can see the air around the heart. Mediastinum you can see. I'll just play a small video clipping of this patient. So this is a video of a patient who have been taken a corrosive. Sorry, it's not playing. So this is a very interesting morning. I told you, that recently we had a family, a group of people came with saying that the patient was being apparently right, went to home, and then early morning he was not able to overcome that thing. So initially we thought it is a stroke. So immediately we did a stroke protocol, and fortunately we were able to see that the patient was having a different change rather than a stroke. So it is nothing but carbon monoxide poisoning. After investigation, we found that the night there was a current cut, and he wanted to sleep in the AC room, so he put a generator outside the AC vent, and then he started. So the AC vent circled all the smoke from the genset, and it was circulating inside his room. Probably he would have asked for a carbon monoxide poisoning. After that, we did a hyperbaric therapy and other things. He was able to recover, but not completely normal before this incident. Still, there is some residual weakness was there. So this is a CT initially we took. So as a stroke protocol we took, we were able to see any early stroke signs like dense artery sign or any cut sign. But surprisingly, we were able to see at two putamen necrosis, globulus sign. So we did a MRI was done. MRI class B shows a bilateral involvement of the globulus. So this is a pathognomy for a carbon monoxide poisoning. So tablets is again common in the pediatric, usually iron tablets. When the mother is pregnant, the child are more prone to develop because this comes in a gem coffee like that. It is being there colorful, so it makes the toddler to explore more, and then they are taking this. You can see this was a child was being brought that he had stolen something. They didn't tell what is stolen, and when we took an X-ray, you can see a classical 3 iron tablet was there inside the thing, and it was very highly toxic. This is a shape the mother brought the iron capsule. It was similar to the same thing was being identified and then we removed endoscopy and then started on dextrostomine and depilation therapy was done, and the child was saved. And this was the last case. Many snake bite we used to see. We used to do an ultrasound to know whether there is any facial compartment edema, is there any progressive muscle necrosis, is there. Suddenly the CPK total will be high and the patient will go for a renal failure. So here it should not be think that the renal failure is due to venom. It can be due to a muscle damage, so increasing the total CPK. Or if you want to do any fasciectomy or any other amputation or a small surgical intervention, again we need a imaging. So imaging will tell you the unspread venom where it is located or any other thing. We have seen many patients with loculated insulin which causes the bolus. We can do an ultrasound and then see the surgical removal of that content. And we can do an MRI or a targeted ultrasound. This is one of the projects our research is doing about this. Iron and heavy metal toxicity is very, very common now. It is increasing. So this can be also be seen as a linear speed pattern like chip. And very commonly we are seeing used to see a bismuth compound. Okay, this will form a black tongue, and the patient will tell you I'm passing a black stool. This should not be considered to be a melanoma. And you take a CT images or X-ray, you can see a metallic density throughout the colon. Okay, due to want of time, I'm not showing all these X-rays, and it is very, very common. So very common in the pharmaceutical agents like potassium salt. Actually, I told you about the M3, and in case of button battery, do an X-ray. Methanol poisoning suspected, do an MRI. If you are suspecting any post rodenticide improvement, do a CT. Carbon monoxide, again MRI. Iron overdose, X-ray is sufficient. Hydrocarbon overdose or parapet, you have to do a HRCT. This will help you out to know. And we have seen certain cases like organophosphate causing neuropathy. When we did OP causing organophosphate, OP causing delayed onset of encephalopathy, where MRI will give you a lot of clues. Okay, so the delayed toxic encephalopathy, we do a MRI. Even certain patients, we have done the PET scan to identify is there any metabolic changes of this happened, especially in the Ayurvedic medications causing for a chronic thallium poisoning. We didn't check to know whether there is any metabolic changes of this there. And now we have incorporated in our hospital, we have incorporated A in the radiology department. So this gives little clue faster to think and proceed further. So this can be also a new area can be explored. So to conclude, so do a initial assessment and then you think whether the imaging is needed, then you take an imaging. Here the first priority is still airway breathing circulation and resuscitation. Imaging will help you out to interpret and to plan your treatment if it is warranted. Okay, so negative radiograph is not to say that the patient is nil of any toxicology. There are maybe radiolucent touch can be there, and single X-ray is single imaging will not give you a clue that this is okay. We need to take a serial imaging, and the clinical correlation is very, very important. Okay, otherwise just seeing this and don't treat the X-ray. Always treat the patient, and imaging will give you a clue definitely. So the clinical wisdom is a good toxicologist must think like a radiologist, and radiologist should also think like a clinician. So that's how in foreign country, first we have to go to a medical school, then only we have to go for a radiological program. Okay, so successful care and saving the patient again depends only on the resuscitation. This can be used as an adjuvant. Thank you for a wonderful opportunity. Thank you.
Thank you, sir. Thank you for your wonderful and very useful talk to that forensic faculties and clinical toxicology. Sir, I have a vast experience in clinical toxicology. I have presented more papers and research paper in publications, national and international level. Thank you, sir. Thank you for your speech, sir. Sir, audience, is there any question? You can raise your questions.
Sir, the questions audience can post in the chat box, sir, so that we can collectively discuss during the panel discussion at the end of the CME, sir.
Yes, sir. I have only one doubt from the sir.
Yes, sir. Yes, sir.
Whether that, suppose, sir, we are doing that vitropsy, whether that imaging study is enough to give the opinion or need for conventional autopsy to take sample for viscera and blood to send for laboratory to confirm the poison.
Actually, in a forensic base, we need a visa and the other thing has to be confirmed. This will help you out to narrow down your broad diagnosis. Imaging will help you out to reduce the thing. In carbon monoxide poisoning and all, you cannot be able to identify any visceral changes or any blood changes. At
Yes,
the time,
sir.
this will help you out to say that yes, probably this would be a diagnosis. Mental poisoning, if the time makes, as the time goes, the osmosis rate will become normal because of the metabolism. So we have to estimate the metabolite. So again, it is difficult that we don't have such a immediate access for the infrastructure. So at the time, this imaging will tell you that the most probably this will be due to methanol poisoning. So that will
Yes,
help
sir.
you out.
Yes, sir. Recent incident in the Kallakurichi itself, that basal ganglia necrosis in autopsy finding, but there is no CT finding, even though treated at Salem Medical College. So that time maybe the go for routine conventional autopsy and visceral examination. Yes, sir. Thank you, sir. Thank you for your good speech, sir. Thank you.
Thank you, speakers, and thank you for the chairperson. With this, we conclude this session. As we move on to the next topic. Yes. We move on to the next speaker for the today's session. Yes. So we move on to the next session. The title for the today's session, this session is the clinical relevance of toxicology in competency-based curriculum, a time for reboot. For this session, I would like to invite our chairperson, Professor Dr. Sanjay Gupta, sir, who is currently the Dean Academics of All India Institute of Medical Sciences, Rajkot, Gujarat. So, good afternoon and welcome you, sir, to chairing this session. Now, I would like to introduce our speaker for this topic, Professor Dr. Kusha Kumar Saha, sir. Currently, sir is serving as the Dean of JIPMER Karaikal. Sir has a professional experience spanning over 2 decades of teaching experience in forensic medicine. His medical legal expertise has played a vital role in helping the judiciary delivery system. Sir is a distinguished academician, has presented topics related to medical, legal, and ethical issues and in allied subjects at various forums. Sir is an expert examiner, chairperson, and member of Board of Studies in Forensic Medicine of several Indian universities, including AIMS, National Board of Examinations, and the UPSC, Union Public Service Exams. Sir currently holds multiple administrative positions, and sir is also member in various professional agencies and bodies. Sir is also the nodal officers for the INICIT and the INICIT SS super specialty and the NEET exams. Now I call upon Dr. Kusha Kumar Saha, sir, to kindly share his screen before starting his presentation. Over to you, sir. Shah sir, can you share your screen, please?
Okay, sir. You can share screen from your side, sir. Okay.
Good morning,
Sir,
sir.
namaskar. Kusha sir, namaskar. Good morning. Good afternoon, sir.
Shah sir, can you unmute yourself, please?
सर अभी आ रहा है साउंड?
Yes, sir.
Sir, आ रहा है. Good afternoon, sir. नमस्कार.
नमस्कार नमस्कार सर. अब आप तो पूरा फिट फैट होके बैठ गए.
Yes, sir. You are visible, sir.
Now visible, na?
Yes, sir.
Okay. So it is a full screen?
No,
Full
no,
screen,
sir. No, so make it into a full screen mode, sir.
Now it is full screen?
Yes, sir. Yes.
Okay. So very good afternoon to organizer team who gave me the opportunity to the topics of clinical relevance in toxicology in the competency-based curriculum and for the time to reboot. And also I thanks Dr. Sanjay Gupta, who will be the chairperson to find out any deficiency, can tell me that how to improve in these slides. So, and Dr. Senthil Kumaran and the team who is also given me the opportunity. So without delay, I will just starting my topics, the clinical relevance in toxicology, competence-based curriculum, and how to reboot. So before starting, you know that in the Indian scenario, there are so many colleges are there in India. Just 1 minute, sir. So many colleges in India where the MBBS seats are increased for 2022. If you see the 2025, the seats are increasing very drastically. Still, we are not providing the proper health care to the citizens or to the community in spite of increasing on the number of seats. And if you see that 61% seats are increased in the last 5 years. Even in the postgraduate seats, almost seats become double in the last 8 years in the both government and the private medical colleges. And the population still we are not achieved as for the WHO. Still we are lacking in that students, doctors and population ratio. So today's learning object is to understand the current structures of toxicology teaching under the Indian CBME systems. So my topic is today, the conference is related to toxicology. I am just giving my point only to the toxicology, not to the entire other subject of the forensic, and to identify the gaps in relation to the clinical relevance and discuss the interactive and competency-based teaching approaches. What are the other approaches which can helpful for making it more interest? Compare the Indian toxicology curriculum with the Western models and explore the strategies to modernize and reboot toxicology education in India. These are my learning objectives, and we can start the slides. So before starting, just see that there are different terms given in the books: forensic toxicology, medical toxicology, and clinical toxicologies. So if you see that they have the different roles. So we are dealing with the forensic toxicology and the medical toxicology, the clinicians, and clinical toxicology. Mostly we are confusing with the medical toxicology with the clinical toxicology. We are thinking that both the same doctors can teach, but clinical toxicology is mostly related to the scientific and research oriented, where the medical toxicology is mostly related to the clinical and therapeutics, and whereas the forensic toxicology is mostly related to the analytical, interactive, interpretative, and the legal aspects of the entire curriculum. And the focus of training in the forensic toxicology we are giving for the interpretations, and medical toxicology for the management, and clinical toxicology for the safety purpose, policy purpose, and the research purpose. So if I ask the one question, how confident you people are as a teachers to teaching or learning toxicology? It is very difficult to answer because our curriculum is so vast, but the subject of toxicology has given a very little importance in the teaching hours. So it is very difficult to or confident in teaching or learning the toxicology. If I asked in the three criteria, high, moderate, low, the answer will be vary from different aspects. In every 3 to 4 minutes, someone in India is exposed to toxic substance, medicinal, occupational, agricultural, and environmental. Every clinicians, they are facing the problems, medical legal experts, they are doing the postmortems, poison cases frequently. Still, paradoxically, toxicology training in India has not evolved with the speed at which toxic exposure are evolving. Every day, new drugs are available, new poison substances coming. Till we are in that old curriculums, we are revising the curriculum. It takes many times because the curriculum will be revised by the NMC, which takes times to revive. By that time, so many new drugs have evolved. So today I want to discuss why toxicology is clinically relevant, why India needs a curriculum reboot, and how we can align ourselves with the global standards in medical and forensic toxicology educations. So where does the current curriculum fall short? You see that there are three levels. One is the MBBS levels, where the MBBS teaching has been happened. One is the MD levels. Another is the currently so many 1 or 2 institutions where they started the DM started in the forensic toxicologies. So these are the three levels where the toxicology we are going to teach. The core concept for the toxicology, if you see the world scenario, is the evolutions drives the interplay between the toxicants and toxins and genoetics, defense mechanism, and justifies the use of model organisms. Biological informations, you want the difference between the genomes and the environmental exposure, drive difference in susceptibility and response to the toxicants, risk assessment and the risk management, which is very, very important. As a doctors, we are sitting here, epidemiology and historical events together with science drive regulatory response to risks to individuals and environment, system toxicology to different systems, organs, individuals, and ecological systems. Above the last, that is the pathway and transformation of energy and matter, which is a very, very important nowadays interactions of the different toxicants and organisms, which are described through the paradigm in the dose response, ADME, and toxicopharmacokinetic. These are the basic concepts of the toxicology, whatever, whether it is MBBS level, whether it is MD level, or whether it is the DM levels. And you can see that the circular can be issued by the NMC for the competency-based medical education. They are revising, they are asking to follow the certain competency which is asked by the uniform to make the uniformity to all over India. So today's contest is what is competency-based medical education? Shift from knowledge-based to competency-based training. Before we are just giving the theoretical knowledge. Till now also most of the places we are only it is theoretical, but we are in the paper. It is the competency-based medical education. Still we are trying to achieve that competency, but we are not in a position to achieve. Focus on knowledge, skill, attitude, and performance. We are providing the knowledge, we are providing the skills, but it is very difficult to assess at the time of examinations their skills and attitudes. Why toxicology matters in medical education? Because it is a part of the medical curriculum we are following, and the clinical relevance, poisoning, overdose, toxins, and medical legal cases. So many cases happen on natural death due to the poisons. So you have to follow certain rules and regulations as per the law of land. So toxicology is a core component of the medical educations. In competency-based medical educations, emphasis is on clinical relevance skills, and we are giving the relevance. When we are put that CBME curriculum, we are giving the relevance, clinical relevance skills and outcome. But why we are not able to achieve? That is the different debate. Indian CBME reform 2019 onwards aims to improve readiness of the graduates dealing with poisoning, a major public health, because we are receiving so many cases, poison cases every day. As for the students morning, I have gone through the talk given by the Narendra sir and as well as the Chowli sirs and Senthil sirs, because they have talked about the so many cases are coming. Still, we are not in a position to deal with the poisoning cases because we don't have a uniform standards. of education. Even the curriculum is there, everything is there, but we are not able to achieve. There are so many hindrances and barriers are there. We need to evaluate whether current training align with the real world needs and international standards. So why it is relevance? Because already I told that it needs a poisoning burden in India, because so many cases, not only in the case of the agriculture poisoning, there is a snake, there is a toxin, there is a biological welfare, so many different type of new drugs are available, poisons are coming to, you have to handle. Emergency medicine and the ICU, when the patients are there, you have to tackle, you have to manage, you have to do the management, airway management, antidote selections is very, very important. We have only that old systems we are following. And medical legal practice, if the case is medical legal, we have to follow the documentations, give the report, autopsy report, interpretation of the results. Everything is very, very important while we are dealing with the toxicology case, and the policy and public health. That is also coming into the picture. So the benefits of the competency-based assessment improve the clarity and transparency to the teachers, to the students, and to the society also, and more seamless personalization of the learning. Okay, it is not like one-way directed learning. It is the both the way the students can learn by themselves and help shift toward the culture of assessment. And you can assess the skills, you can assess the attitudes, whether the students came to that level or not. And students better understand their own learning profile, and they should also know that whether I have to able to manage the patient or not by this competency-based management. So now we have totally shifted from the traditional educational model to the CBME. You can see that the most important thing is the evaluations. Now we are mostly things is evaluated in the clinical settings by seeing the skills and attitudes. Okay, assessments, it is also done in a proper way. And pathway of learning is not hierarchical. Okay, students, they can take the time, they can understand, they can go to different. But in the case of traditional, we are teaching, getting only from the teacher, whatever the teacher said, we are learning. But now it is not like that. It is a teacher students, both the way. Okay, it is not one way directed. So why toxicology matters clinically? Already I told that toxicology is very, very important. Management of the poisoning or overdose to see the real world clinicals need. Okay, we cannot say that I have learned MBBS and I can do whatever I want, because you have to make your update by yourself, by knowing what the new poison substance is coming into this real world. And you have to deal with the real scenario. Patients, physicians must recognize, stabilize, treat, and refer the patient. Refer, it is very, very important. If that facility is not available in your centers, then you must have to refer, and what facility you have to provide the patients till the patient reach to the different other center. Then occupational and environmental toxicology. So industrial poisoning, you must know, these are so many public law issues are there. So knowledge is matters. Medical legal role, already told that as a doctors, you have to do the postmortems, you have to give the report regarding the unnatural death, interpret the results. Okay, in the case of suspected poisoning. So for that, the most important thing is you have to legal implications for collecting the evidence, sampling, and chain of custody. It is very, very important. If the chain of custody is break, then entire level what you have done for this case is totally not futile in front of the court. Public health and prevention role. Toxicovigilance. It is one of the most burning topic nowadays. Identification of poisoning trends and prepare the policies to prevent the poisons. And communications to the patients, to the relatives, take the proper consent, documentations, reporting to the toxicological case if it is required for the higher levels. The CBME curriculum has modernized medical education, but clinical toxicology remains underdeveloped with gaps. There is a nicely CBME curriculum has prepared by the NMC. But if you see that number of hours given to the toxicology and what, because it is only superficials, there is nothing not there about that how you are dealing with the patients, because there is no rotations of the roster of the interns and all these things is coming in this CBME curriculum. So clinical toxicology remain underdeveloped with gaps in skills, training, integration, real exposure cases, simulations, outcome-based assessment. Simulation, most of the private setups, I can know that they have the simulations because they have the NMC is mandatory. But most of the government institutions, you may not get the simulation systems because it is maybe whatever, maybe the regions, but it is very difficult. The students exposed to the simulations. Hardly anything they can be exposed, but not fully for these toxicology cases. So strengthening these areas is essential to produce doctor capable of handling Indians' high burden of poisoning. So we have to prepare doctors who can handle the high burden of poisoning cases that comes to our emergency department. Toxicology in India, CBAB curriculums, where we are lacking in the curriculum because insufficient exposure to the real poisoning cases during the training. We are not exposed to them, only theoretical. We are reading that this is the poison, this is the treatment, this is the postmortem finding, but actually we are not exposed to the real poisoning cases. Minimal hands-on training regarding the gastric decontaminations, airway management, antidote uses, limited interdepartmental teaching. Even the teaching is there, that is also not happening perfectly with the other department. Toxicology specialists are not there, medicine specialists, they are, that is in Western country, if you see, they have the specific toxicology specialist, but nowadays we are getting our toxicology specialist, and morning that AIMS Raipur also, they have started the DM course for last 4 years. They are also getting the toxicology specialist. I think that in future it will helpful as a leadership. They can act as a leadership to develop certain policies. Practical toxicology, interpretation, lab testings, it is rarely demonstrated. Limited emergency simulations and bedside teaching, already I told that, which we are very lack compared to the private institutions. Antidote knowledge often outdated or incomplete, or we are not getting the proper pictures, not taking interest to know that what are the newly developed antidote is coming to the world, and assessment often theoretical. So competency wise, we have a lack or missing in the management of the airway. We are not in a position to assess the scoring of the risk management. Antidote is where the patient is coming. It is very difficult to find out what antidote should be given. Communications with the family and the police, documentations, how to document, and the postmortem management in poison death. These are the competency where we are lacking. As a doctor, we are producing doctors. You can see that we have doctors about double the PG students and almost double the MBBS students are coming. Still, we are not in a position to produce a competent doctor who can handle all these things. Emphasis on the core competency. So we have to, now the times, we have to moving away from the exhaustive but less clinically relevant detail. We are teaching so many things which is not relevant clinically. It is only theoretical. So we have to come out from that. And we have to reach to the real world scenario, what is actually need to the public, to the society. And we have to change our mindset, and we have to adapt to include those modern topics to remain relevant to the current scenario. So if you are teaching the MBBS levels, we are giving the foundation of knowledge, integrated learning, but the problem is that it is so superficial. Most of the things are outdated. In the case of the MD students, we are giving the advanced training, medical legal exposures, but it is varies from different colleges across the India. Poor lab access. We don't have that toxicological lab. Hardly any institution in India having the toxicology lab. We don't have a uniformity. That access is not there. DM cases, hardly 1 or 2 institutions they started. It is a highly specialization. They are giving the leader of to the society who can handle, who can decide the policy. And it is a very limited availability, no uniform curriculum is there. And if you see the system wide, it is a strong clinical load for learning, but non-uniformity resource disparity is there in entire India to the different set of medical institutions. So however, significant inconsistency exists in the teaching, learning and assessment, and that leads to variation in curriculum that contribute to uneven competency in the graduates. So already I told that theory and the practical clinical exposures, there is a disproportionate So we are giving only theoretical knowledge and we are limited or no formal exposure to the clinical toxicology. There is a lack of hands-on experience contribute to the knowledge gap among the healthcare providers. And this is the way we have to develop our curriculums, when you have to identify what are the needs for the curriculum and who are the targeted needs assessment, who are the learners, what environment you are teaching, what are the goal and objectives, and what exactly what is your strategy, what you want to provide to the society, and how you are going to implement, what barriers, what resources you are required, and what administrative helps required in the curriculum, and how you are going to evaluate this curriculum, that is from the learner or from the doctors. That is also very, very important. So these are the certain things before starting or preparing the curriculum you have to keep in your mind. Then only that curriculum will be robust and it can be, you can align with the world scenario. So already I told that most important thing that in India, even we have a uniformity, everything guidelines is there, but lack of standardizations because it is widely variable to the different places. And this is the shifts of the theory and practice of medicine during the last decades. Now you can see that now we are little bit old to new shifting has been taken place from doctor-patient relationships, so and clinical retailing, doctor-society relationship, and medical educations. So we are shifted from the to evidence-based reasoning, analytical decision-making, acceptance of clinical uncertainty. So many things we have changed to the patient-related, patient-centered. Still also we are not achieved the uniformity. So there is a gap in the curriculum. We have to fill that gaps. There is a limitation in teaching learning because we have a little access to the labs. There is a assessment challenges. Mostly we are assessing through the theoretical knowledge rather than practical or skill or aptitude. And infrastructure and resource is very, very important disparity where the things has been stopped, because this is the one of the biggest barrier, infrastructures and resource for getting the good doctors to handle such type of poison cases. So these are the gaps and challenges. Limited time allocations for the MBBS curriculum. If you see that the time is allocated very less. Okay, compare. If you see the toxicology is one of the part, hardly any hours has been given to the toxicology to finish. Theory versus practice imbalance. While legal definitions and forensic principles are taught, practical clinical toxicologies may get less emphasis. If you see the syllabus, it is only definition, but hardly clinical toxicology importance is hardly it is given. Integration challenges, yes, there is a department where we can go to the integrations, but still also it has not happened thoroughly, and if it is happened also, it is just superficially. We are just for the paperwork we are doing. Faculty expertise and resources. Not all medical colleges may have the trained toxicologist or well-equipped toxicology lab, so there is a deficiency in the resources and the expertise to get from the toxicology experts from the experts. And assessment issues, competency assessment may focus more on medical legal knowledge rather than clinical management. Even we are taking our classes, even in the exams, we are giving just theoretical, only the medical legal knowledge rather than the clinical management or poisoning. We have to improve our areas and it should be included in the curriculum. The infrastructures is more important, well-equipped laboratories. And I know that if you see the entire India, toxicological lab is very, very poor developed in 80% of the institutes. Standardization of the curriculum and assessment across the different institutions is also differ, and we must have to standardize. If you see the practical records, if you see the entire India, all the institutions, they have a different type of practical. We don't have a uniform standard. We are teaching the same thing, but there is no uniform standardizations. Training the faculty for the latest development and modern teaching method, they have to take interest. They have to make their capacity building by going through the latest development, attending the conference, attending the CME. Own interest should come what they are going to training to the students. Before training, they should go through the slides or preparations and they should sit with others so they can get the knowledge. Okay, and last is the interns roles. If you see the interns role, they are just going to the department and they are just preparing their PGs, but they are nowadays no one is giving most important to the interns role. The interns should have to be rotated to the toxicology case, because if they are posted in the medicine, they are doing the medicine, but hardly any such cases they are looking after, like the toxicology or whatever it may be. But we have to be, there are certain guidelines will be there, at least minimum this much cases you have to go through in toxicology and all these things, and you have to assess their attitude management, whether they are properly doing or not, what antidotes they are selecting. So we have to be follow that one. So the field of toxicology is constantly evolving with emerging contaminants, new drugs of abuse, and advancement like nanotechnology and personalized medicines. So we have to develop, now you have to adopt to change the curriculum to the modern topics to remain relevant. Coming to the teaching methods, integrated learning, already I told that it is there as per the curriculum. Departments are there, but understanding and reduced redundancies can provide more practical hands-on experience. So we have to be combine other department also, emergency medicines, because it is limited now to the pharmacology or certain department, but you have to bring other department also to their expertise so that it can be properly integrated. Practical training, simulation, and case-based learning is more important rather than theoretical. So initial assessment to treatment planning, real-life case studies, problem-based studies, patient-oriented learning, all these are very, very important practical training. Assessment, fail to test for the applications of the clinical skills, involve multiple methods, direct observations, practical exams, reflective journals, evaluate a student's actual understanding and practical application to the knowledge. Summative assessments often fail to test for the application of clinical skills. Whatever test we are doing currently also, what examinations, the assessment we are following, we are never assessing the application of clinical skills. Even if you are asking any questions, it will be in the theoretical format. Faculty development, they have to change their mind, adapt to this new model, which requires skills in mentorship and continuous individual feedback is crucial for successful implementations. So this is one of the barriers for the development or to revise the new curriculum is the faculty. They have to be mindset. These are the teaching learning methods. We know that we are utilizing our head, hands, and the heart. 3H for knowledge, skill, and attitudes. Okay, which is very, very along with the ATOCM, which is also very important for the attitude development, skill development. And these are the 3-tier relationship training, trainers, and training towards the national aim. Okay, why you are getting training and what is our aim? What we can going to give to the society, to the nations. Okay, so these are the relationship, how it can be trained to the trainers, who is going to train, and all these things is measures with the goal of smart, specific, measurable, achievable, relevant, time bound. Everything will be time bound. It cannot be go for a longer period. Okay, so to get a guest graduates, medical graduates, you have to be within the time frame. We have to be the smart, specific, measurable, achievable, relevant, time bound things you have to provide. So these are the teaching methods. All of us know that we are following. Okay, in small group teachings we are doing, but still I do not know how much you are, because it's most of the places they are following this type of teachings, flip classrooms, skill labs. It is a private institutions they are doing, and these are the different way of teaching methods. Miller's pyramid, from nose to dose, because we know that top of the pyramid, if you do by yourself, by activity, by yourself, then it can be remembered for longer period rather than by just recalling. So it is one of the examples like integrated teaching models. We are also following, everyone is following the way the topic. Suppose it is a case of organ phosphate poisoning, pharmacology department can teach about the mechanism, atropine and agents. Department forensic can be teach about the medical legal documentations, medicine, EMS, can be teach about the ABS, ventilation, decontaminations. Community medicines can teach about the prevention and public health measures. But if you see the curriculum, it is only limited to the certain departments, not beyond the community medicine is hardly involved in the forensic medicine department in the integration teachings. So most of the times, either it is a medicines or pharmacology or FMT, it can be rotated among these three. So we have to approach to other departments. At least we can get certain new way of learning from them also. Activities, there are different way of activities to teach the poisons or toxicology, poison escape rooms, food poison simulations. You can give some simulation methods. So they have to identify, decode the poisons, what type of poison, mixed poisons you can give, antidote simulation cards, clinical toxicology, morning frowns. It should be done, peer role play, triage, communications, and the journals and emergency department exposures. These are the way you can develop more robust toxicologists rather than just graduates. So this is the assessment. We are following formative and summative assessments, which is done by everyone, but we are lag on the skills logbook with supervisor sign up. Skill logbooks, it is not there. We are just having our document, but in the case of the MD students, also they have the logbooks. We are we are signing, but we are not in a proper way. We are looking after their skills, their attitudes, how they are doing. Just they are at the end of the time of exam, so they're bringing and we're just signing that one. Okay, in the exams also we'll just superficially we are doing. We are not able to assess the skills and all these things properly. So that should be done properly, and request to all the who are watching these things, at least to maintain the logbooks with their skills and attitude. We have to follow day to day. Blueprint examples assessment. So many questions are coming, repeated in the theory paper, repeated in the practical record paper. So we have to prepare in such a way the blueprint that the entire things will be covered for the theory and the practical in a uniformity way. Okay, it should not be duplicity should not be there. And what portion will come, how much mark will come, what to be given importance, what area you have to give importance, theoretical, practical, management, all these things should be done before. Okay, so that it will be helpful, so that the students also know that I have to give importance to that area more rather than this area. If there is no blueprint, then there will be the confusion for the students, and he will learn whatever he wants, and finally they are not in a position to write actually what is asked in the questions in the exams. So it is a module supports acute organ of phosphate poison competency, early recognitions, atropine titration, ventilator support, teaching methods. We are putting as a simulation mode, video-based, case-based discussions. We have a case-based discussions. We are also teaching in the theoretical class case-based, but it should be with the real scenario. You take the students to the medicine department's bed where the person is there with acute organ phosphate poison. We can teach them assessment, not only the medicines, only teach only the toxicology, even the forensic doctors, they can also go to the bedsides and they can also teach. Assessment can be done by the documentation checklist, how they are performing, feedback from the faculty, all the residents who are there standing for looking after all these things. You have to get the feedbacks, then only it can be improved. Now coming to the Western toxicology education's overview. What I told now, it is the Indian scenario. If you see the Western toxicology, there the toxicology is taught under the emergency medicine, pharmacology, or dedicated medical toxicology department. Structured clinical toxicology rotations are there. There is here in Indian scenario, the rotations are there, interns are there, but there is no specific clinical toxicology rotations. They are gone to the medical medicine department, they have to rotate, but how many cases they are seeing, it is varies. Well-developed poison control centers integrated into training. We have a poison control centers, poison information centers, but most of the times we have not integrated to the department to these centers. Strong simulation-based education cultures. I told that it is all depending upon the resources, how we are getting. Mandatory competency is in antidote uses and acute poisoning management. Mandatory competency, antidote management is mandatory in the Western countries. And if you see the Poison Information Center in India, it is very hardly anywhere. You can see that only 8 or 9 places where you can say the poison centers, big poison centers are available. And this is the way how it flow, poison information centers. What Western medical curricula do differently? You have seen our curriculum, and if you compare with the Western curriculum, you can see that there, if you compare to the United States, they require clinical toxicology exposure in emergency medicine rotations. Simulation labs is there. Consultant services, the toxicology consult, separate consultancy service is there. Strong poison control centers integrated for training. And everything they have assessed through proper evaluations. United Kingdom, the same things. They have also patient safety, risk assessment, triage, everything we have, but they have a robust way how to manage integrated the teachings. Australia, they have the guidelines, database, models, they have disaster preparedness. If such type of cases, poison cases, disaster happen, they have a methodology, guidelines to prepare to handle immediately. And if you see compare the Indian competency-based medical education with the Western countries, it is I told that rotations, you can see that in Indian, as per that, there is no dedicated rotations, but if you see that Western country, it is a mandatory, poison centers not integrated. Here, Western country, everything is integrated. Okay, antidote training, it is variable. Mostly, if you ask the answer to the student, they will tell the outdated antidote. Western countries, they have a standardized evidence-based, okay, competency evaluations. We are doing agile written evaluations, but they have a simulation-based OSC evaluations. Skill assessment, limited. We have a limited skill assessment, but they have a competency checklist to assess the skill in the Western countries. So what does the world do differently? Global standards in toxicology educations. If you see that already I discussed about Australia, United Kingdom, United States, Europe. So what they do differently? They have a fellowship training program. Today morning also, Narendra sir told that there is a training program, fellowship training program they are also conducting, but it is only limited. If you see the Western countries, they have a more fellowship training in clinical toxicology. And they have the syllabus which is harmonized, uniform syllabus, everyone following, simulation-based training mandatory. Okay. And integration of all the poison information centers. So where we are lacking, these are the field where we are lacks in many pillars compared to the Western culture. So why Western system produce clinically competent graduates? Because these are the 4 important points. Based on that, they are getting the clinically competent graduates because they have the hands-on training, real-time consultation with toxicologists, they have the integrated link between the poison control centers, and they have the regular update their curriculum based on the evolving toxicological trends. But update of curriculum in Indian scenario is very difficult because by the NMC, it takes years to develop the curriculum. By that time, so many new things are evolved. So it is difficult here. So that is why continuous development in Western countries make the clinically competent graduates. So what we must to commit to bring our standards to globalized. So we have to ensure that we have the uniformity across the institutions all over India, skill-based rather than content-heavy educations, exposure to modern toxicological instrument, integrations across specialties, evidence-based digital first teaching, continuous faculty upskilling, capacity buildings. So this is required for us to make us as a global leader in toxicology training, not a follower. So we have to adapt, and the tools to strengthen our toxicology, strengthen capacity of regional poison centers for teaching, introduce mandatory toxicological clinical exposures, update curricula to include novel agents, chemical terrorism, occupational toxicology, incorporate algorithm-based management training, promote research and case reporting among undergraduates. We have to give more importance to the undergraduate level for research in toxicology, national toxicology fellowship integrations, and telemedicine we are following. We have to follow the teletoxicology service across the medical college. So we have to adapt to come and align with the Western system. So why a reboot? Now coming to the pictures, why reboot is needed? What are the key problems? Our curriculum is heavy on all these theoretical toxicokinetic, antidote list, poison classifications. All these things are loaded with our curriculum. Rising incidence of modern toxic exposure, novel psychoactive substances, industrial toxin, environmental pollutants, polypharmacy in elderly. Okay, so these are the key problems. Real world emergency decision making, stabilization steps, communication in poison cases, documentation and medical legal reporting. So these are the reboot is needed all these places because everything is loaded, but theoretically, but practically we don't have any how to manage and all these things properly. So these are the key problems where we need to reboot ourselves to current teaching does not reflect emergency patterns. Medical graduate must be prepared for emergency decision making. Lack of standardized national poisoning guidelines in teaching. Minimal use of stimulations, mannequins or high fluid scenario. Need alignment with global best practice. So this is why we need a reboot to make us as a health leader rather than the follower. These are the areas for the reboot, enhancing the clinical skills and practical applications. Here, these are the two areas where we have to reboot ourselves for in the curriculum. So if you see that, what should India's reboot look like? Common competency framework in all the level, MBBS, MD, DM. DM, they are giving us a leadership. MD level, interpret the lab result. MBBS, at least they can diagnose the poisoning. Integration with the emergency department, ICU, and establish the national toxicology skill and simulation labs. So this is the India needs reboot in the competency framework, integrations, and the skill and simulation labs, and strengthening the poison control centers, introduce the modern assessment tools and faculty development. Faculty development, the trained teachers in analytical toxicology, clinical toxicology, simulation teaching, e-learning modules. So for that faculty development, they have to shift the mindset. Training for faculty is necessary to implement a competency-based curriculum effectively and to shift the mindset from purely academic focus to one that values clinical applicability. So this is very, very important, faculty development. If faculty interest, then the things can change. If they have to change their mindset so that everything can be done very easily. Infrastructure upgradations. It is a very resource oriented. It needs for toxicology development and promote the research culture is going on, but so many areas, but we have to take decision that to make more toxicology oriented research in the different fields. So how to reboot and move towards uniform national standardizations? Already I discussed so many things, all the things I have discussed. Create a national core curriculum, establish tiered competency framework, introduce standardized national logbooks. Logbook is very, very important. Modernize teaching methodology, modernize assessment methods, mandatory rotations, which is very, very important for the interns as well as the students who are going for the different clinical postings. For them also can be made rotations to the toxicology cases. National resource sharing, promote research and innovations, digital learning tools, and periodic national auditing. So these are the area we need move towards for making uniformity. These are my recommendations to strengthen clinical relevance in toxicology for rebooting. Increased curricular weight hours for clinical toxicology, allocate more contact hours to poisoning emergency management antidotes, strengthening the integrations, bedside toxicology, shared case-based learning, develop clinical toxicology labs or tie up with certain other institutions, train faculty, assessment reforms, not just for medical legal theory, but other things, promote toxicovigilance and prevention. It is a very, very important. Toxicology vigilance and preventions which encourage students projects on local poisoning trends, prevention campaigning and poison centers. Policy advocacy, it is one of the last and medical education regulation to re-emphasize clinical toxicology in the next version of the CBME. So policy advocacy is very, very important by the ministry to develop to prevention of the poisons in the society. Benefits, what benefits if you reboot? You can get a better patient outcome, early recognition of the treatment, management, strengthening the public health, legal and forensic capacity, better prepared doctors giving medical legal opinions, improve justice, healthcare system readiness in mass toxic exposure, medical graduate competencies, skilled graduates become more confident clinicians, not just medical legal observers, alignment with global benchmarks and increased interdisciplinary collaboration. So these are the benefits. Once we have to be change our curriculum with the mindset to adapt all the policies and the tools, then we can get so many benefits. The most important is the patient outcome. That is the most important, which we need. By the doctors, the society needs that the patient should benefit it. These are the barriers and risk for the implementation. I know that resource is one of the most important constraints because lab development, simulation lab development, faculty resistance, some faculty, they will be not interested, see this add burden and beyond their specializations. Regulatory inertia, even if guided NMC revision may take time or local colleges may not adopt fully. Assessment load, more clinical assessment, add to exams and evaluation borders. So these are the barriers where it can stop us not to develop the proper uniform standardizations. So what outcomes is coming once if your curriculum develop reboot? You can see that MBBS levels, we can develop MD and DM level, we can develop, which is the roadmap for the national core curriculum. Okay, so these are the different levels where they have their different capacities they can learn. Okay, so if you reboot our curriculum in the toxicologies, then we can achieve more and we can become the align our standards with the globalized way. So these are the focus area. In the case of MBBS, they have to just learn about the poisons, toxidromes, sampling. MD, if you see that, they have to be learn about the equipment, instruments, how to interpret the results. If you see the DM levels, at least they can come to the ECMO, disasters, how to prepare, how to handle the disasters, toxicovigilance, policy decisions. So this capacity of learning will be developed in the different level if you reboot our curriculum. Competency-wise, MBBS can clinically recognized, MD level interpretations and DM level leaderships they can give the society. These are the action plans or roadmaps. If you start now, in certain years, you can achieve your results and you become the align your goals with the global standards. Stakeholder engagement from a working group, NMC is the one of the force which needs. Without that, we cannot change any curriculums. Pilot program, you can start with the 3 to 5 colleges teachings and then national curriculum revisions, faculty training, monitoring and evaluations for 3 to 5 years. Once you develop, then you can go for other implement to the other colleges. So these are the short terms, medium terms and long terms planning. By the times, if you start 1 to 2 years for curriculum revisions, rebooting, skill development, assessment reforms, then medium terms 3 to 5 years, at least you can strengthen your poisoning control centers, and the long terms you can strengthen the health system links with the every centers and like this. So these are the agency which is needed to help us in the reboot our competency-based curriculum. NMC is there, Ministry of Health and Family Affairs. These are the two forces which is without their help, we cannot change the curriculum, we cannot come to the globalized standards. Okay, our effort is also required, faculty effort is required. If you need a doctors, which are competency-based doctors, then we need all the teams works together starting from the curriculum development to faculty development to skill centers to assessment to digital toxicology to national audits. Everything required for a good curriculum to develop for the competency doctors to come out to treat a patients for Indian scenario. To conclude my sessions, toxicology is a critically relevant but under emphasis in current CBME. Indian CBME needs modernizations. Give real world poisonous burden, medical legal needs, and public health importance. A policy reboot is timely. Reboot requires practical hands-on integrated teaching, strengthening integrations, increasing hours, improving faculty capacity, and revising assessments can make graduates more competent. Simulation, cases, and OSCC should form the backbone of the training. Assessment must be competency-driven. Collaborative efforts between national medical commissions, college, and toxicology experts are needed. Toxicology exam must match modern challenges, uniform national system, and ensure trust, reliability, and safety. Reboot will improve healthcare, justice, and public safety. Standardization is not an option, it is a responsibility. So these are my references, and thank you. Any questions?
Thank you, sir. Over to the chairperson. Sanjay Gupta, sir.
Sir, good afternoon.
Good
Very
afternoon,
nice,
sir.
very informative and elaborative presentation. It reminded me about my medical education and technology
Yes, sir.
association for more than a decade. And you brought the many concepts like Miller's pyramid,
Yes.
CBME competency based, where you have specified some roles and goals and competencies, and ultimately you brought down to the SMART objectives, and then entrustable professional attributes and competencies. So, sir, very nice presentation. You also highlighted in your session about the difference between forensic toxicology, medical toxicology, and clinical toxicology. So some of us, many of us might be having, we are using these three terms synonym to each other without understanding that what is the domain of each of these area. And at the same time, sir, you also highlighted the challenges which
Barriers.
currently the forensic medicine and toxicology we are having, and all possible challenges, way forwards, how we can reboot, and comparison with the Western system to our Indian system. So very nicely presented. It's a sort of comprehensive presentation comprised of all aspects pertaining to the role of toxicology in curriculum and especially in our context. I came across some beautiful example from the integration like organophosphates. You mentioned that how we can fix up the role of pharmacology, even community medicine, community, and so how these things can be done. And beautifully you concluded that integration is in, it should be in the mind of the student. So holistically it can be designed if we involve the in interdisciplinary manner rather than teaching the student in isolation. So we can identify certain topics which can be integrated. Department can sit together, we can have the chai pe charcha, and we can fix up. We can share our objectives and competencies and work out with a lesson plan. Lesson plan, and subsequently for the assessment and other part, we can have the blueprint which you have shown in your presentation. That if we have the blueprint, the majority of our things would be sorted out, where you can get to know that these are the area which is to be must be ensured, and these are the area can be just left to the further readings. So weightage of each area, that this should be given the more weightage, less weightage, and then you brought this concept of the 6 steps in the process, where starting from identifying a problem to the evaluation based upon the maybe Kirkpatrick or other modules can be utilized for the evaluation. So, sir, wonderful presentation. Two things which you have frequently highlighted. One is mindset.
Definitely, that is the most important. That is the one of the biggest. That is the most of the important barrier in the any proceeding. That is the.
So very well pointed out, sir, and I'm completely agree with you, because if we the mindset is
and a resource.
something
Another is
which
the resource.
it can be changed. But probably since decades and decades, we are talking about some good things.
Yes.
But we are not changing our mindset at the implementation level.
Yes, sir. Because
So
they think it is an extra burden for them.
so we are considering that if we bring certain things like poison control center, information center, clinical toxicology in our setting, so it may be an extra burden to us. But beyond these boundaries, we are not thinking that this is our domain. In the morning also, Dr. Chavli has very specifically told that the toxicology is not a domain of medicine, neither pharmacology, it's completely our domain. That's why the NMC has mentioned this subject, forensic medicine and toxicology. And many times it's happened that we are ignoring the toxicology part, which is not in the best interest of, it's sort of that we are putting the focus on the brain, but we are ignoring the heart part of our core curriculum or core subject, which should not happen. So, sir, beautifully presented. You brought the concept of the heart, hands, and head, which is a cognitive domain, psychomotor domain by doing something from the hands, and affective domains of hearts. So many good things which I have learned from your presentation, and I'm sure that all our participants must be greatly benefited with your insight and valuable presentation, sir. So thank you, big thank you to you, sir. Thank you very much.
Big thank you to you, sir, as a chairperson. So valuable comment you have given, and others also understand. Because that when I am telling, it may be reaching very less, but when the chairman will tell, it will be 10 times more fast. It will reach.
Thank you,
and when
sir. Thank you so much.
When the organizer will do, then it will reach in 100 times to the participant.
Right, sir. Right.
Thank you, sir.
Thank you, sir. Thank you. Over to you, Dr. Senthil.
Yes, sir.
Thank you.
Thank you, sir. Thank you, sir, for your wonderful talk. We move on to the next session. Thank you, sir. So the next topic for the today's session is postmortem diagnosis of unusual poisons. Challenges and clues for forensic medical experts. So for this today's for today's topic, the chairperson will be Dr. Manigandan G. Sir is currently the associate professor and head in charge of Department of Forensic Medicine of Toxicology, Government Ramanathapuram Medical College, Tamil Nadu. So the speaker for this topic will be Dr. Venkatesh J, Assistant Professor, Department of Forensic Medicine and Toxicology, AIIMS Kalyani. So Dr. Venkatesh J is currently working as Assistant Professor in AIIMS Kalyani. Did his post-graduation from Jipmer Puducherry, followed by a senior residency in AIIMS New Delhi. Dr. Venkatesh J is a member in various professional bodies, has many awards and achievements to his credits. Dr. Venkatesh has been awarded as the Best Faculty Oral Presentation Award in Reformations and Advancements in Forensic Medicine and Toxicology Conference conducted by the Medical Legal Association of Puducherry. Also, the Best Resident Poster Presentation Award in Indian Association of Forensic Medicine Annual National Conference conducted at SGPGI, Lucknow. Now, without further delay, I pass on the mic to Venkatesh J. Over to you, sir.
Sir, so before going into the presentation, I thank to the organizing person to giving me the opportunity, and I will move on to the chairperson. I will share my screen now. Visible, sir?
Yes, sir. It's visible.
Can I start the presentation?
Yes, sir. You can start.
Okay. So before going into the topic, I have to thank entire AIMS Madurai team for organizing wonderful national CME, particularly to the toxicology theory to the practice, which is very limited in our medical college setup, especially with the toxicological, analytical, and clinical toxicology, especially with our department. So coming to our topic of my topic about the postmortem diagnosis of unusual poisons, especially with the challenges and the clues for the forensic medicine expert. The topic was assigned to me, and today I will be sharing my experience with these unusual poisons, which I have done in present and the past institute. I will share my experience with many cases and what are the challenges and the clues and how we are able to diagnose these unusual type of poisons. I'm going to convey through this my presentation. So coming to the introduction of the our topic about these postmortem diagnosis of unusual poison, especially with the diagnostics complexity. The postmortem poisoning diagnosis, especially with the challenging and particularly with uncommon toxins, and when the cases is present with the atypical presentation, and the forensic expert must integrate with the multiple data sources to reach accurate conclusion. So in these things, we need the multidisciplinary approach, especially if we want to diagnose. Successful diagnosis requires the careful synthesis of clinical history, scene of evidence, autopsy finding, and advanced toxicological analysis to establish the accurate cause of death in these atypical presentation of cases. In evolving trends, there will be a severe threat in developing the to restrict the legal controls and resulting in constant evolving of compound that often escape in detection in routine toxicological screening. So coming to the advancement in the newer trends of poison and drug usage, the forensic experts must continuously update their knowledge in emerging drug trends. The rapid introduction of new substances, especially with the designer drugs into the market, and significantly increases the risk of misdiagnosis in the postmortem. So it is essential to collaborate in partnership with specialized toxicology laboratories, and we can start our own analytical laboratories in our own institute, so that we can utilize in detecting and diagnosing and to report the accurate cause of death in case of postmortem. So in that, the main key challenges in postmortem toxicology, it's from the basic, we are lack of medical histories, especially with the diseases. Individual often have an incomplete and unavailable prior medical records, and it makes it very difficult to establish the baseline health status or pre-existing condition, especially with that it has been hidden by the relatives or by the uh, police person who is failing giving medical history about the usage of drugs and all those things. So that it's the main key challenges in postmortem toxicology. Apart from that, in that rapid elimination, especially with the toxins have the short half-life and are metabolized quickly, leaving a minimal detectable traces by the time of autopsy examination. Apart from that, there will be a treatment. It was given in the hospital, and later on with a month, the patient was died, and it was taken for after dying, they have taken for us for the autopsy. In that time, their detection of poisons will be very difficult. So apart from that, in these things like atypical presentation, particularly with some synthetic or designer drugs and evolving new trends in these unusual poisons may produce non-specific autopsy finding that mimic like a natural disease process or other cause of death. So we have to link with these toxicological aspect, especially with the new trends, have to keeping in mind. And in these my presentation, I have added the unusual findings of cases so that you can link with that thing. And apart from that, resource limitation, especially with the thing with insufficient access to the forensic science laboratory, already they are burdened with many cases. So their delay in processing of the samples that leads to a missing out of getting an accurate diagnosis of a postmortem toxicological thing, and it restricts the diagnostic accuracy. So coming to these things, whenever we are going for the postmortem examination, we have a diagnostic clues, especially with the external examination. If that's why the autopsy room should be odorless. So through that olfactory evidences, like if we are getting kerosene or garlicky smell in case of organophosphorus poisoning or phosphide poisoning, and bitter almond, particularly with a strong suggestive of cyanide poisoning, these distinct odor when detected should prompt the specific toxicological testing and grade should get the autopsy examination protocol. So coming to the clues, especially with the internal organs, especially with the GI tract, with the corrosive injury pattern, mucosal ulceration, hemorrhagic lesion, and inflammation, it's all suggestive of corrosive acid ingestion. And especially with the hepatic changes like cirrhosis of liver indicates the chronic alcoholism, or hepatotoxic drugs, which, for example, it is a zinc phosphide or aluminum phosphide. These will causes the fulminant hepatic failure. So that based upon the examination, we can give the clues for the internal finding to diagnose the exact, not exact, we can guess it is a clue for that diagnosing that poisons. So apart from that, edema, congestion in the lung may indicate that the respiratory depression, inhalant toxicity, or aspiration. Especially in these thing, pulmonary edema will be the non-specific cause of death. In these particular, with that underlying cause of death with the poisoning, it will become a specific to that for giving a cause of death in these type of cases. And cerebral evidences like brain edema, congestion, or hemorrhage can result from the neurotoxic substances or metabolic disturbances. Also, we can give some clues for diagnosing these things. So, specific organ changes with the unusual contents, especially with the swollen kidney, especially in poisoning of deep fish, and ethylene glycol poisoning associated with the calcium oxalate crystal deposition in the renal tubule, contracted bladder, especially with the datura or atropine poisoning that results from the urinary retention and the muscle spasm, dark brown blood, especially in aniline poisoning due to methemoglobin formation. These are the things, specific findings we can able to judge that what kind of poison it is. Apart from that, the gastric content examination, the presence of unusual stomach content provide the direct evidence of toxic ingestion, especially with the undigested tablets or capsule when the case comes fresh direct to the broadhead, and it will be so these mandatory have to check the gastric content, especially for any undigested tablets or capsule. Fragmented plant materials, especially if they are consuming the plant poisons, chemical residues, or powder. Unusual colorations of gastric contents. All suspicion must be carefully collected and documented, and a photograph should be taken and preserved for the viscera for the comprehensive laboratory analysis. So coming to that, apart from these autopsy clues, we have to look after for the circumstantial evidence and the scene investigation, particularly with the investigative agencies. In these things, I want to say about the drug paraphernalia. In these syringe, needles, tourniquet, spoons, lighter, and other injection equipment found at the scene indicate the intravenous drug abuse, and the suggestive that specific toxicological testing protocols. So it is very important we have to do the consider the circumstantial evidences, and particularly with the prescription bottles like empty or partially filled medication containers, or empty blisters of tablets, or chemical containers like household cleaners, pesticides, or laboratory reagent discovered at the scene of crime. These all will give the clue for the main directed detailed toxicological screening and significant improving the accuracy of postmortem toxicology diagnosis in forensic practice. So coming to the mortality due to toxicity, so it is linked to the fatality. So we must know about the fatal dose, the amount of drug or substance that kill the 50% of test population, and the minimal fatal dose, that the smallest dose that have been recorded as fatal to healthy adult persons. So these represents the lower threshold of lethality and guide the clinical management. And the fatal period, the time interval in which the person dies and after receiving the fatal dose. So these varies significantly based on the routine exposure, toxin, and individual factors. Why I am telling these fatal dose and minimal fatal dose and fatal period and all those things are there in currently in India. In most of the places they are doing qualitative method of detection of a poisoning, whether it is present or not, positive or negative. They are currently in very limited, especially with the blood alcohol concentration. We are getting the qualitative analysis. So it is mandatory if we want to give that drugs overdose, we need that qualitative analysis. So coming to the toxicokinetics and toxicodynamics of that poison and the toxins, what is the difference in the sense what the poison does to the toxin? That is a toxicokinetics and toxicodynamics, what the toxin does to the body. So if you take the kinetics, absorption, distribution, metabolism, and excretion. So if we take, it will be linked with the autopsy. If we are conducting the absorption, if the drug is getting absorbed in the blood routes or inhalation, dermal or injection, we have to consider that part for the visceral examination. For example, with the multiple injection marks, we can take the skins for sending the visceral examination. Absorption, especially it will be absorbed throughout the body tissues, especially with the stomach and its content intestines, we can consider. And the metabolism, especially it is more commonly occur in the liver, and we have to take the liver for the viscera. And the excretion, it is eliminated through the kidney in the urine. So we have to consider these all the base level of viscera we are sending routinely for the toxicological analysis, but it may varies different to different poisons, particularly with the asphyxiants and all those things. I have to consider that type of organs for that toxicological analytical testing. So coming to the three compartment model of toxin distribution, we have a three compartment: water, fat, and bone compartment. We have to consider for water compartment that we will considering ethanol and methanol will be rapidly distributed throughout the body water and quick onset of toxic effects. And if in case of fat compartment, the lipophilic substance accumulate in the adipose tissue, particularly with organophosphorus poisoning and organofluorines, and prolonged retention and slow relief and extended elimination of life. And compare with the bone component with the chronic metallic ion poisoning like lead, arsenic, and this thing, very long retention time useful for chronic exposure assessment in these type of cases. So coming to the forensic sampling and analysis, the proper specimen collection, preservation, and analysis are the critical for the accurate toxicological diagnosis, especially with each poison types requires the specific handling sample integrity and ensure that reliable results. So here I want to show that specimen preservation guidance by various poisons type like corrosives. The ideal preservative we are using for the corrosive is a rectified spirit and organophosphorus, and most commonly we are using is sodium chloride. We are using for that, and the blood for sodium fluoride are using. These are the base level. Most of the stomach, liver, kidney, and small intestine, at most the 30 centimeter we are sending along with the control samples. So these are the baselines. It will be varying to various poisons. For example, if it is a carbon monoxide poisoning, we have to take the blood in that liquid paraffin to prevent that highly volatile gas to escape. So want to detect that thing. So accordingly, the preservatives and the visceral preservation may change, especially with the CNS toxicities. The brain samples have been preserved and sent it for the toxicological analysis. So coming to that forensic approaches to the poison and drug detection, the preliminary screening with the rapid immunoassay calorimetric testing for initial detection of drugs, and the confirmatory analysis with the GCMS, gas chromatography with the mass spectrometry, and liquid chromatography with the tandem mass spectrometry, and quantitative assessment is a precise measurement of toxin concentration in various biological matrices. Coming to that integration, the clinical correlation and the determination of cause of death is based on the analytical finding only. So coming to the case study, today I am going to discuss about the carbon monoxide poisoning with the case presentation. A 50-year-old male become unresponsive in the bathroom at his residence. The family members discovered him unconscious state, immediately transferred to the emergency department where he was declared broad dead. So in these initial investigation, everything ruled out no natural disease, and sudden unexplained nature of death prompted medical legal autopsy and a comprehensive toxicological investigation was done in this case. So in this case, we have found that after opening that body with PML, we are getting that cherry red color lividity, and opening with that all the visceral organs showing a cherry red color. If you see that after opening the calvarial part, the cherry red discoloration of blood have been noted in the skull, that implies that clue for the diagnosing these carbon monoxide poisoning. So after this, we have given that the cherry red discoloration, it is more common in carbon monoxide poisoning. We have given the clue for the investigating officer to inspect the bathroom. So they have taken that photo of these gas geyser. It is a main purpose of this thing is it will be giving an instant hot waters to the family person, and it is more economically friendly also. It was installed in that bathroom, and the entire bathroom was not ventilated at all. So if you see on the walls with the smoke, everything, it is dealing with that incomplete combustion of gas, especially with the LPG, that emitting the carbon monoxide inside the bathroom, that due to that accumulation in the bathroom carbon monoxide, he was inhaled and he was unconscious. So we all know that it is a colorless and odorless toxic gas. So due to that improper ventilation, the person was uh, fainted in the bathroom itself. So we have done the screening test for that carbon monoxide poisoning, especially with the Kunkel test, that is addition of tannic acid solution to the blood sample, that shows that cherry color discoloration. So that will confirm that presence of carboxyhemoglobin in the so if it is a normal, it turns brown or dark when the tannic acid is added. So in these key findings, we have found that cherry red discoloration and confirm the presence of carbon monoxide and the carboxyhemoglobin in these things. These we have added in these vial for the preservation. So next thing is we have to do the quantitative analysis. In these thing, in the quantitative analysis is conducted with a UV double beam spectrometry. In these, it confirms that more than 50% of carboxyhemoglobin saturation in the blood sample. That confirms that the person is died due to the carbon monoxide inhalation. And the main clinical significance in these cases, it's above 50% are typically filtered, and normal carboxyhemoglobin is less than 2% in non-smoker, and typically with the 5 to 10% in smokers. And the symptoms, especially the loss of consciousness, will occur when the carboxyhemoglobin is more than 40%. So coming to the gas geyser syndrome is a preventable cause of accidental carbon monoxide poisoning, especially in the domestic settings. This syndrome occurs when instant water heater are installed in poorly ventilated bathroom, leading to the accumulation of carbon monoxide gas. So this is a preventable strategy, but based upon that PML, we are came to know that this is a case of carbon monoxide poisoning. So coming to that, this all usually common in India with the snake bite. I want to say this as a thing, but in most of the places in Delhi and all the area, the snake bite is very, very rare. But in Tamil Nadu, Kerala, and in West Bengal, that snake bites are more common. So I need to cover these topic, especially with the challenges in the envenomation. So you can see on the photograph with the two wide uh, fang marks of two punctured marks with a deep thing, which also it is a bite of a Russell viper's bite. So you can, if we are seeing these fang mark along with that history of this thing and surrounding local reaction, we can judge that which would be the cause of death. But in these things, main challenging is due to the delayed presentation, or in case of any decomposition or varying clinical manifestation, that will be remain challenging in these type of cases. It's very, very difficult, especially with the identifying the as a snake bite cases. So in some external examination finding, the snake fang marks typically appeared pad punctured with variable spacing, but in case of local reaction with the cellulitis and all those local reactions, especially with the gangrenous formation, very difficult to identify the fang marks. There will be a severe local tissue damage and a hemorrhagic manifestations like bleeding from bite, site, gums, and other orifices, suggest of coagulopathy and with the hemotoxic venom component. And the neurological sign like ptosis, ophthalmoplegia, and facial weakness indicates the neurotoxic envenomation and characteristics of a cobra or crate bite. So coming to that internal autopsy finding, if we are take the particularly to the kidney, in these case the Russell viper bite, I have been showing externally with the hemorrhagic kidney. On cut section, we are finding the cortical medullary junction is well differentiated along with the congestions in the medulla. So on histopathological features of the snake venomation, it shows that the acute tubular necrosis, if we are seeing on the histopathology, there will be a features of acute tubular necrosis in the kidney and severe congestions on the, especially in the medullary region, we can appreciate in these histopathological image. So the study was conducted in Jimmer during my tenure by my colleague. He was shared this picture. I acknowledge Dr. Sadish for these things. So he has conducted the study with particularly with the endocrine organs with the pituitary, that is pituitary, adrenal, and thyroid. Pituitary and adrenal are showing that coagulative type of necrosis, that star-shaped thing you can see in these images, so that you can get that what are the impact on the endocrinal organs with the state bite. And in thyroid cases, there will be a presence of lymphocytes in that follicular area. That all in it's a atypical presentations of the snake bite, which is rarely reported in cases of snake bites. So coming to the lab diagnosis of snake innovation, advanced diagnostic technique like enzyme immunoassay for particularly identifying the snake species, venom detection kit, all those things, and coagulation studies, particularly for the diagnosis or for the treatment of the person's complete blood count along with the BT, CT, bleeding time, clotting time, prothrombin time, activated thromboplastin time, and fibrogen level, FDP, assess the coagulability severity. And the mass spectrometry will definitely identification of venom component and metabolite in the postmortem sample. even with the when decomposition is absent. So now I want to show that systematic flow for identifying the fang mark. If the fang mark is identified as two puncture wound with intervening and the exact site. If it is not identified, you can use the magnifying lens for proper zooming on the suspected and try to find the fang mark. Still not identified. Particularly, it is a older method they have given as a Bailey method. In the live cases, inject the lignocaine in the suspect area from the fang. The lignocaine can be used as out. Still, you can, in case of postmortem, by dissecting the suspected area of fang mark and search for the tunneling in the tissue, and can say that it will be judged with the fang mark. So, coming to the cause of death, the snake bite and its complication, we can give, and the complication like internal bleeding, intracranial hemorrhages, septicemia, acute tubular necrosis. In cases of hospital treated cases with well documented fang marks, but the fang mark is not found at the autopsy, still can consider the snake bite as a cause of death after perusal of treatment record, circumstantial evidences, post-mortem finding, and the histopathological finding. So here I want to show we have to give without any delay to that cause of death, particularly if we are confirming the case of a snake bite, especially in the West Bengal. They are if the person is died due to the snake bite, they have been compensated with the ex gratia fund of rupees 1 lakh, so that their beloved one will be getting benefited based upon our diagnosis. So coming to that unknown bite cases. So now we have seen the snake bite, and particularly we are getting the call for the unknown bite cases with the present with the unique diagnostic challenges in emergency and the forensic now. And the proper identification of a causative agent is essential for appropriate treatment in most of the cases, but it is very difficult, and we have to document exactly what the findings was present, and it will be documented in the OPD sheets. I want to, it is a clinical case which I got called for this emergency. A 5-year-old female child presented to the pediatric emergency with a history of unknown bite. So initially that examination revealed that a localized edema, erythema, and there is no puncture marks at the bite site, and the child was hemodynamically stable, but required careful monitoring for development of systemic symptoms and allergic. So the child was observed for 3 days of post bite, and he was managed conservatively, where they have done the BT, CT, BT, INR, and all those things are normal. And after the 3 days, the person came for the toxicological review, and you might have seen, as compared with the previous image and with this image, with the progressive resolution of local inverse inflammation, and with healing without signs of secondary inflammation and developing necrosis. So in that thing, there will be a increased of histamine activity that leads to inflammation of skin due to that unknown bites. That will be managed conservatively. So in these type of cases, we have to take the photograph documentation, especially with the unknown bite, is essential for medical legal purpose. And you can retrospective identification of biting animal irritant or topo. So this is a thing I already told, and I will move on to the another case which have been presented to the emergency department with the history of consuming an unknown substances. So the unknown substance, the person was unconscious also. That call come to us, and we are arrived to the emergency department. We have collected the urine through the urinary catheter and tested for all the narcotics and drugs. It was found that it was opioid, morphine group of drugs have been detected in these cases, and the person was treated with the coma cocktail, and the conscious revived. While he was asking, he was consumed that opioid analgesics like strip, and he was unconscious. And based upon that, the person was survived. These all the golden period have to treat the patient of diagnosing accurate poisons, especially in the emergency period. And in these thing, I want to convey in these type of cases, the poisoning cases most and foremost is reported in the emergency department. In the later state, the person is dying after treatment and all those things, the eliminations will be more. So in these type of thing, the gastric lavage, blood, urine, and maximum number of samples are preserved at the emergency medicine. And it will be when the person dies, we have to consider that report in cooperation with the postmortem, so that it will be a valuable evidence for giving a cause of death for administrating law and
ये
justice.
पत्थर क्यों रखा हुआ है कोई
So,
आगे बोले
is there any problem? Okay. So coming to the blood rapid
जाम लगा हुआ है इसका सॉल्यूशन निकालो
So in these things, blood-based multi-drug dissection cassettes are available, particularly with the blood testing. Morphine, methamphetamine, and tetrahydrocannabinoids, cocaine, and benzodiazepine. Total 10 drugs are there, especially with the MDA and amphetamine. So we can use as a rapid test. We can test and diagnosis, and we can treat the patients, or if can screen the patient with these all those drugs. So coming to the substance abuse in young adult, 18 years.
लिया है मैम इधर इधर तो नहीं लिया आपने रूम लिया है क्या हाँ एक लिया है ना इधर इधर ये अस्ट्रोला होम्स है ना ये आगे है क्या हाँ इस डायरेक्शन में
We organizers, you can mute the Vanika's iPhone. It's keep on interrupting with me, so that I will continue my presentation. So coming to that substance abuse in the young adult, in this case, the person was died in the abandoned area. The parents was searching for the 2 days, and later on the body was found in the abandoned area, and the body was shifted. And the parents are creating many issues, some murder and all those things. On examination, we have found the multiple injection marks on the dorsum of hand and the cubital fossa. So that I have collected in these image, you might have seen that collection of skin bit from the side, and there will be a granulation formation over the cubital fossa. That all implies that it's a case of chronic IV drug user. And followed that in the crime scene, they have found that broken vial of pheneramine. Along with that, syringe also recovered from that thing. This is a drug paraphernalia evidences. So in these things, we have sent the whole viscera for the toxicological analysis. In that, we have detected ethyl alcohol, pheneramine, that is antihistamine, and 2-benzyl piperazine. That is typically what is, you might have asked, what is 2-benzyl piperazine? That is a designer drugs, especially with the piperazine group of antibiotic, particularly previous past they have used for roundworm and threadworm infestation treatment, but nowadays no more in practice. So here the piperazine, it is more common in abroad, but not in India. Especially in the New Zealand countries, previously they have allowed with the age of more than 18 years. Now it has been stopped in all over the country, and it has been selling like a herbal messy peel or herbal potty peel. So it has been detected in these case, it is a synthetic designer drug. So that main thing is in these case with the interaction with the ethanol, pheneramine, and phenylpiperazine, this has a unique toxicodynamic effects to that persons. So, for example, if the ethanol intoxicant, it is an inhibitor, pheneramine, it is seen as depressant, we can say, as a sedative, and benzyl piperazine is a stimulant. It will be drastically releases the dopamine and serotonin on the brain that leads to a seizure of the person and also respiratory depression and leads to the death of these person. So many cases have been reported with especially the benzyl piperazine is ingested along with the alcohol. Their interactions and the absorption will be rapid and the effects also will be more that leads to a cause of death in this case. So in this case, we have given the cause of death as a synergetic toxicity of drugs, polydrugs involving ethanol, peneramine, and phenylbenzene piperazine. So coming to the another study was conducted in Chennai in Stanley Medical College. I'm in the part in that thing also, particularly with the sudden death cases of 10 young adults. In these cases, we have taken the autopsy finding, toxicological profile, and histological changes associated with the fatal IV drug abuse. So we have found that very prominent vein access sites, especially with antecubital vein, forearm veins, hand and wrist veins, and alternative sites like femoral jugular and subjugular veins. You might have seen in the photograph, there is a prominent veins to hide the injection mark. The persons are putting that tattoo marks over the hand. These are the thing with the prominent veins you might have seen in these photographs of 5 cases. And thickening of cubital veins and blood extravasation were noted underlying the tract. And in that foreign body granuloma is seen in the vessels underlying tract or mark in the veins. So these all the things, especially while taking into the lung parenchyma with the foreign body material with the congested vessels, it's showing in eosin hematoxylin staining. If you have seen these things are the granulomatous and a deposition of excipients. That is, excipients is nothing but usually these persons are taking a tablet. It is dissolved in the water, and that in the tablet it will be presence of talc, cellulose, starch, and microcellulose that is useful for the absorption in the GI tract. So these persons are mixing with the water and taking in the syringe and directly injected into the vein. And these all will be getting settled in the end organs like lungs. So the macrophages are identifying these as a foreign material and engulfing, and there will be a formation of a granulomatter reaction with the foreign body deposition that implies that excipient lung disease, which was diagnosed in all the 10 cases. And most commonest drug in these type of cases is involved is a tapindadol. It is a oral opioid drug being used for these type of case. And this is a new trend is started in the thing. This case also published, especially in that expedient lung diseases with a fatal outcome. And you can access through by downloading these thing. And coming to that, methanol poisoning. So in these things, I want to report as 2 case reports. In these things, 35-year-old male have consumed alcohol on the previous day, right?
Excuse me, doctor. Sorry to interrupt. We are running a bit late.
Okay.
Already now
Okay,
time
we'll
2:50.
finish. 5 minutes we'll finish. And suggested the consumption of illicit and adulterated alcohol. And the mass casualty and methanol poisoning event also occurred, especially in the holy time. All the bodies are cremated. The one person was survived and he also died on the next day. The case was done by us. And here we have preserved blood vitreous sample and CSF and urine. And gas chromatography and head space analysis was done in these cases. And in these, in blood vitreous CSF and urine in case 1 with a peak detection of ethanol and a prominent peak with the methanol also detected in these cases. And coming to the case 2, it is presence of same methanol and toxicity. So that these all the qualitative analysis with the blood, vitreous humor, urine, and the CSF. So coming to the huge tragedy, we all know that particularly with methanol poisoning, it's attributed to that 2,000 deaths attributed to the consumption of spurious thing, which are contributing factor. It's unregulated production and distribution of illicit drug, adulteration with industrial methanol to increase potency, lack of quality control. These are the things with the detection of these, especially with the advanced method like gas chromatography with the headspace with the FID flame ionization detector. So we can sure that it is died to the methanol poisoning. You can access these things. And next case is the case was present with the unidentified foreign nation, especially identified as a Nigerian origin. And the postmortem CT was find that there is something on the stomach. You might have seen some packet was found in these things which showing the radio opaque foreign body within gastrointestinal tract. So on opening, there is a presence of packets. It's confirmed that it is a cocaine of 500 grams, and these are the internal findings. And it is a very unusual thing. We are detecting these type of things, especially with the advancement technique like a virtual autopsy. So coming to that cause of death, particularly to these type of cases, acute drug overdose, intestinal obstruction, and sepsis from the leaking of a content. So these are the syndromes. I don't want to, due to the shortage of time, I will be restricting with these things. And I want to show that basic toxicology setup at our institute with the thin layer chromatography. We are doing with the gastric lavage sample was taken particularly from the emergency department. If they are requesting, we are making a control and processing the gastric lavage and making a manual silicon plates and processes for detection of a poison. If you might have seen here, there is a true pattern on that thin layer chromatographic plate. This is positive for the drugs on the TLC plate. So apart from that, we are using the urine multi-drug detection kit, especially with the patient with unconscious, with unknown substance consumption. So we are screening for that maximum 10 drugs of these things so that we can treat quickly. So coming to the conclusion, the postmortem diagnosis of unusual poisons requires the comprehensive integration of skin investigation, autopsy finding, histopathological and advanced analysis. And the forensic expert must maintain the current knowledge of emerging substances, analytical techniques, and integration of strategies to accurate the determined cause of death and serve justice. In that forensic excellence, the continuing education and training required for recent trend in these things and collaboration with the specialists, especially with the emergency and quality assurance in the laboratory and the evidence-based interpretation. So key takeaway, systematic approach to the poisoning, importance of seen evidences, multiple specimen analysis, advanced analytical methods is required to tell with the qualitative and quantitative method of analysis is required to give us a overdose. And the public health impact, the surveillance of emerging threats, prevention of strategies and policy development and community educations. It's required to prevent of drug of abuse. These are all my references. Thank you.
And thank you for our excellent presentation, Doctor.
Okay.
The history you have laid certain importance on the history of the cases, right? How we
yes.
have to take history in case, especially in poison cases, because most of the time we doesn't know where the poison is.
Yes.
Most of the time, what the relatives will tell, they won't even respond to us. What kind of poison, whether the person is already taking certain drugs regarding for the treatment or some ailment. Sometimes they will take some Ayurvedic drugs also.
Yes,
some kashayam, something like that they will take. So you have laid importance on the history of the case. Then your case studies are very excellent regarding that carbon monoxide poisoning, and also you have laid importance on the urine-based multi-drug analysis kit. How important all those kits are. And also we have to improve this thing. We have to increase awareness among the police person also
Yes, sir.
to see the crime scene, to collect the evidence along with the forensic science personnel. Thank you so much, Doctor. Your
Yes, sir.
presentation has been
Thank you,
excellent.
sir. And first
Thanks.
time you were saying, sir, I heard about you. Sir
Yeah.
also, Sindhil sir also told about you. So I will little bit delay in presentation, sir. Sorry, actually I will
No
be
issues,
elaborate.
Doctor. Your case studies are very good. Super. Your
Okay, sir.
photographs also very good.
Okay, sir. Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, Dr. Venkatesh, for your wonderful presentation. I also thank our chairperson for this session, Manigandan sir, for moderating this session. So we move on to the next scientific talk. The next talk is we go on to the next topic. The topic for this session is negative report and positive suspicions. Forensic reasoning alleged poisoning deaths. So for this session, I invite the chairperson, Dr. Murugesh Bharati sir. Sir is currently the Associate Professor of Department of Forensic Medicine and Toxicology at Indira Gandhi Medical College and Research Institute, Puducherry. We welcome you, sir, to chair this session. So, the guest speaker for this topic is Dr. Manivasagam M. Sir is the Associate Professor at the Department of Forensic Medicine, Government Mohan Kumaramangalam Hospital, Medical College and Hospital, Salem. So, Sir has a vast professional experience doing his post-graduation from Tirunelveli Medical College. Sir holds various administrative positions, notably the nodal officer for the medical legal jurisdiction for the government medical colleges in Chennai. Sir is also the member at various professional bodies. Sir has, to his credit, co-editing the Tamil Nadu Medical Legal Manual at various editions, the recent one being released this year at 2025. Sir has been a key role in the, along with the editor, Sir has played a key role in drafting this medical legal manual. Has also contributed to various textbooks, textbooks of Anil Agarwal, textbook for forensic medicine by Dr. K. Tamilmani, and a practical manual in forensic medicine. With such a vast experience, we are indeed honored to have Dr. Manivasagam sir amongst us to give his lecture on this unique topic. Over to you, sir. Manivasagam sir, you can unmute yourself and start sharing your screen.
Yeah, okay. So am I clearly audible?
Yes, you're audible.
Okay.
And your presentation.
Yes, sir, you're audible, sir.
Yeah, okay, sir. Okay. So do I have a go ahead from the chairperson? Shall I start, sir?
Yes, please, sir.
Thank you, sir. Thank you. So first, I must thank Dr. Gerard for all those kind words about me. I hope I do justice for those kind words, at least in this presentation. So these are my contents, in the presentation. So there will be 3 parts in my presentation. The first one is the introduction part. The second one, the core component that contains the negative suspicions and about the positive fallacy. And then in the end, I'll be summarizing what we were talking about the session. So the objective of this session, so all the participants would be able to overcome procedural lapses in negative chemical analysis, and you would understand how the techniques are getting changed in detecting poisons, right, in the autopsies we do, right? And more importantly, the core objective of the session, so you'll be able to frame a sound opinion, a medico-legally sound opinion, in case you encounter a negative chemical analysis report, right? So why do we bother much about the negative chemical analysis? See, there is a classification with respect to offering cause of death. There is cause of death nearing certainty. In certain cases, so we can give cause of death with absolute certainty, right? So there would be facts
Of course, there will be specific findings. Both will be there. So I'll be showing some case scenarios as well. So second thing would be where our cause of death would be probable. It is more probable. So either we would have a overwhelming fact, or we have a finding that would be some non-specific. But on the balance of overwhelming facts, our cause of death would be more probable, right? So these two categories are manageable, right? Of course, we are manageable. The third component comes, see, conjunctural. See, our cause of death, there is no possible finding or no concrete fact to arrive at a cause of death. So there we are, what to say, out of thin air, we are making an opinion. So what we call is conjunctural. So it is simply based on our assumption, we can say, scientific assumption, we can say. So that is conjunction. So that is the part where we are going to concentrate much in this presentation. And of course, the last one, we must agree that we were not able to identify cause of death in certain cases, right? Yes, it is not humanly possible to ascertain cause of death in every possible scenario, right? So we must accept our limitations. Fine. So the first example in your ways, certainty cases. See, so how often do we get negative chemical analysis report? Yes, anybody from the chat box? Yes.
Yeah, we get every time, sir. Most of the time when there is a the case is treated in hospital. So
Yes,
for
yes.
example, if it is treated for a couple of weeks or 1 week,
Yes.
when the patient is comatose for a long time and all, we
Yes.
often get this negative reports.
Yes, often. Yes, sir. Yes, often. See, if we say often, we are somewhere in the tertiary care center. Of course, most of us would be in a tertiary care center, medical colleges. So, with respect to forensic expertise working in a medical college setup, particularly in tertiary care setup, most often we would be dealing with this negative chemical analysis. So, how do we manage that, right? So, we'll see how to manage that. Okay. Yes. So these are, like I said, these are cause of deaths nearing certainty. You could see a concrete fact like stomach coloration, brick red color in cyanide or cherry carbon monoxide, cherry red color in the viscera. And of course, the viscera report will come positive as cyanide and positive for carbon monoxide. So now you have a concrete finding as well as chemical detection. Okay, case is simple, right? Nearing certainty. Case is simple, right? We'll move away. Likewise, methanol. See, methanol also, you see, we can go for a chemical reduction, yes, as well as there would be some specific findings. See, with the looming huge tragedies happening on and off, we can, to some extent, find a specific finding, that is putamen necrosis, right? In the basal ganglia region, you could even in the photograph, you could see there is a putamen necrosis or putamen hemorrhage, we can see. Those findings are attributed to be specific findings of methanol, right? Fine. And of course, OPC, the characteristic smell we perceive, and so sensitive. Most of the forensic science tests would be so sensitive to detect OPC, so we would get OPC detection also. So yes. So corrosives. Next one is corrosives. So you would have a locally corroded organ, right? And some unusual cases. You see the hair dye poisoning cases. You see the hair dye poisoning, the paraphenyl diamine compound would produce intense laryngeal edema. You could see, you could only see the edematous glottis, not a normal one. This much edema. See, usually this edema subsides. So it is so uncommon, or in postmortem examination, in routine postmortem examinations, this edema would subside, and we would be not seeing this edema in a routine way. But to our surprise, of course, Marjorie, it's a temple of surprise. To our surprise, it may be still there for us to witness it. So there would be a specific finding and as well as chemical detection, right? So these cases, as we see in our routine way. Now, the phytotoxins, the plants like oleander, the wooduvin, and then the endrin organochlorids. So they share the same aspect, like certainty. Now comes the second kind of cases we encounter with. That is, cause of death is more probable. Say, for example, there is a suicide case, of course, with alleged history of tablet consumption and attempted suicide. So in that case, we could see some crushed white pasty material in the stomach. So there is not much specific finding, but there is some pasty material. And now the chemical analysis also says detected a basic drug. See, now this is what I was saying. The cause of death is probable, and now you have to interpret what those basic drugs could mean. So those basic drugs could be a group of drugs, fine. So you have to interpret and arrive at a cause of death, right? So this is somewhat better. Okay. So now we are stepping down the ladder. Okay. So this also looks easier. Okay, fine. So now we'll go for a case scenario. See, like our Muresh Bharati sir said, see, a person would have been getting treated for 10 days or 2 weeks, right? You have a longer stay in the hospital, yes. So the case comes, so there will not be any specific finding in autopsy. So to our surprise, we have to take the viscera and send for FSL analysis, and the report also comes as negative. So how we are going to deal with this? So most of the time, we will be writing as yes, consistent with, but nobody knows how it is consistent with, right? So we'll see how to mitigate this situation, right? So first of all, we must know, why do we encounter this negative chemical analysis, right? Yes. See, there are a number of reasons listed. So to understand or to approach in a systematic way, we can say delay. We will be taking the samples now, and there is a delay in submission of sample towards the FSL, right? So that is considered to be one of the main reasons for negative chemical analysis. See, there is a report by NHRC, right? I've been listing that in the reference column. You could go to the NHRC website also to see the entire document. See, in that document, they have specifically mentioned under toxicology chapter. See, one of the most notorious reasons for negative chemical analysis is delay in submission of viscera to the FSL. Right? So they have listed within 1 day or within 5 days or within a week or within a month or within a year, how much samples are getting or reaching the FSL. So that is one of the main reasons where we lag. Okay. Then second one, the legal status. See, is there any legal status that governs that viscera shall reach the forensic science lab within that time frame, right? Yes, I'll come to that next. So next one is, viscera is either tampered, lost, or unaccounted for. See, every now and then you will encounter a police constable who comes to you and says, sir, I've lost the bottle. Or he would say, sir, I was traveling in my two-wheeler in that the viscera box you gave me, and all of a sudden I put a brake, dog ran in, so the bottle fell down, and the bottle got broken. Now I have lost, right? So tampered with or lost. Okay. Then comes inherent to the body or the treatment procedures. So the person would have got treated, so the drug would have got metabolized or neutralized and got excreted or been converted into some metabolite, right? A metabolite. See, most times the sensitive test would be picking up the parent compound. Once the drug gets metabolized, unless we design a kit that picks up the metabolites also, there is every chance that we might end up with a negative chemical analysis report from our side. Then comes the sample, inadequate sample, right? Or the wrong preservative used. Yes, okay. Is there any overcoming things that we can undertake for these reasons of negative chemical analysis just listed out? See, if there is a delay, we can, immediately hand over the viscera along with the body. So as soon as the body leaves, we have to hand over the viscera to the in charge police constable. Yes, that is one way. Yes, that will sort out most of our problems. And most of us would be like who to tie bell on the cat, no? The word attach, right? See, every now and then, if we are anticipating a chemical analysis report to be positive and that report comes as negative, on the same day we would see for some other case where we take viscera for want of needing a negative report because we have a natural death in our mind. So the postmortem finding also reflect a natural death. Just for the completion's sake, we would have been taken viscera in that case. Unfortunately, that case would come positive as viscera, right? Positive for some poison. Rather than some other case where you honestly expect poison to be there because of this finding you see or the smell you perceive, right? So what happens here, right? See, wrong sample, right? So we do not see where the viscera is being packed and all. So we'll give the work to someone subordinate to us. So they'll take the viscera to a room. So they'll pack it. So there is exchange of viscera, right? The wrong sample, right? But we can, of course, we cannot give in our opinion or accept that we are being negligent in that. So that is one of the reason that is not explicitly discussed or explicitly spoken about regarding this negative chemical analysis. The second one, how do we satisfy this legal status? You see, in Tamil Nadu, we have a specific section in medical code that says beyond 24 hours, we cannot keep a viscera, right? So there is a legal bar that prevents a medical officer from keeping the viscera beyond 24 hours, all right? So there is a law in place. So what do we do now if the policeman is not taking it up? So what do we do now? See, again, the same section extends that you have to communicate that the viscera was not taken up, right? You have to communicate to the corresponding investigating officer or one officer above, right? Yes. So that will overcome the legal hurdle. Yes. So the next one, what I'm going to tell you is, if you are being told by a police officer or a constable that they have lost the viscera, so get it recorded, right? Get it recorded and open your inability to give your opinion in that matter, right? Yes, that will, of course, I'll tell you how to frame opinion in that part, right? Then the second one, treated or metabolized. Like even the previous session by Dr. Venkatesh, he was saying gastric lavage. Yes. So where do we miss in treatment cases? So in treatment cases, the part we often miss is the gastric lavage contents or the dress material. See, in the emergency department, in the casualty, they would have been, of course, immediately the first step what they undertake is the gastric lavage, right? So the gastric lavage content, they would have been keeping it, yes? The dress material, everything would have been keeping it. So we have to coordinate or we have to somehow make the police to collect those gastric lavages, right? Or we must have an SOP in our hospital so that we keep all those gastric lavage contents or dress materials, right, in poison cases, and it has to be handed over to the police. And then sampling, see, appropriate sampling or appropriate tests, right? So the appropriate sample, in 2 slides, I'll tell you what appropriate sample this negative chemical analysis mean, okay? So then some reasons for negative chemical analysis, that is like with respect to forensic science lab, based on the test they do or lab related, the shortage in instruments facilities, or the nature of tests they undertake, or of course, see, most of the times the FSL reports will be of qualitative in nature. Either they are detected or not detected. Only for alcohol they give quantification, right? So all others they'll give only qualitative results. So those results, of course, for FSL, we don't have, we can only suggest to them that we are in need of protection kits and sample specific, like urine specific or blood specific or CSF specific kits, body fluid specific kits we are in need of. So we can make a suggestion to them, right? Okay. So we'll leave that part up. So with respect to poison, specific poisons, is there anything that we can augment, or we can go around to find reasons or explore possibilities to make it detectable? See, one thing is the organics are not detectable, yes, of course. Then decomposition also makes a poison less detectable. Okay, poisons that are proteinaceous in nature. See, the snake, we know, for example. So how can we go around or overcome this negative chemical analysis problem, right? So you can always augment with histopathological examination, right? So I'll show you how we can reduce that. One thing. So see, in treated organophosphorus poisoning is, of course, that is the most common poisoning, the agricultural poisoning, the most common poisoning in India. So in treated cases, rather than taking the same stomach or intestines, we can, prefer mesenteric fat. And of course, the muscles. See, the muscles, they mean whether it is intermediate syndrome, you have to select the muscles from the proximal area, right? Where the cranial nerve supply, the neck muscles, right? Or intercostal muscles, right? So only then we have a probability of having a positive detection, right? Yes. Or alternatively, what we can do is, see, there are numerous studies that say these organophosphorus or any poisonous compound are being notorious for causing erosion and corrosion in stomach, right? But specifically for organophosphorus compound, we can anticipate some intramural hemorrhages in GIT. So alternately, we can send mesentery and muscle sample for chemical analysis on one side, and we can preserve those intestines to look for transmural hemorrhagic areas in histopathology also. And likewise, for drug overdose or tablet overdose, to be precise. See, we have to look for the body fluids, right? The bile, the vitreous humor of body fluids. And we have to choose a part of brain where its concentration is more, right? Brainstem or cerebellum, right? Yes. And specifically, now I'll tell you one of my experience with paracetamol. There was a case of paracetamol who survived for 4 to 5 days and then he succumbed. So now the case comes for autopsy. So due to an exam commitment, I was not in the station, and I just informed them, see, don't just limit yourself with routine USRA. Rather, please take up liver and send it for histopathological examination, right? So as it happens, after 5 or 10 minutes, I get a call that, sir, how on earth we take a sample for histopathology in a poisoning case? Have you gone crazy? I said, no, it is not so. Because, specifically for paracetamol, you can anticipate a central lobular necrosis, right? Yes. Of course, the half-life of paracetamol, 1 to 2 hours, even in overdose cases, it gets excreted. The T-half lies somewhere between 4 to 6 hours. So after 5 days, you do not expect paracetamol to be present there, right? It is expected that paracetamol would not be present in chemical analysis. So in that situation, you have to augment your autopsy with the histopathological examination. And second is the second kind of poisoning, what we come across in our area is the paraquat, the paraquat. So paraquat, of course, it is known to have, pulmonary hemorrhages, There we could see pulmonary hemorrhages. Yes, of course. Only in the end stages, you might be looking for pulmonary fibrosis. Of course, in the initial stages, you could see alveolar hemorrhages or a typical feature, what we call the honeycombing of liver. Sorry, honeycombing of lung. So those things, it can easily augment our diagnosis. But to our surprise, paracute has longer excretion time. So most often for paracute cases, we may end up with a positive report also, right? So then comes the question of snake bites, the venomous snake bites. Of course, snake bites, by nature, our routine chemical analysis tests do not detect snake bite. The snake venom is not detectable, right? So we send chemical analysis. The purpose of chemical analysis in snake bite is to rule out foul play, right? Because we know that our routine tests are not going to pick up the snake venom, right? So how do we augment that also? So you either send for acute kidney injury or you look for acute tubular necrosis, right, through histopathology. And rarely, even in snake envenomation cases, you might encounter with a case of acute MI, right? So that is one of the rare complications, but yet it is still not uncommon. Rarely we often see myocardial infarction precipitated by snake bites. Also, I once had a strange case of warfarin coagulopathy triggered by snake bite. See, in that case, so even the clinical feature, there was no sign of envenomation. So there was only a history of snake bite, and the person has got the coagulopathy feature in the body, the staining, the blood extravasation and all. So in all those cases, histopathology is going to save our skin. And likewise, the heavy metals or forates, right? So they would have their manifestations in the kidney, right? So in or balloonic degeneration, okay? So it happens now. So this marking is still there. Yes. So we have seen few things about and troubleshoots about negative chemical analysis. Now, what is a positive fallacy? See, you see a positive report that so-and-so compound is detected in chemical analysis, but that is not the actual cause of it, right? So, it is not highly uncommon to see cyanide detected in burns cases. See, of course, plastic, when it is burnt, it liberates cyanide. So it is possible to see cyanide positivity in burns case. See, of course, bearing all the suspicions, right, or bearing all the foul play, it is possible, scientifically possible, to have cyanide positivity in burns case, right? Yes. And likewise, see, another common fallacy or the biggest confounder with respect to us human beings is the alcohol. Alcohol, it will be present in hanging victims or drowning victims because the statistics say hanging is 4 to 8 times more commoner in individuals under intoxication, right? Of course, drowning, if you are drunk, the chance of drowning also gets increased. But the concept is different. Alcohol is a positive finding, but it is not the cause of death, right? That is one thing. Second thing is sewer gas deaths. So even in sewer gas death, the culprit is something else, hydrogen sulfide, right, or methane. But the positive report would contain alcohol. See, just that the workers who engage in that kind of cleaning work or consuming alcohol prior to entry into the drainage system. So you would expect a positive alcohol report, a fallacy report, yes. And most often, you see, as cirrhotic person or person in a functional standard, so there would be alcohol, but not in the level to cause alcohol intoxication. So in cirrhosis and postural death, even lesser levels of alcohol would produce could produce alcohol intoxication also, or in fact, the cause of it could be postural asphyxia or even esophageal varices rupture. So that is also a positive fallacy we are commonly encountered, right? And another one of the controversial topics in our contemporary time is there a possibility a person who consumes organic vegetables could his viscera turn positive for organophosphorus compound poisoning? Yes, of course, there are a lot of articles supporting it and a lot of scientific views against it. This can be settled only with the quantification of the poison rather than what we are getting is only a qualitative result. So it will only end until the quantification is done. Yes. So let me go into framing the opinion in these cases. So pattern one, there is a specific finding with or chemical reduction. You could straight away say, yes, this is the cause of death. That the disease, where in our state we used to write the disease would appear to have died off. So that is the phrase we use, right? So there is no doubt in it. So that is, you straight away give it, right? Yes. So what happens in the cases we just talk about, right? So what I would suggest is, so in my personal experience, what I would recommend is, or what I would write in my certificate is, see the clinical course and the autopsies findings were consistent with death due to poisoning, right? So I would not say what poison it was because I would limit myself to a bigger or wider topic like death due to poisoning. And I would mention, see, the negative CE report is most likely, or the negative CE report is consistent with treatment intervention or body metabolism, right? Either you can write this way, or you can have a different phrase. Our choice of words are different. So there is an alternate phrase. What we can use is, see, treatment intervention likely reduced or eliminated detected level of poison. So the treatment intervention reduces the detectable level of poison. So chemical analysis comes negative. So these opinions you can use for highly toxic compounds. Even in low doses, it can trigger a cascade of events towards death. But the treatment intervention would reduce the level of those extremely toxic poisons to detectable levels below the detectable levels. So I would suggest, so this expression can be used as, so the level has gone below the level of detection. Yes, you can. Yes, you can. So the second example, what I have is, yes. So the second example, what we routinely follow is, for in case of drugs, see, paracetamol overdose or folate overdose, where even you don't have a augmentation with histopathology also, right? So these opinions I'm saying about, you don't have cross finding, you don't have histopathology finding, and of course you lack chemical analysis report, right? So in those cases, so how to arrive at this opinion? So earlier I was telling to you, with the help of histopathology, how we can convert a certain group of, or a major chunk of negative chemical analysis cases to have a histopathology backup, right? So if you have histopathology backup, you can go for probable cause of it or a certain cause of it, right? So even after augmenting or even after troubleshooting or going around or making all the steps correctly, even then you are having a negative chemical analysis report. So now you can always say, yes, clinical course and autopsy findings were consistent with death due to drug overdose. Specifically, you can mention, yes, there is a drug overdose. And the negative CE report is most likely, yes, more consistently with treatment intervention or body metabolism. Yes, like I was telling you, I would also suggest some other phrases. You can say treatment intervention likely alter detection, which means metabolites have come, right? Metabolites have come. So the detection methodology was altered. Yes. Or in a routine way, you can say metabolism and treatment resulting in negative analysis. Yes, you can say. See, the purpose is you are giving a cause of death and you are addressing there is a negative chemical analysis report. Now, as well as you are giving your professional opinion that in your opinion, what could be the more likely or most likely explanation for that negative chemical analysis report, right? Even after going through a meticulous autopsy and going for appropriate viscera and augmenting it with histopathology or some other test, even then you end up with a negative report. So what the reason could possibly be explained in scientific terms, right? That is the explanation we are giving in the last lines. Yes. So we have one more type of opinion. You see, snake bites, right? Of course, snake bites. Here you see, what I would prefer is, I would write consistent with death due to envenomation. Yes, of course, there is a treatment intervention. But specifically, I would add a line that, see, negative CE report is expected because of non-detectable nature of snake venom by routine chemical analysis. So I would quote in this way that I was expecting a negative chemical analysis report in this case because the routine test would not detect the snake venom, right? So now you may ask me, so why do you want to send a sample, right? So you are expecting negative report, then why do you want to send a sample, right? See, that is the same logic what we are going through, right? See, we have to rule out a foul play, and certain conditions can mimic exactly a snake bite envenomation, average, for example. So, to rule out the foul play, we are in anticipation of a negative report, send samples for chemical analysis, right? So, we can very well, in our professional rights, can say, I was expecting it, right? So, I was expecting a negative chemical analysis report. Or simply you can say it is not detectable, or you can say proteinaceous and low concentration of snake venom, hence it is not being detected in routine FSL. If you want to go soft on FSL, you can say it is proteinaceous and it is on low concentration. Yes, or let me be blunt. You can say yes, it is not detectable. Yes, with the test they are using, it is not detectable. Yes, right. So, yes. Now, one more thing. What I told you that after a few slides we will be discussing about it. So that is the slide here. See, rarely you would be in a dilemmatic position or an awkward position where the constable or the IBO says that they have lost the viscera that you have handed them with. So technically, what we should do is you could say, I cannot opine in this case because the sample has been lost, right? That is the most clear-cut way, right? Then comes, so for the communications you have made, the efforts you have taken, now the sample is reaching the FSL after a year, or after 3 months, or after 6 months, or after 2 or 3 years, the sample reaches the FSL. So now you get a negative CA. So now, how do you address this negative CA? You can very well say, you see, the negative CE report could more likely be due to delayed submission, right? It's a delayed submission by the investigating authority or delayed submission by the concern towards the forensic science lab. So how do you arrive at this opinion? See, earlier our FSL reports would be having the preamble about the case and the report. But nowadays we often see all the FSL reports. They say by what date the sample they have received. So they are already addressing this in an indirect way. FSL is indirectly addressing that we have received the sample only today. Probably you have preserved the sample and had out the sample 2 or 3 years back, but we have received only today. So there is no part of no fault on our side. This is what the FSL report itself indirectly says to us. So in those cases, we have to write in which date the autopsy was conducted, in which date the sample was handed over to the PC, and by which date the FSL received the sample. So if there is an undue delay, there is no harm in saying, see, I could not arrive at or I could not interpret this negative CE report, or the negative CE report is most likely due to a delayed submission. Yes, you can very well write in that. Yes. And this was what we were referring to, the visa was lost. And for that reason, I cannot give my opinion. So the opinion is not possible, you can say. So in the preliminary certificate, you would have said the professional opinion is consistent with poisoning. Yes, but I cannot come at an exact opinion, or my final opinion cannot be given for the reason of last viscera. So both are scientifically explainable. And the second one, where you say I cannot comment an opinion because it is a poisoning case. All I want is a non-specific finding only I have, and I rely completely on a CE report. So even in that case, we can simply say yes, I cannot arrive at an opinion just because the evidence was lost. Right? So now I cannot opinion in this case. So you can very well say that. Yes. So to summarize, I'll say not we must stick to the conventional viscera sampling techniques. Of course, you go for specific organs, right? Alternate organs. And of course, now the trend is more towards augmenting poisoning cases with histopathological techniques, right? So you choose the alternate methods that is available now. And second, the sampling lapses, we have to be at most careful to do away these sampling lapses in the container or in the technique in which we seal the containers. Even the covers, the court nowadays say simply affixing 2 seals or not enough. So you have to make threads in crossway, the Holy Cross. In that way, you have to tie the cover in a plus way, and you have to affix your sealing wax at every corner. So minimally there should be 16 seals, right? So those things are cropping up. Yes, of course. Yes. So we have to avoid that sampling lapses. Okay. Then the procedural lapses, right? Procedural lapses, like I was saying, so you have to hand over it immediately, and all the viscera should be packed in front of us. So there should not be any exchange, or there should not be any like what you say, you might be in a hurry, and FSL would not get it unless you forget to sign at one area, or you mistakenly written a date. Instead of writing 2211, you would have written 2210. So all those simple procedural lapses. So the FSL would return the sample. Once it is returned, now the police would not go back again for submitting the viscera, right? All those procedural lapses. Then, of course, you document the relevant things and record all what you seem to be relevant in your case. That is, whether the viscera was taken up or viscera was not taken up, whether you have received information that viscera was lost, everything, all those relevant findings. Yes, they are all medico-legally relevant. They are all legally relevant. So you record everything in your report. And the opinion part, just now we discussed the opinion part. So it has got 3 things. One is you have to say, yes, the cause of death by conjunctural means. If you say, so there is no specific finding or there is no chemical detection, what I would suggest is you have to have 3 components. The first component is, yes, the findings are consistent, in which you indirectly say you have ruled out fatal injuries, you have ruled out other causes of death, and according to you, now the findings are consistent with poisoning. That is the first thing you have to say. And second thing is you mention, yes, there is negative chemical analysis report, and you can venture into saying the reason for the negative chemical analysis, whether it is treatment intervention or the metabolism or the course of the drug, it was reduced to a minimal level, or for the uncommon reasons like the delayed submission, or altogether the visa has been lost. Yes. So these are the references, I was mentioning to you. So you could always go to that. Right. Yes, could always download this. It is there in the NHRC website. You can just type it. So they would say how these procedural lapses form the cornerstone, or it forms the brunt of negative reports across India. And a lot of Supreme Court judgments are there, placing importance on the Vizra reports. So this is one such judgment, recent judgment, one such judgment, 2022, where it says the acquittal or the conviction based on the delayed submission of Visera, delayed submission resulting in negative chemical analysis report. Yes, and then the journal it discusses the varied reasons for negative chemical analysis. So it is there. Okay. So other two references were with respect to the positive fallacies, how alcohol creates a fallacy that it is not the cause of death, but it will be invariably present in the chemical analysis and detection. Yes. So with that, I sincerely thank Dr. Sandil sir for giving me this opportunity, and I would also extend my warm regards and greetings to Dr. Murias Sibartha sir for chairing this session. Over to you, sir. Thank you.
Thank you, Mani sir. This presentation was really good. Actually, you covered all practical problems what we face day to day in our autopsy routine. So, like, the patient will be regularly on benzodiazepine like alprazolam or something. But whenever we send for a viscera analysis, the report comes positive for benzodiazepines, but they don't give any quantitative analysis. Only they see the presence of benzodiazepine. That will be really confusing the case.
Yes.
So then that is where we have things where we have to ask for the daily prescription, what the drugs the patient is taking on, and that will also help us to eliminate things. And to add up to one more thing, to say when we get a negative autopsy in one of a case, actually they discovered the person was using sildenafil citrate for a long time and overdose. The second day, first the report came negative. Actually, the first immediately we asked for processing. Then we send a sample of sildenafil citrate to them and ask them to see whether that particular compound is present.
Yes.
So that way we can reduce. They will also see that particular compound is present in the sample what we send. So that was a thing which is reducing. The same thing happened with acronym bromide. The sample we had sent us acronym bromide and ask them to see, because our not all labs are fully equipped. Some labs are in a very primitive state, and they see only for a very limited poison toxic analysis will be done. Now they are developing, but this is the things what we had we had to send a sample so that we got a positive report following the negative thing. Nice presentation, sir. Thank you very
Yes, sir.
much.
Yes, sir. Yes. If you may permit me, even I would like to add one such a similar case where we had homicide using vicronium. He was an anesthesia technician, so he got vicronium, right? And he injected to his girlfriend. Of course, they were in the phase of separation. So even in that case, what you are saying is, for those drugs, sir, FSL always would ask for a sample. But the practical problem is, how do we send the sample? Because are we legally authorized to send this sample? Would it not create a problem later on, a questionable thing in a court of law? That we honestly do not know, but practically we do it. We'll get a sample
Practically,
from.
sir, that I would ask the investigating officer to suggest. As the doctor suggested this thing, the investigating officer will naturally suggest the same thing to see whether they will give a separate requisition based on our our ideas.
Yes. So we would ask the IO to give a letter to the head of the institution to give a
sample of
or something for monitoring. Yes, sir. Yes. Thank you, sir.
Thank you, sir. Thank you, Sindhil and Gerald and Mukesh and team. It was a really well organized online CME or this forensic thing. Thank you, Sindhil.
Thank you, sir. Thank you, Badi sir, for your kind words. We also thank the our Mani Oscom sir for enlightening us with the practical case.
Excuse me, Dr. Sindhil, sir.
Thank you, sir.
Yeah, thank you, Dr. President. Thank you.
Thank you, sir. So now we move on to the next session. That is the last session for today. The challenges in toxicology analysis in hospital samples. Yes. So for this session, I would like to invite as chairperson Dr. Rajan S. Dr. Rajan S. is Associate Professor at the Department of Forensic Medicine at St. John's Medical College, Bangalore, Karnataka. So good afternoon and welcome, sir, to the charges session. The speaker for this topic is Mr. D. Shanmugam. Sir is the Deputy Director, retired, the Regional Forensic Science Laboratory, Virupuram, Government of Tamil Nadu. Sir has a wonderful professional experience, completing his MA in Political Administration, MPhil in Political Administration, with MSc in Forensic Sciences. Sir has held various administrative positions, and Sir's field of expertise is in crime scene investigation, excise division, and narcotics division. Sir has also served as a resource person in imparting training to various police professionals at various rankings, railway police, jail authorities, medical people, judiciary, revenue, customs, bank and insurance. So Sir has been a main resource person for educating vast spectrum of audience. Sir has, to his credit, has attended more than 10,000 crime scenes. So this is an owed to his experience and has played a pivotal role in collecting scientific evidences and detection. Sir has also received the prestigious Tamil Nadu Chief Minister Anna Medal of Excellences in Forensic Science for the year 2021. Sir has also received multiple times. There's a feather in his cap that he has received 6 times the Best Forensic Science Award from the Director General of Police, Government of Tamil Nadu. So with this brief introduction, I request our speaker, Dr. Mr. D. Shanmugam, sir, to kindly proceed from here, and sir can share his screen and proceed with his talk. Thank you, sir.
Good afternoon, sir. Are you able to hear me, sir?
Good afternoon, sir.
Yes,
Your
sir.
voice is clear.
Yes. Shall I proceed?
Yes, sir. You can please share your PowerPoint, sir, and then
Yes,
proceed.
sir. Yes, sir. Good afternoon, sir. Being a forensic expert, I want to start from some basic things about toxicology, sir.
Yes, sir.
What is toxicology? The toxicology is word derived from the Greek word toxicon, that is used to hunting the wild animals in olden period, in which the arrow was dipped in a poisonous extract. For example, aconite is one of the plant poison. They prepared crude extract of the dried leaves. From that, they dip the poisonous arrows and throw it down onto the animals. They got killed. So the word derived from toxicon. Next, Paracelsus and Matthew Orifla. They are called as the father of toxicology. Among that, Dr. P.K. Gupta is called as the father of modern toxicology in India. And another pioneer, Dr. K.S. Rao, also called as Guru of Indian toxicology. So toxicology is one of the very important discipline of forensic science. It is a science embodying the knowledge of the sources, character of properties of poisons, the symptoms they produce, the fatal effects, the lethal doses, and the remedial measures. All of the things, the study about the poison is a single line, is called toxicology. So another word. It is a study of the effects of drugs, chemicals, poisons on biological systems. What is poison? So anything is a poison and nothing is without a poison. The dosage alone decides whether it is a poison or not. In Tamil, we can say, அளவுக்கு மீறினால் அமிர்தமும் நஞ்சு. Like that, a poison may be defined as any substance administered in whatever way produce ill health, disease, or death. They may be a synthetic or mineral, animal or vegetable origin, or chemical or substance that can induce disease, damage, or death when our bodies are exposed to it. So we can define poison as like this. Now, how poison has come to our body, that is mode of administration, let us discuss. Everyone, that is called ingestion, poison ingestion it is called, not injection, ingestion. That is through mouth, injection or inhalation, or through skin or through mucous membranes when it contacts. That is divided into enteral or parenteral. Enteral means mouth or rectum. Parenteral means inhalation, injection into various body areas, subcutaneous, intramuscular, intrathecal, intravenous. So what is the role of forensic toxicology? So forensic toxicology is a hybrid of analytical chemistry. I am the specialist in analytical chemistry in chemical toxicology when I was pursuing MSc Forensic Science degree. So it is aptly you have selected me to take the CME regarding the toxicology. So I have worked in toxicology field for more than 15 years. So we receive samples from blood, urine, gastric contents, vitreous, and various tissues that includes viscera for such a poisons from many possible poisons and drugs. We are usually the specialists to handle various areas of toxicology. That is forensic toxicology or industrial toxicology, clinical toxicology, environmental toxicology. Now, we have stopped in clinical toxicology all over Tamil Nadu due to our case burden. And we have instructed the concerned medical college to send the samples to Chennai Rajiv Gandhi Medical College, General Medical College and Hospital for clinical toxicology. We are receiving samples for ascertaining the presence of any ethyl alcohol or methyl alcohol in the samples seized by the current trends. That is only we are doing drunkenness cases along with the patients admitted with the drunkenness in the hospitals. We are receiving blood and urine samples and doing clinical toxicology only attributed to this level only, not in other poison scenario. The expertise of forensic toxicology is primarily utilized in establishing the cause of death and elucidating its circumstances in post-mortem investigations. In manner of death, there is a suicidal poisoning or homicidal poisoning or accidental poisoning. So, during the autopsy, why they are doing autopsy? To know the apparent or real cause of death. It may be a murder, it may be due to accident, it may be due to some fire accident or explosives, but they have to rule out whether they are consumed poison or not. When it was useful, our report, it is if it is the case of consumption of poison. So our role is very important to rule out and also to establish the presence of poisons in the chemical reports. So the work of forensic toxicology is therefore considered as highly complicated because we are examining the tissues, blood, urine samples, after postmortem. So you think about the samples, nature of the samples. They are degradable and metabolizable and excretable, and all the changes will be happening after the death. So we have to examine the visceral organs and we have to search for the poisons. So we are using various techniques in our laboratory to detect the poisons. Let us see the famous poisoning cases in the world. You see, hemlock, that is a plant poison, Conium maculatum. That was the extract was given to the famous Greek philosopher Socrates during his execution. This is poisonous plant extraction was given to Greek philosopher Socrates. Another one, that Saint Helena is one island, the South Atlantic Ocean. In that island, the great king Napoleon Bonaparte was incarcerated during his final days. During 1821, he died due to physical illness. After conducting so many researches, they concluded that he died due to arsenic poisoning. Where it comes arsenic poison? That is the wallpaper surrounded in the room where he was incarcerated. So this was the historical. Now we come to India. Immediately killing more than 300 and 800 people, also cattle, and causing significant morbidity and premature death from many thousands more. In that, company was engaged in manufacture of sevin, that is organocarbamate insecticides. In another case, in every state is happening, in Orissa, Bihar, in Tamil Nadu. In recently, it happened in Tamil Nadu, one in Vilpuram district, 2023 and 2025, 24 and 25, 23 and 24. Marakanam hooch tragedy case, 16 persons died, and Kallakurchi hooch tragedy cases, 68 persons died. So these cases we have detected methanol poisoning. For these cases, in these cases, we have analyzed clinical samples when the patients are taking treatment in the concerned hospitals, various hospitals. Now we go to classification of poisons. From analytical point of view, the common poisons are classified in 7 main groups. Volatile poisons, that is insecticides, non-volatile organic poisons, corrosives, toxic anions, miscellaneous poisons, metallic poisons. So this category, according to the analysis, this has been categorized into 7 categories. So according to the arrival of our cases, we are taking the analytical methods. We are few examples of some organophosphorus insecticides. I don't want to go in detail about the list of poisons in the slide. Organochloro insecticides, carbamate insecticides, herbicide, pyrethroid insecticides, neonicotinoid insecticides, acidic drugs, benzodiazepines. Now other drugs, rodenticides, Likewise, so many poisons have been analyzed and reported. Now, corrosives. So in corrosives, we can see inorganic acid, sulfuric acid, that is nitric acid, hydrochloric acid, hydrofluoric acid. Alkalis like ammonia, potassium hydroxide, sodium hydroxide, ammonium carbonate, potassium carbonate, sodium carbonate, calcium hydroxide. Organic acid, in one speaker submitted biooxalate poisoning, that is phenyl poisoning, picric acid, salicylic acid, aspirin, acetic acid, tartaric acid, citric acid, like that. Now we go to plant poisons. So oleander, we know in mofusils they called aralikotai or kovalakotai. In rural areas, they consume these oleanders. And Oduan is called Oduan Tadai. They use the leaves and grinding the leaves and they take as a gravy, they died. Cannabis, you know, that is drugs of abuse now. Datura, it is used for intoxication. Death rate is very slow. That is atropine. It is admixed with arak samples for intoxication. Naxwamica, that is Datura, comes from Umatangai in Tamil. Naxwamica, that is Etikai. Abras, we know during Vinayaga Chaturthi, we can see Kundrimani. So by crushing the powder of, consuming the powder of Abras seeds, the death will happen. Next one, Chlorissa superba. Chlorissa superba, the flower of Chlorissa superba is the Tamil Nadu flower, is called Senkandal Malar. The root of Chlorissa superba is a very poisonous, in that active principles are superbine and colchicine. It is otherwise called Kartigai Kirangu or Kalapai Kirangu in rural areas. Another thing, in the girl child killing, Madar is Iruk. Next, we go for gas poisoning. In the unused wells, we can see some plants that molasses tanks, the death are happened due to carbon dioxide. In gas exhaust, AC, due to refrigerator and fire accident cases, we come across carbon monoxide poisoning. Carbon disulfide, hydrogen sulfide, we can see in sewage cases, in drainage, while cleaning the drainage, we can come across this type of gas poisoning. Sulfur dioxide in explosion cases or crackers explosion cases, it comes in a certain level. So another war cases, these are all literary purpose only. We are not receiving any casualty, that is vesicants, lung irritants, tear gases. Just for information, I am telling you. What are all the methods we are following in our laboratory? We are receiving viscera, that is, we can colloquially call silk. What it means, silk, S-I-L-K, silk. S means stomach and contents, I means intestine and contents, L means liver, K means kidney. Silk plus P is equal to viscera. What is P? That is preservative, which you are adding and sending the samples. So silk plus P is equal to viscera. In not only these 4 items, so we can add brain, spleen, or skin, or muscle, lungs, whatever it may be, according to the nature of the issue of the case and type of the poison they have injected, you can select the different body tissues and body fluids. What are all the methods, testing methods we are adapting? Now we are following these techniques as per our NABL guidelines, screening tests, color tests, spot tests, filter paper tests, and titometry, volumetric analysis, thin light chromatographic methods, instrumental methods, that is UV spectrophotometer, GCMS, and FTIR, radioimmunoassay, and if necessary metallic Pisons, will send the samples to Bombay for neutron activation analysis. Now, causes, what are the causes affecting the reduction of Pisons? That is, quantity is very important. How much they have consumed, we don't know. The type and amount of compound ingested, what type of compound, what type of poison they have taken, we don't know. Form, in which state they have taken, whether liquid state or a gaseous state or solid state, or they have combined any other chemical combination they have consumed, or mechanical combination, like they mixed with some other mechanical items. So mode of administration already we have discussed. So when empty stomach, the absorption will be very quick, very rapid. And another thing, points also we have to consider, condition of the body, that is age, allergy, genetic factors, habit, tolerance, and drug dependence, and state of health, sleep, and also intoxication. Most important point is treatment. How long he has been treated in so many hospitals. Another thing, during treatment or pre-treatment, there is any vomiting or purging, detoxification, conjugated or eliminated or gastric emptying. What are the things that we have to know? Another thing, whether they have taken co-ingestion with alcohol or food. Another thing, what is the time lapsed between ingestion and death? Now, what are all the main reasons for perfect results obtaining in from the forensic lab? If you delay, there will be no use, because the tissue samples, it is degradable. It will automatically, putrefaction starts, and all the organs is deteriorated. So we can't able to determine the nature of poison itself. It lost its reduction limit of the poison. Another thing, the nature of preservative, the medical officers are choosing. Most of the visceral samples should be preserved in the saturated saline. And you have to also send the sample of preservative along with the viscera as a control. Because if the preservative bottle itself contains any poison, it will be contaminated with the other organs. So we are requesting preservative bottle as one of the sample. Formalin should not be used at any cost for preserving viscera while forwarding for poison examination, because it interferes the chemical reactions. We can use formalin where? When you are establishing a museum or exhibition or preserving any human or animal or cattle or bird organs in the bottles or preserved, you can use formalin. It will be, we can see at any time. So for chemical examination, never use formalin. In gaseous poisoning, the preferred sample is blood and lung samples. That should be preserved in liquid paraffin. Liquid paraffin should be poured above the layer of the viscera. That should be kept in mind in gaseous poisoning cases. While forwarding blood and urine samples for alcohol estimation in drunkenness cases, blood samples should be preserved in sodium fluoride, that is 10 milligram per ml. sodium citrate or potassium oxalate or EDTA tube because they are anticoagulants. They should be used for blood and urine samples. Blood samples only. Urine samples, we don't need any preservative. You can send as it is. In acid cases, the viscera should be preserved in rectified spirit because it will be soluble in other hydrochloric acid means it is having chloride ion. If you preserve in a saline bottle, it is also having sodium chloride, so it will react. So that's why they are suggesting in acid cases it should be preserved in rectified spirit. Maximum 200 grams of viscera immersed in 200 ml of saturated saline should be forwarded for toxicology analysis. I mean for all the visceral samples. Total 200 grams is enough. Another thing, the viscera bottle should have the label compulsorily. It is a mandatory procedure. What are all the things to be given in the label affixed on the bottle, as well as you are providing the label along with the CMF Form 66. That is name of the deceased as per the Aadhaar card. Please compare the age, name, spelling with the Aadhaar card. You request the IO to bring the Aadhaar card of the deceased person because they are getting welfare measures from the government of various agencies. So they are insurance companies. They are expecting correct spelling for their visceral report. That's why now we are insisting some hospitals are following. They are attaching the copy of the Aadhaar card also. It confirms the actual age because during the giving the complaint to the IO, the complainant may be the blood relative or the accompanying persons or acquaintances, whatever it may be, they will give some approximate age. இவ்வளவுதான் வயசாகுது அப்படின்னு ஓவரலா சொல்லிட்டு போயிடுவாங்க. ஸோ we have to confirm through Aadhaar card. Sex should be mentioned, name of the specimen sent, and PM number and date, crime number and name of the police station. Sign of the medical officer is compulsory. All the details should be in the label. You can manually write or you can type the left hand side and fill the input through pen and paste the label on all the sample bottles, and you give the sample label along with the CMF form while forwarding viscera. Okay. Now, the name of the medical officer who has conducted PM should be clearly written in the appropriate column. In second page of the CMF form 66, there is a specific column, name of the medical officer who has conducted autopsy. We are seeing in many forms it is unfilled. In another cases, we are getting CMF form without filling the form, only they are putting a sign on the fourth page of the bottom of the fourth page. Otherwise, we don't require any fulfillment, but you have to fill the mandatorily the name of the deceased, age, sex, and the constable through whom you are dispatching these viscera samples to the laboratory. These are all the very minimum basic things. These won't affect the analysis. You just got the point. Sending very large quantities of samples in containers with inadequate preservative. We are seeing, we see some crystal sodium chloride salts at the bottom. Only visceral samples are dominating the container. So it is inadequate preservative. And we have to pour some saturated saline water also. So you preserve, you take crystalline sodium chloride and add some water. Then you put the viscera. You insect this procedure to the mortuary attendants because they are only, you are selecting the visceral organs for preservation, but the preservation and the sample preparation are done by the, practically I have seen in many hospitals, they are done by the mortuary attendants or assistants or technicians, whatever it may be. In sometimes They paste the stomach label in the brain label in the intestine label in liver sample. Like that, they are interchanging the label. Another thing, they are pasting the label in the reverse form also. We have to see the label in yoga form. You just think of our difficulty in the laboratory. If you tilt the viscera bottle, it will definitely open and the viscera will get destroyed. Just for fun, I am telling you this. These are all we are encountering in our routine toxicology examination. What happening, I am telling. Copy of each label affixed on the bottle should be attached to CM form, that is Civil Medical Form 66. So please enclose the form to corroborate whether the label pasted on the sample bottle is tallied with the form attached with the label attached to the form. That's why we are requesting the sample label. The viscera bottle should be sealed without any leakage. Sometimes they are not tightly closed. Due to putrefaction, while bringing by the police, they don't have any lid in that bottle. They tell during the travel in the bus itself, it goes in the air, sir. It vedichupochi, sir. Like that they are telling. So don't fill the visceral bottles. Give some headspace. And you can also tape, bandage tapes you can use for sealing the bottles. Even though you close the bottle with the lid, the plastic lid or water glass lid, whatever it may be, you cover with the tape, and again you put the seal on the bottle. That is sealing wax seal. But after that, in the CMF form, the facsimile impression of the seal also should be affixed in the appropriate column that's allotted in the form. That's a Swiss seal. Why we are insisting this? We have to compare. The chain of custody should be maintained at any cost. You are sending the sample, you are sealing the sample, you are sending the facsimile impression of the sample. We are comparing before opening the bottle. We are comparing the facsimile impression and the seal, and also the seal on the samples. That's why. So we have to in court when we go for evidence, they are not asking about the subject. They are asking these filthy things. Whether seal, they have medical officer affixed any seal. They have mentioned the constable name. Whether it is a correct age, what is the preservative they are. They only like that silly question they are asking. So now we are taking all the visceras, photographs, and we are enclosing in our case sheets while going to court evidence, because we have to prove ourselves that how it was received during the reception itself. So to avoid returning of the samples back to hospitals, please please request your staff to follow these mandatory procedures for better receiving in the forensic science laboratories. Again, another thing, better you have to attach the postmortem certificate while forwarding the visceral samples. You need not fill the CMF form. So you just enclose the postmortem certificate. It will give idea about how we have to plan our strategy to search for our poison detection. So whatever it may be, you observe what the patient says, what the relative says, what the containers they bring, whatever it may be, you please give all the information to the forensic lab authorities so that we can go for such a poison directly, because poison is a ocean. Umpty number of poisons are there. So we have to narrow down our analysis. And time is also consumed. Time consumption also, we can reduce the time consumption also. So for the purpose also, detailed information of the PM appearance, especially finding related to stomach, intestine, and their contents, changes in the mucosa, any specific color, any specific odor, any foreign material. That means if in granular poison, you can observe in carbofuran, furan, you can see some violet color granules. If you observe in porate poisoning, you can see some black color or brown color granules in that. So like that, if you find any kerosene odor, you can mention. So we can go for analysis in that wise. Another thing, in last speakers, they are telling about we are not giving quantitative report. We are analyzing only qualitative report. Now, as per NABL, our guidelines given, sophisticated instruments are provided by the government, and we are imperative to give quantitative results. In case of drugs and another alcohol already we are giving. Drugs, it is very useful to you. Regarding pesticides and other plant poisons, they are expecting only qualitative only. That's why we are giving. If particularly you are specifying quantitative, you please ask your question. Specifically, we want quantitative estimation of the poison detected. Please give it in a report. We be obliged. So the nature of the poison suspected, like that, you can mention in the question itself. Another thing, after handovering the viscera, we are giving one receipt. We have received 4 sealed or 5 sealed glass bottles through these police constables, and we are issuing the receipt to the medical officer who has conducted autopsy only. Now we came to learn that receipts are not reaching the concerned. They are keeping by the police in their case diary itself. When we are coming to court, they are showing the original viscera deposition receipt. So please, hereafter, so to maintain the chain of custody, even postmortem constable, viscera handing-over constable is also required to depose or testify before the court of law. So, if compulsory as a expert evidence, every doctor and forensic expert has to depose evidence before the court of law, whether it's a virtual or through in physical mode, whatever it may be. At that time, we have to show all the documents to them. So please insist the police constable or insist the IO to bring back the original copy of the receipt for which the viscera was handed over. So you accept, you attach the receipt in your case sheet when you are coming to the court. As I am telling as a request, and all those should be followed mandatorily. Next, what are all the documents should be enclosed while sending the viscera samples to forensic lab? A requisition letter from the medical officer, that is CMF Form 66. That is very well known to you. It is the form you are requesting us from medical officer, so-and-so medical college, so-and-so, to the deputy director or director forensic science lab, whatever it may be. And the PM notes in CMF Form 66 should be forwarded along with the viscera with all columns duly filled. The copy of the PM certificate should be attached if available. In some subdivisional hospitals, they are not preparing PM certificate on the day itself. As Manivasakam sir told in an earlier class, within 24 hours, they should hand over the viscera, but nobody can hand over the viscera except medical colleges. You please find this. So you can circulate to the IOs or you can circulate to the superintendent of police to take the viscera on the day itself. In situ, you have to dispatch the viscera after postmortem on the day itself. And day after tomorrow, they have to come to the forensic lab. Likewise, you have to sync with the police officers and the mortuary assistants while dispatching the visceral samples to the forensic lab, so that we can avoid time lapse between the visceral sample received and taken for analysis. Now, time has been assigned to give viscera report within 15 days. You just note down it. This is the time assigned to us to take time for viscera report, only 15 days. This is whenever I have worked, I have followed it. Now all itself, now officers are asking me, sir, after your retirement, no report is coming to in time-bound manner. So strictly I am following. I won't keep any pending. I will dispose the cases within 15 days. I will straight away dispatch the viscera reports directly through registered ports. We won't give in the hand and through police because they will last. They will tell lie. They will ask for copy, but we won't give. We are preparing only one copy for medical officer, and we are not. If court insisted, we will give the copy of the report. Otherwise, we won't get the copy. We don't have the copy also. In the file, we have the short signed copy, countersigned copy, only manuscript only available in our laboratory records.
Sir, sorry to interrupt, sir.
Please tell me.
We are exceeding time, sir. Sir.
No. I am.
Yes, sir. Yes, sir.
I am the ending, sir. I will finish up, sir. With I want to show some pictures, sir. With that pictures, I will finish it up, sir. Shall I continue, sir?
Yes,
Are
sir.
you able to hear, sir?
Yes, sir. Please proceed, sir.
Please give me, sir. Give me some more time, sir.
Okay, sir. Thank you, sir.
I have interesting cases, sir. Please, sir.
Yes, sir. You can continue, sir.
Okay.
Yes.
If you are willing, I can continue, sir.
Sure, sir. You can continue, sir.
Yes, sir. Yes. Okay. If available, please attach PM certificate. While forwarding blood and urine samples, please attach drunkenness certificate also. The police come and admit in the hospital for drunkenness cases. You AR copy or whatever it may be, please enclose. If custodial death case like Satangulam, like that cases, the requisition should be from the judicial magistrate. That is mandatory. Their court is expecting. They are also asking copy of the report. Please ask in murder cases also. Even though you are sending directly viscera from medical college to FSL, after that you ask them to bring the requisition to send to the forensic lab. In requisition from the RDO or sub-collector should be forwarded in that is RDO cases, that is below 7 years to the female cases, like on E-Road, that lady cases, you know, dowry death cases. And the copy of the history of the case and FIR should be attached. Please ensure that circumstances of death and details of drugs thought to be implicated, post-medical history, including current or recent prescription medication, should be furnished. We are enclosing acknowledgement card for, suppose we are dispatching 20 reports to you. We mentioned 20 numbers, our toxicology number in that acknowledgement card. Please sign in that acknowledgement card and return back. And also we are end user feedback form given by the NABL authorities. So please fill up the form about our quality. Please give your opinion, feedback. Now we will straight away go to some cases I have personally attended. Now this one of the important point I have to say, name of the sample, how much we have to collect, what is the preservative to be added. Stomach, entire stomach you please send saturated saline. Contents of stomach up to 100 gram saturated saline. Small intestine 30 centimeter length saturated saline. Small intestine contents up to 100 gram, and liver 50 to 100 gram. Bile for opium or paracetamol cases, entire gallbladder saturated saline. Kidney, 1/2 of each kidney saturated saline. Blood, if available, peripheral blood or femoral blood, if the patient is live or dead, if it is taken. If other samples are not available, 20 ml you preserve in sodium chloride, as I said earlier. Urine 20 ml, no preservative. Skin, injection site or snake bite cases, 2 4 centimeter radius saturated saline. That is for we are giving negative report only. We don't have any kit, special kit for snake bite cases. So we are giving a nil report only because it is neurotoxins. Their poisons are, they are unable to detect in routine visceral examinations. Just as Sir said in earlier topic, for government of Tamil Nadu snake bite poison cases, they are giving 1 lakh rupees the compensation to the victims, deceased persons' families. So that's why they are asking collectorate. They are asking forensic report.
Sir, sir, a humble request, sir. If you could shift to the images, main images, it would be helpful, sir.
Okay, sir. Okay, sir.
Over to the session, sir. Thank you.
Okay, sir. Okay, thank you, sir. So this is the case attended by me. He has left a few months before from his house. They thought that he has gone to Bangalore for his work, but in Bangalore also he has not been reached. So after that, the skeletonized body was found with the clothing were found intact. Now I have visited the SOC and collected all the samples. So no any external injuries could be made out. Only things what are the poisons consumed and other matters, and where he bought the poison also it is possible. Which poison was also he purchased also we used to find out. This case also found dead. It is in a putrefied state, and we have detected poison case. You see, is another case. We found skeletonized in a scattered state in a forest, clothings and scattered few bones we found. Along with we found a poison container. So it's identified later and confirmed the cause of death is a poisonous. Another symptoms we have seen in the lice and flies are found dead in the insects were found dead in the body itself. That is the one of the symptoms we observe in poison cases. This you can see only few bones. After 6 months, when new SP joined, this case was come to a discussion during crime meeting. The still person is missing. They have gone to the court for to search up the person. So the SP asked me to go and visit the SOC of his native place. In that their field in eucalyptus grew, I found the skeletonized bones and lungi with cloth. Another with that poison packet sachet, granular poison. So we have concluded that brother of the deceased person told that lungi was belonged to that person. We have identified the person also, and carbofuran we have detected in the remaining organs. This case is looking like a accident case. It's a simulated SA accident case. You can see multiple cause of death in that. Ligature marks, we can see the below the mandible. So he was strangulated. But in living position, one cannot strangulate easily while traveling in the car. For that, they are giving alprazolam in the masa bottle. After consuming masa bottle, he fainted. Then he was strangulated and his body was thrown out like side of the road and simulated as a road accident. This was, we have given evidence and the case was given life conviction. This you can see 2 children, boy children and 1 parent. Earlier, the parent tried to give dye, hair dye mixed with water and along with the guava fruit, they have given to the deceased child. But it will take time to make a cause of death. He strangulated both the boys in Chavos with her wife. He committed hanging by suicide. We have detected dye to certain level. You can see in the SOC, we have found the body like that, and we have collected. We don't find any poison, but poisonous container we don't find. but we found the PET bottle and the disposable tumbler. From that, we have deducted and gave a report. Since it is a 194 BNSS case, it's a poisonous case, I am telling you. This is one of the interesting case. They are the business people at a Coimbatore, over debt, over burnt up debt. They have lost everything. Though they want to commit suicide, they are choosing the Udupuram Lodge and check in the room and purchased various type of poisons and admixed with Bonto cool drinks and consumed. Father, mother, and two daughters. Father and one of the daughter died. Mother and one more daughter are saved. This you can see. This is Casuarina groves. This one aged person was found dead. Disease was identified, but the cause of death they didn't know. But I visited the SOC and found the poisonous container in his packet, dryer packet. So you can see the dead insects also in that. This the self-explanatory crimes in photo. The man found at the sports ground. You can see carbofuran. You can see the another co-food items. So it is a carbofuran poisoning case. I attended case. You can see this case. This is an interesting case. This man is the husband of one wife. The girl, the lady is the wife of another man. They have illicit intimacy. They don't they don't want to live to face the village people and the family members. They are consuming poison. Initially, the deceased were not known. I myself visited the SOC and collected 2 monocotopus poisons and massa bottles, and also collected the polythene bag and which also identified the place of that is place Chetupattu, like we have identified the deceased person also. So this is the clear case of pesticide cases. See, you can see here also you can see this poisonous case. We have seen the poisonous container and tumbler. So this also you can see. This is the below of the rock, bottom of the rock, one body was found. So after removing the skeletonized body, no disturbance were found made. All the belongings were found intact. No external injuries were found. But on examination of the bottom of the rock, hillock rock, we have collected poisonous container and cool drinks bottle and etc. So you can see this the chocolate is there and another poisonous container is there. So mixed with the cool drinks, she consumed poison, no external injuries. Now you can see this is a case of homicidal poisoning. First, the fellow is purchasing on hen, injecting the poison to the hen. He is watching whether what is the action of the hen. Hen immediately died. The hen photo is second photo.
Sir, sorry to interrupt, sir. So
Yes,
we are
sir.
running short of time, sir. Like,
Yes, sir. So I am
please
going
note
to end, sir.
Fine, sir.
End,
Okay,
sir.
sir.
This is the last case, sir.
Sure, sir. Okay, sir.
Last case, sir. So you can see the SP also smelling the poisonous. It feels as a pleasant odor, like monocotops. Two types we are having. This one person is in passport size photo is the one accused. He planned to kill all the 4 persons, but he refused to take the monocotopas mixed with that alcohol imapals. Like MGR, he used to throw in wash basin. Other he gave to all the 4 persons. So they died, and he was arrested. He was convicted, life convicted. With this, I want to finish my. Sorry for taking so much time. Little bit of. Thank you for giving me opportunity in the online class. A special thanks to HOD Sindhil sir and Mukesh sir and Gerard sir, and all the participants and all the speakers. Thank you. Thank you.
Thank you, sir, for a
Thank you, sir.
wonderful
That was
Thank you, sir.
presentation and cases, sir. Now over to Rajan, sir, for his comments.
Yes, sir. Yes, sir. Yes.
yes, sir. Thank you, sir. It was a full, interesting and wonderful presentation. And good, like you started from the origin of the word toxin and poison. And that later, like you highlighted on what the medical officers has to the points to be followed to send the samples to the lab. Good, sir. And also you highlighted on giving the quantitative results on drugs. So
Yes,
that was
sir,
wonderful, sir, from FSL, like you're giving quantitative things.
Yes,
Sir, I have one question, sir. It's not as a question, one suggestion, like from you to us.
Please,
Like
sir.
as you told, like you're burdened with all medical legal cases, autopsy cases for the toxicology. Now in hospitals, like most of the colleges, you are starting with toxicology labs.
Yes,
So
sir.
what is your suggestion on how we go about like testing this clinical samples?
Sir, for clinical samples, we can start in the every hospital, sir. We need infrastructure and necessary funds, sir. I can give you suggestions, sir. So very screening tests and spot tests, some filter paper test we can made in the hospital level, sir. Or mini toxicology lab we can start, sir. It is possible, sir. Also, government also issued a GO to start analysis clinical toxicology in every hospital, sir. Like after methanol incident, they instructed all the hospitals to conduct test in your itself, sir. So it is possible, then, sir.
Okay, sir. So in continue, we are doing some of our tests in our institution also, and many people are doing it. The challenges what we face is like usually we have the samples as either urine sample or the gastric level sample. So this is the one we are running.
For living persons, sir.
Yes, sir.
Blood samples, gastric lavage, gastric contents, vomited
But
matter.
extraction becomes difficult from the blood and all, sir.
Yes, sir. Yes, sir.
Yes, sir. So
for cyanide also, cyanide we can detect immediately, sir. Just filter paper level itself we can detect. Some more poisons only we need some extraction and thin layer chromatography like that, sir.
Okay, sir. So for
most
color
of the
test,
points
can we use the urine samples directly, or it's better?
No, sir.
Extract
No,
urine
sir.
and then go for color test.
No. We have to take extracting.
We have to extract and then
extract and then add.
Better to extract and do it.
Extraction is very possible by using separating funnels, sir. We can use and put some solvent. We can take acid extract or ethyl alkali extract. We can take it and evaporate in the portable water bath, and we can continue the examination in the hospital itself. It is possible only. It is possible, sir.
Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you.
Thank you, sir. Now I request.
And thank you for the. Yes, sir. Go on, sir.
Yes. Now we are moving on to the much anticipated panel discussion. I request our speaker Shanmugam, sir, to kindly stay online to join the other speakers for the panel discussion. Now I pass on the mic to the moderator for the panel session, Dr. Mukesh. Over to you, Dr. Mukesh. Thank you.
Yeah. Sir, good evening, sir. Good evening to all the speakers and the chat persons, and we are thankful for a very wonderful session with the enriched knowledge. And it is a very good, clear redefinition of all the concepts what you have already learned. However, there are certain questions from the audience which we have collected, and I have reframed certain questions accordingly, sir. So we will discuss like in a Q&A session and also like in a panel discussion. Let me go with the first session, the question to Professor Dr. Krishnadat Chavali. With respect to the clinical forensic toxicology advancing today's practice towards global excellence. Certain PGs were asking, so how are we going to build a globally competent toxicology training programs, which includes the passed out candidates from MD forensic medicine, to integrate the clinical, forensic, and technological innovation under a unified framework. Is there any other guidelines which you're supposed to follow? Is there any proposed guidelines from abroad countries which we can refer to put ourselves on the right track?
It's a big question. It's a great question. I don't think there are any guidelines. I'm not aware of them if they are. I think clinical toxicology and forensic toxicology integration happens only in India or in this part of the world. We don't have such integration in other parts. So, if you are thinking of upgrading, the only way is to practice. The only way is to work. We have been given an opportunity to include toxicology and clinical aspects into our curriculum. We have this opportunity. So it is, I think it is best that we take that opportunity with both our hands and make the best use of it, because that sort of opportunity won't be available. Clinical toxicology in other parts of the country of the world are part of either emergency medicine or general medicine. So they are not part of forensic medicine. So in this direction, we started this course of DM in medical and forensic toxicology, where we are integrating both. We are producing people. I think 3 of them are here already. So we are producing people who are confident in both the clinical management of poisoning patients as well as their medico-legal aspects. So both integration happens this way.
Okay, sir.
As of now, that I think that is the only solution. In future, when we have more people, we might come out with more guidelines.
Guidelines. Sir, since part of this question also corresponds to the second topic, that is current trends in acute poisoning management, I would like to put the same question to Dr. Narendranath Jana, sir. Sir, I hope you have heard the question. Once again, I'll repeat, sir. With respect to integration of clinical, forensic, and technological aspects under a unified framework, do you suggest any other thing you want to add to any of the proposals which has been given by sir or experience which was shared by sir? 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 Dr. Jana, sir? It's not there. Okay, I think sir is not accessible. And with... okay, sir. I mean, my second question goes to Manivasagam, sir. Dr. Manivasagam, sir. Sir, are you online, sir?
Sir, yes, please continue. I'm listening.
Yes, sir. Yes, sir. Actually, people have asked what are the reforms you suggest to minimize the high impact consequences of incorrect assumptions arising from negative toxicology reports. So, like whatever we are facing, I mean, whichever is happening continuously on different occasions, to reduce that incorrect assumptions arising from negative toxicology reports, what are the other strategies which we can follow, like very minimal strategies or anything?
Sir, to begin with, like I pointed out, sir, is the audio correct?
Yes, sir, I can receive.
Echoing.
I can receive. Yes, sir. Yes.
Sir, most of the negative chemical analysis reports, like I pointed you in those references, were due to the visceras were not taken up by the police towards the FSL.
Okay, sir.
See, that inordinate delay was given as the primary reason, rather than the tests being inadequate or inappropriate tests being done at the FSLs or not.
Fine, sir.
So the very first step we must undertake is we must ensure that visceras are taken care of by the in charge PC, and it is taken at as early as the body leaves.
Okay,
and second thing is, sir, we also face a practical issue that even if you hand over the viscera immediately, here FSLs, they have a working time that up to 4 o'clock or 5 o'clock in the evening they'll receive the samples. Beyond that, they won't receive.
Yes, sir. Yes.
And furthermore, on holidays they don't
Okay.
receive viscera samples.
Sir, sorry to interrupt, sir. I am Shanmugam, sir. Sorry
Yes,
to
sir, please.
interrupt, sir.
Sir,
Sir, there is no time barrier to receive after 4 o'clock, sir. This is the law, sir. Up to 5:45, you can hand over, the police can hand over the samples to the forensic lab, sir.
sir, okay, sir. Fine, sir. Fine, sir. Fine.
So you can request the officers. Tell me what is the time of receiving up samples in a day. You can ask the person, sir. So they won't deny, sir. They should not deny, sir.
5:45.
5:45 up to 5:45, the sample should be received.
Okay, sir. Fine, sir. Over to Manivasan,
So,
sir, again. Yes, sir.
Yes, sir.
Yeah, thank you, sir. Thank you for clarification, sir. And if you may magnanimously tell us, sir, what would happen for the holidays, sir?
The
We are
holidays
facing a big
yes, sir.
headache
Yes,
for those
sir.
holidays.
Yes, sir. Holidays it is compulsory, sir. It is every Saturday, Sunday, or any government holiday. It is a holiday, sir. So at the time, I am helpless in that, sir.
Yes, sir. Yes, sir. See, sir, practically, like I quoted you, our medical code says we should not hold a viscera for more than 24
Yes, sir.
hours.
Yes.
But
They know.
yes, sir. Autopsies are carried on all days. We don't have a holiday.
Yes, sir. Yes, sir.
Yes.
You are
Suppose
conducting
if I do,
autopsy
yes.
Friday evening. After 5:45, the office will be closed, sir. You
Yes,
have
sir.
to wait.
Yes.
You have to wait for Monday, sir. So that is unavoidable, sir. I am
Sir,
sorry to say that, sir.
Fine, sir. Sir,
Yes,
just
sir.
1 minute,
Are
sir.
are we not in conflict with sir?
Yes, sir.
Yes,
Just a
sir. I
minute,
am
sir.
conflicted.
Oh,
Yes, I am conflicted, but
fine,
no other way, sir. No other way.
Sir, Professor Dr. Chavali wants to interfere, sir. Just excuse me, please.
Yes, sir. Yes, please proceed, sir.
Sir.
Yeah, thank you, Mukesh. Thank you.
Yes, sir.
As far as this question is concerned, I just wanted to add that toxicology testing is not an emergency.
Okay.
So I think keeping it at 24-hour time frame for receiving is not required.
Okay.
What can be done is that those viscera that are collected should be properly preserved and they should be stored in a refrigerator, preferably in a refrigerator, before they can be handed over. So that can be done. The problem is that people start accumulating them in the departments first and then in the police stations. And then we have cases where viscera have been sent to the FSL 2 years after we had handover. Here in Raipur, we hand over immediately after the case. The police took that viscera to the FSL after 2 years.
Okay.
So that problem at the police level also is there.
Fine, sir.
So even if suppose we assume that the FSL receives viscera all 24 hours, how can you handle this? Police bringing viscera after 2 years.
Okay, sir. Fine, sir. That's good, sir. Sir, my next question goes to Dr. Senthil Kumaran, sir, who has taken the session of diagnostic imaging of toxicological importance. Sir, are you available, sir? Hello, sir. Sir?
Available, sir. Available.
Sir? Yes, sir. Yes, sir. I'm sorry. I'm not seeing you on screen. Fine, sir. Sir, with respect to your experience, I wanted to know about the utility of available resources of radio diagnosis in diagnosing cases in poisoning cases, mainly by diagnosing the poisoning cases in primary and secondary healthcare centers. How have you been associated with them? What are the referrals you have got already in your practice? And you just wanted to share, we want you to share your experiences with respect to the poisoning cases, which is attended in secondary healthcare centers, which is referred to you all now. Utility of radio diagnosis.
Secondary town only, sir. Secondary level only.
Yes, sir.
In my lecture, if you carefully see, majority of them we insist on test X-ray, which is easily and freely available. The reason why we are insisting on test X-ray is, not test X-ray, radiography. 24/7 it is easily available. No specialization is needed. So immediately we can check. Only in complex cases or neurological symptoms is involved, then we need it. That too, it is not mandatory that immediately it is needed. The first priority is always resuscitation, taking care of airway or breathing, circulation, and then organ-specific support.
Okay.
Later comes, in a completion, we come for the imaging. So
Okay, sir.
imaging is not mandatory. Here the best is resuscitation. Imaging will give to narrow down our differential diagnosis.
Okay.
As I told you in two cases, where the family members found he was totally conscious, well oriented, went for the bed, woke up with an altered sensorium, then later turned to be carbon monoxide poisoning.
Okay, sir.
That helped me with the MRI.
Okay,
So
sir.
only few cases where we need a special diagnostic like MRI or CT, sir.
Okay.
Majority of time it will settle with X-ray.
Okay.
So it can be easily practiced.
Okay, sir. Okay. So my next question goes to Dr. Venkatesh J, who has taken the session of postmortem diagnosis of unusual poisons. Um, in cases where both autopsy and chemical analysis fail to give clarity, you have already done a lot of projects, sir. So we are already aware of it. So any other advanced investigative reasoning strategies should help us in opinion framing or opinion writing, which you would like to add mainly with respect to obscure or unclarified state of an autopsy. I mean output of an autopsy. Advanced investigative
Yes, sir.
reasoning strategies which should guide in final opinion writing.
It's very good question you have asked because we are rely on mainly on the autopsy and analytical toxicology. So here one thing is most of the cases mainly we are very lack of resources basically. The most of the hospital we doesn't have even a base level setup also. It's always it is end up with either negative or obscure we can say. Negative we can say when it is a histopathological or any other techniques if we are using still it is positive, then we can go for negative autopsy. In these thing is main thing for getting obscure is in many of the medical institute are not having a base level toxicological screening. So if it is there, we can get more positive results if we are correlating with the history of the patient, with the basic color test, colorimetric test, and all those things. By screening them, we will be able to say. But one more challenge is there. If we are reporting in the medical college, is it's valid in the court of law, or that will be a debatable thing, but in each institute we should have a forensic science qualified person to conduct all those tests, basic tests, colorimetric, and even TLC also we can run to confirm these type of poisons. So one thing, and advanced techniques we can go with the histopathological, forensic histopathological, along with forensic virtual autopsy with the extraordinary findings. So as recent advances in the forensic medicine, we can go with that thing also.
Fine, sir. That
My
was a very
opinion. Thank you,
beautiful suggestion which you have given. Actually, we should be into that. And there was one more question from the audience. If you mentioned about this multi-drug kit, what is the usual
Yes,
cost
sir.
which you I mean, do you feel the cost effectiveness of the kits, and also what is the cost
It
of
will
that?
be coming. Yes, yes. It will be come in a package only. One pack it's contain 25 kits. Per kit around 200 price we brought.
Okay. Fine, sir. Fine.
200. So one box is entire is 5,000. So
5,000.
like that, 6 drugs detection, 10 drug detection, like that is there. For 10 drug detection, around 350 per kit is coming.
Okay, sir. Okay, sir. Professor Dr. Chavali wanted to add something. Sir, can you please?
Yes.
Yes, Mukesh. I just
Yes,
wanted
sir.
to add that I agree with Dr. Venkatesh.
Yes, sir.
We are using a 12 drug kit and we're getting it for somewhere around 300 or 350 per kit. And
Okay.
like you have rightly said, 25 pack. And we also have one more thing, that is alcohol detection also. We have one kit for that.
Okay, sir.
So
Separate kits.
that we are using both regularly.
Okay, sir. Okay. Sir, how far is it the possibility of unifying the same concept all over India, like with respect, is it a cost? I mean, is it economical, sir, like to effectively implement in most of the secondary centers also easily?
Effective in the sense that if you are using it judiciously based
Okay,
on your
sir.
symptoms, see what happens is sometimes
Every day.
people come, a person who is just found unconscious is brought, and without looking for any other clinical features, you jump into testing, then it would be a waste of money.
Fine, sir.
So you have to take a proper history information about how the person was found, what are the clinical features, and whether this test is going to help you in any way or not.
Okay.
If you use it that way, I think that's a good, because it's a you don't have to wait for time. It can detect very early, almost instantaneously. So that's the advantage.
Yes, sir. So my question to Shanmugam sir now, Shanmugam sir, Mr.
Yes,
Shanmugam sir. Yes, sir. Sir, actually,
please, sir.
we got certain cases with respect to railway regulatory board where there is a discrepancy between this alcohol estimation with respect to immediate method which they are using and then sending to FSLs. We have two important questions for you. One is the discrepancies which is happening between the preliminary test which we are doing, professional test, and then when it is sent to the laboratory for confirmation, discrepancies. How are you handling that in court cases, and how is it affecting? Number one. And number two, I will ask you subsequently after this question answer.
So regarding railway cases, sir, they are payment cases. We are giving due importance and we are taking the case at once, sir.
Okay.
It immediately we are taking to a working table and we have started the analysis and we are preparing the report also, sir.
Okay, sir. Okay. With respect to
So
pilots.
yes, sir. Yes, sir. Yes. We are giving positive reports. So many cases we have given positive reports, but the collection of reports only they are taking delays there. But
Okay.
in the analytical part, we are giving more importance to that, sir.
Right, sir. Sir, with respect to
We
clinical
are following Kosalka distillation method, sir.
Kosalka test. Okay, okay, sir.
Kosalka distillation method.
Distillation.
So the methods are very reliable, sir. No doubt about it, sir.
Fine, sir. In this case, one more question, sir. With respect to clinical toxicology, we are still struggling from the hospital side. What do you want to suggest in a very short note? What do you want to suggest to the hospitals with respect to setting up a state or else having a tie-up with the FSLs, the regional tie-ups for the clinical toxicology cases? If anything is there, or what is your proposing? What is your proposal on this? I mean, having been
sir, it may this issue has to be addressed to the government, sir.
Okay.
So you get the permission. You can suggest that, sir, in collaboration with the nearest forensic lab to this medical institute. So why don't you start clinical toxicology unit in the hospital itself? So please permit us and also grant some infrastructure fund for infrastructure and necessary staff and like that, sir. It is possible only, sir.
Fine,
the issue has to be applied to the appropriate authority in an appropriate manner, sir.
Fine, sir. Understood, sir.
Definitely, it will be fruitful, sir.
Understood, sir. Sir, Professor Dr. Chavli wanted to answer.
Yes, sir.
Yes, sir.
Sir, I just wanted to say that, yes, it's not very expensive. And you can set up that lab in the, we have done that here. We had a budget of only 5 lakhs. That was, was around 10 years ago. But I think now it might have gone a little bit up, but that's all that we need. And like someone was saying, you need the mindset to start. It's not about the equipment. It's not about the people, because even a PG can do the testing. So it's not very difficult. It's only that you should have that mindset to take up that additional work. That's what, in fact, I had gone to some place for examination. They asked me, sir, what is the requirement for setting up a lab? I said, you need the correct mindset to start the work. It's not about equipment or people or anything. And FSLs, can always help us with, in fact, our FSL here in Raipur is helping us whenever technical things, when we need help, we approach them and they are very helpful to us.
Okay,
so we can take their help in that manner.
Fine, sir.
Sir, can I suggest one more thing, sir? Can I suggest
Yes, sir,
that?
please. Yes,
Sir,
please.
now National Forensic Science University has started a Chennai campus recently, sir, this year, sir. So you can approach this government of India also for the establishing of clinical toxicology. Then they will be magnanimous. They are having so many funds, sir, in the Home Ministry. They will give a permission for that, sir. In AIMS, you can easily start the clinical laboratory, sir.
Right. Sir, my one more final question to Narendranath Jana, sir, actually, Dr. Narendranath Jana, sir. Sir, with respect to clinical knowledge in the budding doctors, I'm telling about like in a state, we have to be equipping all the peoples with clinical knowledge with respect to toxicology. It may include certain aspects of medical departments also. What is your say for developing this toxidromal understandings and clinical understandings, imparting knowledge on that to including the people, doctors from forensic medicine? What is your say, sir, on this? How far you are finding the people knowledgeable with respect to the budding doctors, I mean, who are doing post graduations about toxicology, sir? You want to add on any comments on that, sir? Interest shown and Jana, sir? Okay, I think sir is not online. So I'm hereby closing the session and over to audience. If you want to ask any questions to the speakers, just for 5 minutes, you can ask questions. Any good questions, like you can you are ready to ask, but just please raise your hands. I'll open it up and unmute.
Sir, can I answer for Jana?
Yes, sir. Please, sir. Yes, sir. Please. Sure.
Regarding the incorporating the toxidrome.
Yes, sir.
Very important.
Yes,
Because toxidrome, of course, we are trained and tuned to read a lot of syndromes.
Okay, sir.
Most of the time, it is not being seen in our clinical practice.
Fine, sir.
We enumerate a lot of syndromes, at least
Yes,
one or two syndromes we come across in the clinical practice. But day in day out practice, especially in a rural area where I have been working, it's an area between the hilly and rural area and in between. So we used to see a lot of patients, but most of the time, these patients were not aware that this patient has been suffering from some kind of toxicrome.
Okay.
Because the awareness among the postgraduates as well as the treating practicing doctor itself, it is not there. So unless we command this more, this will be easy for them to catch early. So we can reduce a lot of complications. Unless it comes a direct case of poisoning, we are able to manage. Otherwise, if there is any foul play or other things are there, it is very difficult for them to identify and it delays the diagnosis.
Fine, sir. That was a very beautiful answer. So thank you so much. Thank you so much. And Professor Dr. Chavali, sir, wanted to add something, sir?
No. I just agree with what that's what I also wanted to say.
Fine, sir. Fine.
Senthil has already answered on my
Fine,
behalf.
sir. Fine, sir. Thank you so much, sir. Thank you so much for joining in the panel discussion, sparing your very valuable time. Now I request Dr. Gerard Pradeep Devnath to proceed with the declaration of the results of the e-poster sessions and also further things, and let me close after the sessions. PPT, sir. படிச்சது சார் படிச்சு
So as we close this CME, we would like to share the prizes for the poster competition. So it was an overwhelming response from all the delegates. So we had multiple prize categories across various specialities for faculty, senior residents, forensic science graduates, and to encourage the postgraduate presentation, we had almost had 6 prizes at various categories. And to this, I want to add beyond around 65 presentations and a panel of expert judges, 6 judges, and this process went on for almost 2 days. And as a result of this, we are happy to announce the prize winners. So the prize winners first category of the faculty presentation, first prize goes to Dr. Karthi Vignesh Raj. Second prize goes to Dr. Venkatesh J. And the third prize is being jointly shared by Dr. Sunil Subramaniam and Dr. Pulkit Giridhar. Now moving on to the senior resident category, the first prize goes to Dr. Kirtika Ravi. Second prize goes to Dr. Rahul Kaushik. And third prize has been shared by Dr. Ramasamy Nagapan and Dr. Aravindan U. Now moving on to the forensic science graduates. First prize goes to Miss Erna Chakrabarti. Second prize goes to Miss Anishwa Masundar. And the third prize goes to Miss Jayashri Shaha. And coming on to the much awaited postgraduate category. So postgraduate category, number one, that is the research and review presentation. First prize goes to Dr. Kishore Kumar R. Second prize goes to Dr. K. Veerlakshmi. Third prize goes to Dr. Ashmia M. Verghese. And coming to the postgraduate category 2, that is a case report and case series. First prize goes to Dr. Rajasurya Verma BR. Second prize goes to Dr. Arun Kumar M. And third prize goes to Jorno CH Marak. So we are very happy to share the list of presenters. We congratulate all of them. So we would like to inform that all the presenters will receive a shield and a certificate, which will be posted to you personally through registered post. So kindly be patient. It might take 1 or 2 weeks for their shields and certificates to reach you. We will keep you updated on this further. And now, regarding the other delegates, we are happy to announce that you will be receiving your participation certificates today itself. Every instruction for downloading your participation certificate will be shared in the common group soon. We also request and encourage you to submit your feedback forms. That's the link is already been shared in the pinned in the our WhatsApp group. So please do share your feedbacks, and all of you will be receiving your certificates by the end of this day. And finally, to conclude, I pass on the mic to Dr. Mukesh.
Sir, to be again with immense
Mukesh, you are not audible. Mukesh, you are not audible.
Fine, sir. Sir, I'm very sorry, sir. So, with immense pride and gratitude, I would like to deliver the closing note. Today has been a very remarkable day of academic enrichment, insightful discussions, and professional convergence. Each session brought a very deep clinical and forensic perspectives that truly reflected the essence of our specialty. And we are honored to have an exceptional panel of distinguished speakers who enlightened us with their expertise across a spectrum of topics. Professor Dr. Krishnadath Chavali, Dr. Narendranath Jana, Dr. S. Sendil Kumaran, Professor Kusakumar Shaha, Dr. Venkatesh J, Dr. Madivasagam M, and Dr. Shanmugam D, and all the respective panelists and chairpersons. And a special appreciation to all the participants, including the faculty members and different groups from different institutions across the country. Your presence, discussions, and enthusiasm made this event truly vibrant. Thank you so much. My sincere thanks to the entire organizing team, technical coordinators, student volunteers, and supporting staffs of AIMS Madurai, whose dedication worked behind the scenes to make this event a grand success. And I would like to tell that the certificates and receipts also, the last set of receipts also will be sent in mail to you. Thank you once again to each and everyone for being a part of Forensic Convergence 1.0. Jai Hind. Thank you so much.
Thank you.
Thank you. In meeting.
Hey, convert on video.
Convert also. In meeting. In meeting.